We're going to open this up with the Kansas Department of Aging and Disabilities, targeted case management criteria, TCM differences between community mental health centers and certified community behavioral health center clinics for the intellectual and development. What?
All of these
Are written only?
Yes.
Never mind then. So our 9 o'clock is written only.
Yes.
Well, then let's go down here to the next deal. We'll open it up with KanCare individuals and providers and organizations. So Kylie Childs, Director of Governmental Affairs, Leading Age Kansas. Welcome to committee. I thought that was a long
All right. Good morning, Madam Chair and members of the committee. My name is Kylie Childs. I'm the Director of Government Affairs with Leading Age Kansas, which is the State Association of Nonprofit and other mission-driven aging services providers. And thank you for the opportunity to provide our testimony today. You should have our written testimony in front of you, and I won't go over all of the topics just due to time constraints, but wanted to bring one main priority in front of you, which is that of the rural emergency hospital model and its impact on long-term care units. So we believe the goal of this legislature has always been to keep as many long-term care beds online as possible. And with more hospitals beginning the transition from critical access hospitals to rural emergency hospitals, we thought you should know that the RH model does not currently allow for inpatient beds. So while this is a federal designation that will need to be addressed at that level, we also believe our state agency's narrow interpretation of granting physical environment waivers for these REH providers that want to keep their long-term care units licensed as adult care homes is just as much of a hindrance to that goal of keeping these beds online. So Aaron Erbel with Mercy Hospital is here today to talk about his experience, but ultimately Mercy Hospital did have to close their long-term care unit due to KDAD's interpretation of them not previously being an adult care home, despite the fact that they had been providing the same type of service in the same building for a number of years just under their hospital license. So we would respectfully request assistance from the committee to encourage the state agencies to review their interpretation and the provider's ability to qualify for these physical environment waivers so they could continue with the licensing process and we can keep these long-term care beds open and online in Kansas. The other issues that we have outlined in our testimony are streamlining provider processes for the HCBS FE waiver, survey trends and civil money penalties, and a federal minimum staffing rule update. So as you all know, our workforce shortage in healthcare, specifically aging services, are at critical levels, which is why we have to take action now to build that pipeline. And this is why we would ask for the committee's support in requesting a healthcare workforce roundtable, as the late Honorable Representative Les Mason intended to do last session, so we could cultivate a comprehensive healthcare workforce bill that aims to address this issue. So thank you for the opportunity to share our concerns, and I'm happy to stand for questions at the appropriate time.
All right, we'll go through our list and see where we come back to. Thank you. All right, next I have Aaron Herbel, Administrator, Mercy Hospital. Welcome to committee.
Good morning, Chair and the committee. My name is Aaron Herbel. I am the Administrator and CFO at Mercy Hospital in Mound Ridge, Kansas. And we are the second of what is now 3 hospitals in the state of Kansas that have converted to the new rural emergency hospital model that was just mentioned in the previous testimony. We did very much feel the support of KDHE and their staff as we made the initial transition to convert from an acute care hospital to a rural emergency hospital. But when we looked at trying to continue providing skilled nursing as is allowed under the federal law, we ran into some challenges working with the state agencies. We initially started the paperwork process in September, and we converted to operating as a rural emergency hospital in January of 2024. In February, we found out that there was going to be additional paperwork that would be needed, and it took until late May of 2024 until we were finally told that we were not going to be able to qualify for a waiver. This was following an encouragement from the Kansas Department of Aging and Disability Services to apply for a waiver, acknowledging at that point in time that we had never been licensed as an adult care home. We had previously been providing skilled nursing care services for over 50 years in our facility, a very similar type of care than what is provided in those adult care homes. This did cost our facility over $450,000 in lost reimbursement, and an annualized number of patients impacted by the closure of our facility is about 90, and our county has already lost a number of skilled nursing beds, so we were quite concerned that this had impacted. There is additional details about the timeline in my written testimony, which was provided to you. One point that I would like to mention this morning specifically to the committee is that the REH conversion is a conversion process for existing hospital facilities. New hospitals that are just being built are not eligible to apply. This is only for existing hospitals. And so for the state agencies to interpret that we must meet all new facility requirements, knowing that this conversion process is for existing facilities only, seems to me to be a very narrow interpretation. The costs estimated for our facility to meet those new facility requirements has been conservatively estimated at $2.5 million and could easily exceed $3 million. This does also affect other hospitals in the state that are interested in applying for this REH designation, which would provide them with additional federal reimbursement to keep emergency hospital services open in those communities. And it's discouraging these hospitals from transitioning to that because they're afraid that they would lose the skilled nursing services in their community. Thank you for listening to my testimony, and I do stand open for questions at the appropriate time.
All right, thank you very much. Next, I have Heather Brahm, Senior Policy Advisor, Kansas Action for Children. Welcome to committee.
Thank you, Madam Chair. Madam Chair and members of the committee, thank you for the opportunity to provide public comment today. My name is Heather Brahm, and I am the Senior Policy Advisor with Kansas Action for Children, a nonprofit advocacy organization working to make Kansas a place where every child has the opportunity to grow up healthy and thrive. We weigh in on KanCare-related issues as more than 76% of KanCare enrollees are children and their parents' caregivers. Through KanCare, the Medicaid and Children's Health Insurance Program, or CHIP, options work together to provide free or low-cost health coverage for kids, covering important time-sensitive services like doctor and dentist visits, immunizations, therapies, prescriptions, and hospital stays. These programs are a lifeline for Kansas families who aren't offered health insurance through a job for their children or can't afford health insurance on their own. These programs are designed to work together to meet children's health care needs and ensure that no one is left behind. I have two items to bring to your attention. First, as you have heard us raise numerous times in previous meetings of this committee, we ask that you again support our request to permanently fix the 16-year and counting error with the CHIP eligibility threshold, as well as aligning state law with additional changes in federal regulation. The specific details of the issue can be found in my written testimony. While the budget provisos that the legislature has passed the last 3 years have temporarily fixed this issue 1 year at a time, a permanent fix is still needed. We ask that when you make your recommendations to the 2025 legislature in October, that you include permanently fixing this issue in your recommendations, including bringing forth a bill like you did in 2023 at the beginning of the session. The second issue is regarding reimbursement rates that impact pediatric and maternity-related codes. Our written testimony includes some specifics around increasing pediatric-related codes for child-sick visits and for well-child visits for established patients that the Kansas chapter of the American Academy of Pediatrics has been pushing for. Research we cite in our written testimony shows that increased Medicaid payments made it easier for parents to find doctors for their children, including in rural areas, as more than 60% of those KanCare enrollees are children, yet account for only 23% of the spending. This request is an important step to benefit the long-term health of Kansas children. As the state finalizes a comprehensive reimbursement rate study and releases the results soon, we ask that this committee particularly elevate and scrutinize the findings on the rates for children, maternity, and postpartum care, and that rate increases be pursued where possible over the next year, including overhauling how pregnancy and maternity care is reimbursed. Thank you for the opportunity to testify, and I'll stand for questions at the appropriate time. Thank you.
All right, thank you very much. Next, I have Christina Kovacs, Chief Clinical Officer, Behavioral Health Solutions, virtual.
Good morning, Madam Chair, members of the committee. My name is Dr. Christina Kovacs. I'm a clinical psychologist and the Chief Clinical Officer and co-founder of Behavioral Health Solutions. We're a behavioral health company with a core focus on behavioral health programming and wraparound mental health services in nursing facilities. My goal today in speaking to you is to educate you on the importance and the efficacy of value-based behavioral reimbursement programs in nursing homes. BHS was established in Nevada to administrate a program, the Behaviorally Complex Care Program, and the catalyst for that program was a need to find in-state placement for behaviorally complex Medicaid recipients that were often stuck in the acute setting for inappropriate amounts of time and were not appropriate for discharge to the community, and nursing facilities were very reluctant to admit due to lack of resources to provide care and meet the needs of such patients. The BCCP provided an add-on rate of between $111 and $326 a day, depending on the frequency and degree of behaviors. Having an adequate rate and access to wraparound behavioral care and staff training gave homes the ability and confidence to admit and provide quality care to behaviorally complex patients that otherwise had nowhere to go and were on a vicious loop from the acute to the ER to the streets, temporary housing, and often back to the ER and acute settings. Now more than ever, we are seeing an immense need for value-based programs and services for this vulnerable and underserved population. There's been a significant shift in the demographics and population of nursing homes with an increase in patients with behavioral and mental health needs and disorders. Close to 80% of nursing home residents have a medically based behavioral disorder, from dementia with behaviors to psychosis, bipolar, and they require specialized services and care. And value-based behavioral programs in nursing homes allow states to provide resources to this growing population. Resources such as staff education to prepare the staff and give them the skills and confidence to care for this population, and to provide wraparound services such as psychiatric assessment, medication management, psychotherapy, peer support, psychosocial one-on-one and group activities, neuropsychological assessment, cognitive care planning, just to name a few of the services that these types of patients need. We've had the opportunity to collect data on the efficacy of the program in Nevada, which the details are in the written testimony, which demonstrate improved outcomes and cost savings to the mental health care system. A reduction in ER visits, acute transfers, and an increase in patient stabilization and the quality of life metrics, and reduction in psychotropics, with the increase in focus on non-pharmacological interventions. Due to the growing issue of appropriate placement, many states have adopted behavioral programs or are in the development phase, but there is currently no such program in Kansas, and development of value-based behavioral reimbursement program would significantly improve the quality of care and patient outcomes for behaviorally and medically complex individuals while decreasing the cost of providing that care. Thank you for your time and attention this morning, and I stand open for questions at the appropriate time. Thank you.
All right, thank you very much. Next, I have Rachel Banning, Rainbows United. Welcome to committee. Did I pronounce that name right? Okay.
Good morning. My name is Rachel Banning. I serve as the president of Rainbows United, a nonprofit in Wichita that serves over 65,000 children with exceptionalities and their families over the last 50 years. I'm also the mother of 2 children with exceptionalities, Mia, who passed away in 2013, and Dylan, who's almost 21, employed, and very close to leading a life of independence. I am here today to urge you to increase the rate for direct support providers by 3.5% and proactively establish a cost of living adjustment. Year after year, you hear the need for support of our most vulnerable populations, and acting on this request is not only the right thing to do, it ensures that when you find yourself in need of care, the quality of workforce tending to your needs or that of a loved one is adequate. Have no doubt that these workers are the most humble and compassionate humans in our workforce. The issue of adequacy is not going to be their integrity. It will likely be availability. Begging the question, if we do not take care of them now, will they be there when we need them? Or will these direct support providers be working in another sector to make enough money to live on and support a family? Caregiving is the most intimate form of compassion. It is also one of the most exhausting, and I know this firsthand. Our daughter Mia suffered from severe cerebral palsy, was nonverbal, non-ambulatory, and completely dependent on others for all of her daily living activities. Mia's schedule was rigid and included being medicated every 6 hours, and after multiple surgeries and treatments across Kansas in her young life, it took more than 7 years for my husband and I to have respite together. Piecing together the 5 direct support providers who served our daughter helped enable me to have employment outside of our household and for our household to function. They literally saved our lives. They became and still are an extension of our family. Evidence shows that direct support providers not only help combat child abuse and neglect, they also help prevent costly hospitalizations. Further, they provide companionship to otherwise isolated medically fragile children. If our legislature is compelled to tie this into an economic development issue, direct support providers allow parents like myself to remain in the workforce. Likely, until you and I are elderly and unable to take care of ourselves, we will never understand the significance of direct support providers in our daily living activities. My hope is that when that occurs, that I am able to hire and compensate at a rate worthy of my dependency and vulnerability, people who don't have to work 2 jobs just to make ends meet or bring their own struggles and worries into the space of caregiving. The rate increase of 3.5% and a regular cost of living adjustment ensures that children across Kansas' most basic needs can be met with dignity. And I thank you for your time.
Thank you. Committee, we have Edward Patton, private citizen, which is a written only. And then next we have Rick Elskamp, private citizen. There you are.
Good morning, Chairman, members of the committee. Thank you for your service and allowing me the opportunity to testify today. My name is Rick Elskamp. I'm a parent, guardian, and advocate for our daughter, adult daughter Sheridan, 23 years old, and glad to say she is on the waiver finally. Thank you, Representative Carpenter, for all your work helping us out this last session. Much appreciated. What I wanted to speak about today, I've been involved in the system ever since we were fighting to get our daughter on the waiver. I wasn't able to make it to the last meeting, but I watched the live stream and was really surprised. And as I'm sure all you on this committee was, when we found out about AmeriGroup and their past of owing the state thousands and up to over 14 million in unpaid claims. As also a taxpayer in the state, that concerns me. I wanted to just make sure that is at the forefront and is taken care of. I did get a chance to read some of the testimony online this morning, and it looks like they have settled over 8 million in unpaid claims, but still leaves quite a bit unpaid, and I'm not for sure on all the details, but I just really surprised that the state would consider continuing to do business with a company that has stiffed us of that much money. That certainly wouldn't happen in my household. It shouldn't happen in this house. So my other opinion or comment is I feel the MCO should be audited on an annual basis to ensure that funds are spent correctly. Also feel there should be a state auditor office that is an elected position who is responsible to the people of Kansas, ensuring that public funds such as these are spent according to how they are allocated. But other than that, that's really all I had to say. Thank you.
Thank you very much. Next, I have Hal Oberholzer, is that correct, with Business Development Manager, Maxim Healthcare Services. Is that correct?
Yes, thank you.
All right.
Good morning, Chair Landwehr and Committee. My name is Hal Oberholzer, and I'm the Senior Business Development Manager for Maxim Healthcare Services over the entire state of Kansas. Maxim is a provider of specialized medical care, which is extended hourly nursing utilizing LPNs and RNs in the homes to Kansas's most medically complex population. We provide these services through Kansas's home and community-based waivers. Maxim has 3 asks today for the committee. The first, increase the specialized medical care rate to $60 per hour. The second, reimburse providers for overtime. And the third is create a provider payment to transition patients from hospital to home. First is the increase of $60 per hour reimbursement rate. The legislature has given increases the past few years. However, they have been partially funded, and it has not given us a sufficient rate to provide this service without the use of single case agreements. With the focus of KanCare 3.0 on outcomes, we need a rate to compete with other healthcare settings and other states. Second is to reimburse providers for overtime, or employees who work over 40 hours. KDADS attempted to use ARPA funds last session, but CMS informed us ARPA funds could not be used for direct worker payments, so we asked this program is looked at using state general funds. This would allow the current nursing population to impact this program at a much greater level. This is the quickest, most efficient, and effective way to increase care to this patient population. Third is to create a transition from hospital to home payment to providers that eliminate delayed discharges and unnecessary hospitalizations. These three asks are vital for the program and this patient population to receive the care they desperately need. The most desired and cost-effective setting to provide care to this patient population is in the home. These programs have a cost to them, but the cost savings to the entire healthcare ecosystem is staggering. At almost $12,000 per day in the NICU and PICU, anything that can reduce delayed or unnecessary hospital stays should be attempted. We are at the point that the state, MCOs, and almost all stakeholders are using data to determine quality outcomes. Maxim believes these are the first steps needed to create universal data sets that allow all providers to be evaluated using the same metrics. Thank you for your time, and I'll stand for questions at the appropriate time.
All right, thank you. Next, we have Michael Quinn, President and Chief Executive Officer, Autism Support Now, LLC. Welcome to committee.
Madam Chair, committee members, good morning. My name is Dr. Michael Quinn, President and CEO of Autism Support Now. I appreciate the opportunity to be here this morning to provide testimony. My testimony pertains to the Autism Task Team, which was established in 2021 by KDADS, the Kansas Department for Aging and Disability Services. I will begin by commending the state of Kansas for increasing the reimbursement rate for applied behavior analysis treatment, which was a recommendation of the task team itself. As a result of this policy change, many providers, including my organization, are now incentivized to provide further treatment provisions across the state of Kansas for children and families impacted by autism. As stated in 2021, KDADS formed the Autism Task Team, a state-based initiative designed to develop recommendations to improve the lives of children, adolescents, adults impacted by autism. To achieve this directive, the task team strategically engaged a cohort of professionals across different institutions, but most importantly, included the voice of individuals with autism in the conversation. While a great deal of progress has been made, there remains more work to be done. We now need to take an important next step on behalf of the many Kansans touched by autism to resurrect the task team. By doing so, we can engage new and existing stakeholders in conversations designed to enhance lives today and accelerate a spectrum of solutions for tomorrow. Autism is a developmental disability that can cause significant social, communication, and behavioral challenges. Applied behavior analysis, also known as ABA, is a scientifically supported model of treatment to remediate the functional impairments typically found in the autism population. While approaches for autism treatment may vary, ABA is the most common treatment due to the abundant evidence of efficacy, according to the American Academy of Pediatrics. In the US, according to the latest available data, autism is the fastest growing developmental disability, impacting 1 in every 36 children and 1 in every 45 adults. Consequently, the rise in autism prevalence has highlighted the need for the continuation of state-based initiatives to continue to develop new and existing policies that impact the autism community. I'm so grateful to have met and talked to so many constituents in Kansas that support the autism community. In conclusion, I'm requesting that this committee direct KDADS to reconstitute the Autism Task Team to implement recommendations going forward. Thank you for this opportunity to provide testimony. I'm happy to address any questions or comments at the appropriate time.
All right, thank you very much, Michael. Next, I have Sean Gatewood, KanCare Advocates Network. Different hat today.
Different hat every day, Madam Chair.
I won't go there.
Well, thank you for having me to committee. Appreciate the opportunity to testify. And the first thing I want to do is to thank the folks at KDHE and KDADS, both secretaries, at KDAD's continuing their stakeholder engagement to their budget process, and for KDHE to initiate theirs. That opportunity is kind of new to me in my years of doing this, and I appreciate it. My testimony today is largely a repeat of what I submitted to both of those agencies, and so we sort of want everybody to kind of be on the same page. Most of what I have to say is non-controversial. I think we have broad agreement on ending wait lists, reducing wait lists, and even rate parity. I think there's members of this committee that expressed some interest in that. We just fundamentally don't see a difference between providing identical services among the different waiver services, the different populations. And so sort of building the capacity across the waivers is more of our goal. That's all in my written testimony. I do want to talk a little bit about autism. That is something that in my years of doing this, I really haven't seen a whole lot of progress. As mentioned before, the rate increase that happened recently was a very good thing, but we still are years out in evaluations when kids are diagnosed. There was recently an article I want to bring your attention to that pointed out that quite a few children in the state of Kansas get placed in state custody because their mental health needs or the severity of their disabilities beyond the parents' ability to care for the child. That I believe to be something that we should probably be tracking. I think that would be a great thing to have in our spreadsheet that this committee tracks, from time to time. This is something, as far as autism goes, that the state gets a lot of return on its investment because it's throughout the lifespan that the child will be, at an increase in their productivity and in their just general well-being in their life. So I think it's something that we've easily gets missed. Ever since I've been doing this, we serve about 10% of the kids that have applied on the autism waiver. So that is to say, right now we have about 60 kids being served, while there's 600 that are waiting. And we really haven't made a dent in that over the years. So to be able to track some of these things a little bit more closely, I think would be great for this committee. And that way we can kind of make an effort. So thank you so much.
Thank you, Sean. Next, we have Libby Hastings, Communications and Public Relations Coordinator, Kansas Advocates for Better Care. Welcome to committee.
Hi, good morning. Good morning, Madam Chair and members of the committee. My name is Libby Hastings, and I'm the Communication and Public Relations Coordinator for Kansas Advocates for Better Care, a nonprofit organization dedicated to improving the quality of long-term care for older Kansans, both in their home and in residential care settings. We are here today to discuss the success of our new resource, the Douglas County Senior Resource Directory, made possible through a grant from the Douglas County Community Foundation, and to ask your support of the Senior Care Task Force recommendation to reinstate the Explore Your Options Resource Guide. Our Senior Resource Directory has been tremendously successful in Douglas County. Through this effort, we have witnessed a significant need in the older adult community for a physical resource guide that offers guidance and support regarding the services and resources available to aging Kansans. In the final report of the Kansas Senior Task Force to the 2023 Kansas Legislature, a key recommendation was for KDADs to reinstate the Explore Your Options Resource Guide. The recommendation also encourages KDADs to work in collaboration with the AAAs to gather resource information for the 11 planning and service areas served by the AAAs. And if the Explore Your Options Guide was published online, we also strongly believe that a physical copy is essential based on our experience with our Douglas County Senior Resource Directory. The resource has made a substantial difference in connecting older adults to the services they need, and we believe that a reinstated Explore Your Options Guide would have a similar impact statewide. While the Johnson County AAA, Central Plains AAA, and now Douglas County have found a way to bring an Explore Your Options type resource guide available to our residents, most counties across the state may not have the resources and capacity to produce a similar product without state assistance. We respectfully ask this committee to encourage and support KDADs in bringing back the Explore Your Options Guide. The need is clear, and its return would provide invaluable support to older Kansans and their families. Thank you for your time and consideration, and I'm here to stand for questions at the appropriate time.
All right, thank you. Next, we have Amy Campbell, Kansas Association of Centers for Independent Living. Welcome to committee, Amy.
Good morning. Today I'm visiting with you about the Centers for Independent Living in the state of Kansas. I'm standing in for Audrey Schrimmer. The Centers for Independent Living want to thank you all for your support for additional funds for the grants that they operate under. These grants flow through DCF, but they impact work that the centers can do across multiple agencies. Centers for Independent Living serve any Kansan with a disability, whether they are on a waiver or not, and we've been working with the secretary to expand the role of the centers to do some outreach for folks who are on the PD waiver to help to get those folks linked to services that exist within their communities. The Centers for Independent Living provide these unique services across the state. They are assigned to every county in the state of Kansas. Page 2 shows who your Center for Independent Living is, and we highly encourage you to reach out to them and to get to know them and the services they provide so that you can link your constituents with them when you run into folks who have those kinds of specialized needs. What the centers do is to help people live independently in their own homes, which is, of course, the ideal for folks with disabilities in most circumstances. One issue we'd like for you to keep in the forefront is the issue of rate parity. There are multiple Medicaid waivers that provide similar services at different rates. This creates an issue in providing services for folks with disabilities when a direct services worker might work for an individual on the frail and elderly waiver, providing housekeeping services at the hourly rate of $14.65, then travel to someone's home who is under the IDD waiver and get paid $15.60. As you can imagine, that worker then says, I only want to work for people who are on the IDD waiver. And so that continues to be an issue. We hope you will consider that in the upcoming year. And with that, I would be happy to answer anyone's questions. My contact information is at the bottom. Thank you,
Amy. Next, we have Mary McBain, private citizen. Welcome to committee, Mary.
Hello. Thank you, Madam Chair, and the rest of the committee. I'm so happy to be here. And thanks for reading the testimony and for listening to me today. I have to take a deep breath and sigh, because once again, we're faced with finding a new MCO, connecting with and educating a new care coordinator, developing a new plan of care, and hopefully maintaining our current providers if they are available through our new MCO. So my son, who has a severe TBI with chronic, complex conditions, can remain safe and healthy in his own home and not in an institution. We have Aetna as our current MCO. And the first year was a little bumpy with the pandemic and their ability to find the providers and care coordinators. We did go through about 4 care coordinators before locating a stable care coordinator. They stepped up to the plate, listened to us, read my participant interest inventory that I wrote for my son, and came up with a special case agreement so that he could receive the 24/7 care that he needed from a stable workforce. And so it's troubling that their contract has not been renewed. The purpose of my testimony is to encourage Kansas to adopt a 5-year time frame for managed care organization contracts. As of 2024, 19 out of 39 states have a 5-year cycle for renewing MCO contracts for Medicaid. The longer renewal period allows for stability and continuity in managed care programs. The short 3-year time frame prevents issues with continuity, especially for those with chronic conditions who qualify for one of the waivers. Think about it. I was a CPA for many years in Kansas and worked with lots of small businesses. To get a business going, get the organization established, takes time. You do that in the first year. The second year, you maybe get some stability. The third year, the MCO's fighting for their contract. Why not cushion that with a couple more years so that they can really prove to you, and to us that they can do their job? So I would encourage you to work with KDHE to see if we can extend that contract timeframe. Thank you.
Thank you, Mary. Next, we have Tanya Dorf-Bruner, Executive Director, Oral Health Kansas. Welcome to committee.
Good morning, Madam Chair. Thank you. It's a pleasure to be with you this morning. Again, my name is Tanya Dorf-Bruner. I'm the Executive Director at Oral Health Kansas, and we are the state's oral health consumer advocacy organization. I want to start by just thanking you all to say we appreciate the legislature's investment in the Medicaid dental program over the last few years, particularly the $4.8 million you all invested in this year for preventative care for people, for adults. We're grateful. That's going to make a massive difference for an awful lot of people, and so thank you for that. We've got two budget requests. Both of them don't have a dollar amount yet, but I just want to preview that this is what we're going to be asking, kind of echo what Sean Gatewood said earlier, that we're really grateful to KDHE for having opened a stakeholder budget input process this year. So I did share this with KDHE as well. First of all, in 2023 was the first year that there were dental benefits available for adults. And in that year, just over 7,500 adults were able to access care. That's incredible. Those 7,500 people, that changed their lives forever. That was incredible. The thing is, there's tens of thousands that are not getting care yet. So we need to make more progress. And you hear this over and over from every stakeholder system. Low rates are one of the biggest issues and one of the biggest barriers to providers being Medicaid providers. So we're going to be talking about a rate increase. There's two reasons I want to cite just briefly. First of all, in 2022, the state of Missouri increased their Medicaid dental rates basically from the rates we are right now to the commercial level. I mean, that's something no other state has done. But what no other state has done also is see the dramatic increase that they've had in the Medicaid dental providers. They've had, I didn't look it up, so I shouldn't say it, but over 150 new dental providers in the first year of that rate increase. So it's tremendous. One of the other things to point out is FQHCs are seeing a disproportionately larger number of people who are served by Medicaid. And some of them are even getting to the point that they are not accepting new patients. And that's just, that means really there's only one way to go to be able to increase the dental provider network, and that is to increase to get more private practices to be Medicaid providers. So we're going to be asking for the legislature to increase the Medicaid dental rates to the commercial level, to the rates in Missouri. We're excited about the rate study that this agency is doing and hopeful that we'll have a good number. They know that we're interested in this and we'll be the first in line to advocate. The other thing, and I'll make it brief, is there's a hospital code called GO330 that we're a big fan of. It's a code, well, this is a preview for the sedation interim committee, sedation interim committee in October. This code reimburses hospitals for their facility for sedation dental care. It was implemented just a year ago. It was set at the Medicare federal rate, which was $1,722. That rate has now increased to $3,087. Utilization is very low of that. We understand that the $1,722 sounds high to me, but that's it's not quite enough to incentivize hospitals to really open those OR spaces for sedation dental cases. So we're going to be asking for that rate to increase as well from $1,722 to $3,087. And so I hear the buzzer, and I just want to thank you. And again, we'll talk more about that at the interim committee here in a couple of months, and look forward to any questions you may have. Thanks.
Thank you, Tanya. Next, we have Colin Olnick, Legislative Liaison, Self-Advocate Coalition of Kansas. Virtual?
I'm here.
Oh, you're here. There you are.
Okay.
Welcome back.
Thank you. All right, so today I am speaking before you about the new community support waiver. Now, when I was writing this, I did say make sure there's adequate funding, and then I remembered it was just capped off at $20,000. So I'm going to talk about the other thing. The other thing is the supported employment component of that. We just want to ensure that the definitions that are in that component are flexible enough for the purposes of billing. We have there is the state of New York who has its supported employment rate at $90, yet they have not been able to move the needle on that because the definitions are so narrow and so rigid. So what we would ask for is definitions which allow providers to bill and support both employer and employee as well, because the employer needs support to help the employee. And so that is what we're talking about, and we just want to make sure that there's appropriate flexibility in those definitions. Thank you for your time. I'll stand for questions.
All right, thank you very much. I appreciate it. Next, we have Mark Schulte, Legislative Co-Chair, Kansas Adult Care Executive Associations, virtual. Are you there, Mark?
I am. Madam
All
Chair and members
Yep.
of the committee, thank you for allowing me to participate in this meeting today, and thank you, Representative Landwehr and all committee members, for the continued engagement you have demonstrated with providers, beneficiaries, and families whose lives are touched by senior care, senior services, and senior living. My name is Mark Schulte, and I'm a board member of the Kansas Adult Care Executives Association. KACE is a professional association for licensed adult care administrators and assisted living operators. My written testimony has been submitted, and today I would like to focus on 3 items. First of those being a thank you. Long-term care providers in Kansas are grateful for the fully rebased Medicaid rates and for the Medicaid add-on for the fiscal year 2025 for nursing facilities. As we move forward, continuing rising costs will necessitate this continued support to serve aging Kansans. Second issue I'd like to address is Medicaid application processing continues to be a challenge for long-term care providers, as process time most often exceeds 45 days. In all cases, this delays payments to long-term care providers, and in the worst case scenario, could potentially delay admissions for seniors who need to be admitted to long-term care providers. Finally, I'd like to talk about an issue that was of great discussion. The Kansas Adult Care Administrators Association held its annual convention last week. There were more than 200 adult care executives from Kansas that were in attendance at the event. One of the most concerning topics discussed at the event was the impact of the new CMS staffing requirements for long-term care providers. Many long-term care communities in Kansas, particularly those in rural areas, will not be able to meet those staffing requirements. There just simply aren't enough nurses. The worst case scenario for providers who cannot meet the staffing requirement will be closing their doors, which will affect many rural Kansans without long-term care providers being there at all. An alternative outcome is for long-term care facilities to switch their license designation from a long-term care to a residential care facility designation, which is a state licensed only designation. If providers are forced to become residential care facilities to continue to stay in business and provide in rural Kansas communities, the impact on Medicaid and HCBS will be significant. For those Kansans who rely on Medicaid to pay long-term care, they will have to switch to home and community-based services waiver to get services paid for in a residential care facility. The concerns that this raises are threefold. Question 1, can the infrastructure for HCBS accommodate an influx of HCBS applicants? Will care be rationed because HCBS service have waiting lists due to the higher demand? And finally, will the HCBS plans of care provide sufficient units to safely provide care under HCBS guidelines? We don't have good answers for these questions yet, but the impact to rural Kansas providers who are forced to switch from long-term care to residential care facilities will be significant. We'd like to make sure that that gets on the radar screen for KDADs so they can start thinking about how that might affect providing. Again, I thank you for being here today, and that's all. I'll be available for questions.
All right, thank you very much. Committee, then we also have written-only testimony from Matt Fletcher with Executive Director, Interhab, Leslie Anderson, Executive Director, Kansas Association of Area Agencies on Aging and Disabilities, Vicki DeStefano Purbeck, President of 501c3 Adamantly Protecting Kansans from KanCare, and Sarah Hart-Ware, Executive Director, Kansas Council on Developmental Disabilities. There we go. All right, committee, are there questions for any of the conferees? Representative Carpenter.
Thank you, Madam Chair. So I continued through this whole testimony was rate parity. So did something happen in the appropriations process? I know social services budget recommended all the waivers be at the same rate last year. Can somebody answer me if that didn't happen? Did it not happen in negotiations during conference committee, or do you know? Does anybody know that answer?
Is there anyone from KDHE or KDADS that can respond to that? Is there anyone from, I know KDADS is in the room, so where's KDHE? Oh, there's KDHE. Can you help us out?
My understanding is there was the rates for FE and for IDD are higher than the rates for the other waivers. There was, so when you look across for the DSP rates, that they're slightly higher than the other waivers.
Well, thank you for that. I thought that the committee recommendations were to bring all the waivers to the same rate. And I don't know, I'm not on appropriations, so I don't know where that, what happened.
I'm not sure either that we agree with you, Representative Carpenter. We want to see rate parity across all the waivers. But apparently there's been some work being done to raise rates for certain populations.
Okay. I need you to, if you'll stand there for a moment, and just tell us who you are so we have it on the record.
Oh, sorry.
I know
I'm Michelle Hayden. I'm the LTSS Commissioner for KDADS.
Okay, perhaps what you could do is relay back to folks is that if they can do it sometime today, and if not, if they could get it to us tomorrow.
Okay.
You know, let's find out what did we have in there, where did it change, so we understand why we're at where we are today.
Okay.
So that we can figure out what needs to be changed for the next year. Okay?
Okay, thank
All right,
you.
thank you very much. Committee, are there further questions? Representative Reese.
I have a question for Kristen with Behavioral Health Solutions. She's still on. Hi, Kristen. Can you used the phrase value-based services several times, and can you please define what you mean by that?
That the outcomes determine the value of the program, that we look at the outcomes of the program and see that there is a cost savings. So it's basically a program that would increase outcomes while decreasing costs to the system.
Okay, thank you.
Of course.
Representative Baumgartner, or excuse me, Senator Baumgartner. Apologize.
No problem. Thank you, Madam Chair. Two questions. First one is for Tanya Dorfbrunner. Tanya, as you come up, you talked about the dental provider network in Kansas. How many dental providers do we have in Kansas that are taking these individuals?
Madam Chair and Senator, that's an excellent question, and I don't have an answer for you right now. We've actually got a data request into KDHE to ask that exact question. In fact, we're even asking how many Medicaid providers are there and how many people do they see each year? Is it 5 people? Is it 10? Is it 50, et cetera? So I'm waiting on that information.
So when you shared the information with regard to Missouri increasing their rates, do you know what percentage of their dentists are actually providers? And are the rates going to be different per region? Because that's often the case.
I am almost completely certain they are not different in the by region in Missouri. I can check on that, and I didn't bring the number, the percentage of, I know that number, but I didn't happen to bring that with me today from Missouri. I can talk to my counterpart and get that.
So, Madam Chair, while KDADS works on getting that information, it needs to be broken down, not just dental providers, but those that are pedo, that
Yeah.
provide for the children, because we heard testimony before that in the Sedgwick County area, there was just one pedodontist that provided service for children. So we need that breakdown in Kansas.
Agree.
KDADS also needs to provide that information for medical care providers, because we keep talking about changing rates, and we don't even know where the providers are or how many we have in our state for medical as well as dental. My other question just had to do with, so thank you, was Sean Gatewood.
Wait, let's wait just a moment
Oh,
here. I'm going
okay.
to tag along on that there.
Great.
Tanya, I think one
Yes.
of the other things for us to understand is besides how many we have out there and how many are taking Medicaid, because we know that it's not as many as it should be, is also the issue that I hear from dentists is also the issue of no-shows. So if there's any way that we can figure out and gather some of that information for us to get a better handle on that and see if there's any way of addressing that.
I think-
Because dentists do not like no-shows.
100%. And I think that's an excellent question. And I would hope that we could maybe keep coming back to that issue. We are in the process right now of forming a dental provider experience focus group, advisory group, that's the word, a dental provider advisory group. And we want to get at those exact things. We've got dentists who've signed up to be on this that are Medicaid providers, some that are not. And we're trying to figure out exactly like, so what is it that works for you in your office, and how do you handle no-shows? How do we create some change and help other providers understand, here's a policy you could put in place in your office that you could make the same thing work. So we're 100% on board with that. We're looking at it. We just don't know yet, but we're trying to look at what are some models and how can we scale those up. So it's a great question.
Thank you.
Thank you.
And Madam Chair, to tag on to that, please identify the no-shows that are no-shows for prophies versus no-shows for actual dental work. A dentist has to be present in the office if a prophy is done, but it's typically done by a hygienist, but the dentist still has to physically be there. But we need to know those differences.
That's that wasn't even on our list of things to ask. That's a great question. And prophies is cleanings. So that's a great question to ask. Thank you.
Thank you.
Thanks.
So my other question was for Sean Gatewood. Sean, you were talking about autistic kids, and we've got 60 and 600 on the wait list. You know, a couple years ago, I think I was sitting where Senator Peck is sitting, and part of the discussion was that autistic kids being evaluated, they were being evaluated differently for being on the list or not based on where they lived. Have we gotten that settled down? So that it's consistent regardless of where a child lives that is on the spectrum?
I have to say I have no idea. I'm not probably the person to ask. We might be able to get a little bit of an answer from that from my colleague, Mr. Quinn, in the back. He might have a better feel for that.
Senator, I might add on because I had marked Sean's testimony as well as Michael's. And I think it's something, staff, that we need to put this on the spreadsheet. So the issue of the task force, is it dismantled? What's going on to that? Is there anyone from KDADS that can respond to that now? That knows, and if not, you can bring it back to us later. Yeah, I'm looking at two of you back there. Can you bring it back to us later? Can you bring it back to us later, perhaps? All right. Or at least you can get the message to the people that can. All right, appreciate that. Go ahead, Mike.
Senator, if you could repeat your question, I'll try my best to address it.
The question was, we had heard concern from parents with children that were on the spectrum, and they were being evaluated differently depending on where they lived. So kids with similar issues on the spectrum that lived in Johnson County, Olathe in particular, those were being evaluated differently from kids that lived in other areas. So there was an inconsistency as far as evaluation just to even get on the wait list.
So my response to that is the American Psychiatric Association has a explicit set of diagnostic criteria that should be used across the board, irrespective of a child's racial, ethnic, or socioeconomic background. What I'm hearing from constituents across the state of Kansas is that the screening, evaluation, and diagnosing of children with autism is very much ad hoc, and that requires some attention. And I would be happy to be a part of a broader conversation how we can improve that as an area.
So I appreciate that. What we were finding is it really wasn't so much gender, racial background, or economic background, but more of a zip code and what zip code was doing the evaluation. So if we could get to that, I think that would be important. Thank you.
Okay.
Thank you, Madam Chair.
So I would say that on the spreadsheet is the issue of the task force, evaluation disparity, and if I'm understanding between both Michael and Sean, I think the other issue we have out there is some dual diagnosis, that autism and then mental health on top of it. Is that correct? Whoever wants to respond to that. Sean? And maybe the dual diagnosis doesn't get as clarified as it should.
I have to apologize. I don't think I understood the question entirely.
On the issue of the children that are defined as autistic, and then there's mental health issues on top of that. Behavioral health services that are needed.
What are you asking exactly? Like, yes, I understand they're dual diagnosis, but what are we?
Are we seeing a problem with that not occurring properly?
Well, I think the biggest problem that we're seeing, I guess the hurdle that is probably the lowest hanging fruit is just the initial diagnosis and of the child. It just takes years to get through the process, and that's whether the child has the single diagnosis of autism spectrum disorder or dual diagnosis. So just the general evaluation is very difficult to get through the process.
All right, that's why I wanted to clarify for our spreadsheet.
Thank you, Madam Chair.
Is it on this here?
I have a question about what he just said.
Well, we can go back and forth between those, Sean. What did you say, Senator?
I have a question about what he just said.
Okay, Sean, she's got a question. She wants some clarification.
You said over the course of years. I mean, a child, the mental health issues can, from one year to another, change significantly, as can the autism, where they are on the spectrum can change as they continue to develop. So if it's taking years for an initial diagnosis, they would actually be, the diagnosis would be ongoing, because that's why it's referred to as a spectrum, because where they sit in it shifts as developmentally they change. So are you saying the initial diagnosis is taking several years?
The initial diagnosis for a lot of kids takes a very long time. And again, to your point, not only do you have that issue, but you have the issue of, the waiver is only for children to age 6. And so you're burning that time too.
Thank you, Madam. Not the answer I wanted, but thank you, Madam Chair.
Well, I think on top of that then is probably some clarification that the legislature needs to understand as they proceed forward with this. And again, I think it goes back to, finding out what the deal is with this task force, is then who's responsible for these kids in getting these assessments, et cetera? Because if we're dealing with the kids 5 and above, then is that the school districts to help identify that? And is that an IEP issue? I don't know the answer to that, but I think that's the things we need more detailed information on. So, okay, and then I think Representative Ballard has a question for one of these gentlemen, then we'll come back to Representative Reese and then Representative Carpenter.
Thank you, Madam Chair. I think it's on. Yes. I want to follow up with Michael Quinn.
We just make you a little jumping jack back here.
Can I get my steps in, Madam Chair?
Apologies, it took me a while. I've been asked the question of how closely does your organization work with school districts?
That's a great question. So just to give a little bit of context, the vast majority of our work is done in the state of Missouri. However, because of the recent reimbursement increase rates, we are committed to expanding care and provision in Kansas. The state of Missouri they're in the process of introducing a new policy that will provide coverage for autism treatment in schools. The question is, will schools allow providers like Autism Support Now and others to enter the school and partner and collaborate? And I think one of the long-term goals, shall we say, for the task team should be to look at providing treatment in schools in the state of Kansas.
Okay, so that I'm surmising from that we're not doing much in the state of Kansas by working in schools.
Correct.
Okay. So if we're not working in schools, does your organization then provide additional treatment, or maybe I should say information to parents in order to work with their children?
Yes, so a stipulation with the MCOs and other commercial payers is to have an element of parental engagement as part of the broader treatment program. So children receive clinical intervention in a clinical setting. In addition to that, they also receive what we call family guidance. The CPT code for that is 97156, and that requires parents to engage on a consistent basis regarding their child's treatment.
So you actually treat K through 12, or is there an age limit in terms of where you stop?
So the youngest children we serve are 18 months, and we go up to 14 years of age. But as your colleague said previously, autism is a spectrum, and it's also a lifelong disability. So treatment should be continuous throughout the lifespan.
So, Madam Chair, I guess I gather from there that Kansas needs to develop a kind of relationship so that it can be even more effective and not so spotty in terms of not having treatment.
Yes, you can provide clinical intervention on a consistent basis, but the key is the generalization of skills, and those skills need to be examined in other contexts, such as a school setting.
All righty. Thank you, Madam Chair. You answered my question. Appreciate it.
Well, and then Representative Ballard, the question comes is, do we wait to see what's happening with the task force and leave it to them? Or do we do that plus have the legislature take a look at that during the next legislative session?
Madam Chair, to respond to what he said and to you, I would say we probably need to do both.
Okay, that's now on your shoulders.
You know what?
My shoulders are leaving the building.
I was gullible and I went right into it. I worked with her long enough to know better. But thank you, Madam Chair. I take that on.
All right. Well, I just want to make sure someone's going to follow up with that. So, all right. Thank you, Michael.
Thank you, Madam
Appreciate
Chair.
it. And I think you kind of got all that, so it'll be helpful for the spreadsheet. And I want to go back just on the issue of the rate differentials is to put that issue on the spreadsheet so that we don't lose it in the process. Okay? I didn't tell you to do that. And let's see if I had another. Okay, that's it. Now we've got Representative Reese.
Thank you, Madam Chair. My question is for Colin.
Yeah.
Hey, Colin. Can you just explain a little further what you meant about the supported employment, the definitions, and how both the employee and employer can be supported?
Well, I am on a separate committee about this, and the person I can suggest to you who would know the most about it would be Craig Knutson over at the KU UCDD.
Okay.
But what I know from talking to him is that, all right, you've got the state of New York has their supported employment rate at $90 an hour. I don't know how it's billed particularly, but they aren't moving the needle in a positive direction because what the definitions say you can bill for is very restrictive. And so what Craig said to me is you could have it at $1,000 an hour and still be getting nowhere without appropriate flexibility like transportation for the job coach, talking to the employer, working with them. And it is a two-way street in that you need to support both parties, not just the employee, but the employer so that they can understand. I'd again point you to Craig Knutson for more information about that.
Okay.
He knows more than I do, but I've been learning a lot.
Yeah, you are.
All right.
Okay, well, thank you, Colin.
You're welcome.
Okay, Representative Carpenter.
Thank you, Madam Chair. So I don't really have any questions here. I just want to put these on agencies that will be before us so that they can speak to these. In our packets was an issue with KanCare with Patton, a gentleman named Patton. And so when KDHE gets up here, either today or tomorrow, I'd like some details on how that is proceeding and where that's at. And then also with KDAD's long-term care applications, and, that's in-house, and what's our problem with that. And then secondly, somebody may be able to answer this in the office. So has CMS released their hours, the requirements for the hours? Has that happened yet, or does anybody know? One of the guy that was online talked about the requirements for increased hours, and I didn't think it was processed yet and through the process, but I'd like to know that. Thank you, Madam Chair.
Senator Petty.
Thank you, Madam Chair. My questions are for Heather Braun. Heather, I'll speak to them as you come up. You mentioned, and I was looking back through your testimony because I know the time frame goes by really fast, but you mentioned two things, and one is the chip correction. And so as I'm looking here, you mentioned that so you will have legislation prepared to address that issue for the 2025 legislature?
We plan to. We also plan to come before you all in October with a draft, if you would like that to help jumpstart that process. That I know in fall of '22, the committee co-sponsored that bill, or actually introduced it on our behalf, a committee-sponsored bill to the 2023 legislature. We're hoping that happens again in 2025. As I hinted and have, in much more detail in the written testimony, there have been additional federal regulation changes that kind of accompany this. Like if we're having already opened up the statute, there are now at least two provisions that are out of alignment with federal regulation regarding waiting periods and lockout periods, which candidly get way far into the weeds, and I've had to rely on agency staff to explain what those mean. But yes, it is our plan to continue to pursue that permanent fix to legislation.
So it'll be, so with the changes that have been made at the federal level, it'll be beyond what the former legislation was?
Yes.
And then the second one was the second item that you had mentioned, which was increasing the payments for the pediatric and the maternal-related codes. So I just want, as I was looking through your testimony, reiterate the fact that, so we have 60% of KanCare enrollees are children, but they're only accounting for 23% of the spending. And so, I mean, yes, as people get older, they're going to have higher, more costly needs, but you're maintaining that, is this because of the reimbursements rates that
No, I'm just saying, Madam Chair, I'm just saying that, you know, what we invest in our children is not much in comparison to the rest of the cost of the program. They are a large majority of the population of KanCare, but they account for very little spending. I didn't have it there in writing, but always imply it. We know that you invest in children's health in their early childhood years. It is a much lower cost over the course of their lifetime. And so when you invest in children's health in childhood, you actually save money on their health care over the length of their life. And so if we are spending very little on reimbursement rates that go to children's health care, we should invest a little bit more, especially if we see that we will get more providers involved in their care, because we know there is a lack of providers that care for children with Medicaid in this state.
And then lastly, on the rate increase for pregnancy and maternity care reimbursement, I totally agree with you, but it seems that if we invest there, some of these other issues when it comes to autism and waitlist, those could be addressed if pre-birth, that those issues that there is investment on our part, so that mothers know what services are available before they even have the child. Otherwise, they are ignored a lot longer, and then we have increased issues. Thanks to you. Thank you.
You're welcome. Thank you.
I had a last question for Leslie. With
Just a moment. Were there any other questions for Heather while she was up here? I have one. Yeah. I want to try to keep them from all having to bounce back and forth. So Representative
Thank you.
Carpenter.
So Heather, has there been any progress on our deal that we've made?
We have tried behind the scenes.
Okay.
And we continue to try. It is our goal this fall to investigate the germanus issue that continues to hold up the CHIP eligibility fix, where it is, you know, some believe that it's germane to Medicaid expansion, and so that's why it keeps getting held up. And we plan to explore that this fall. And we're going to keep trying to find every avenue that we have available to us so our CHIP eligibility rate doesn't suddenly drop below 200%, which is what will happen.
But you know why.
I know why.
We all know the game.
We do, and I appreciate everyone's support in finding a way to navigate the politics around this. So, thank you.
Thank you.
Well, it's also one of the reasons that having a bill available then provides for the proviso that's needed in the appropriations bill. So you can also make those changes on the federal stuff within that proviso. Okay, is there any other questions for Heather? All right, seeing none. Senator Petty, continue with your next one, Senator.
Yes, I'm sorry. It's for Libby Hastings with Kansas Advocates for Better Care. Libby, you had talked about the resource guide and how we now have, I think it was 3 or 4 areas of the state where they're preparing their own resource guides. And so, is Kansas Advocates for Better Care looking into what this would cost for the state to help with other senior care centers to provide that same sort of resource?
Sure. So we don't have a number figure yet, but that is something we'd be more than happy to collaborate with KDADS on to get a more accurate cost. I believe the last time an Explore Your Options resource guide was made available was 2013. So we can look at the data of how the resource guide was distributed and printed in 2013. And I know costs have probably very much increased over the 10-year period since it last came out. I know for us specifically, for Douglas County, it was about $7,500 to print about 1,000 guides. So printing is a factor in the cost of distributing the guides.
Sure. And with the guides where they're, like, for example, in Johnson County, where they have been available, so is there any tracking as to, I got this information because I had a guide, or is that tracked in any way?
I am not for sure in terms of how Johnson County and the Central Plains AAA are tracking that. I'd be more than happy to reach out to them and see if there is a way that they've been tracking it. Our guide came out a little less than a month ago, so we haven't been able to track that data yet because we're still distributing the guides, but we're able to track, how many guides we send out, if they visited on our online platform, how many clicks and such. But that's some data that we'd be very much interested in collecting.
Thank you.
And Elizabeth, along those lines, I actually had that on my list here, was to add us to look at the, explore the options guide and see what we could do with that.
Sure.
The cost on something like that
Yeah.
would be, put it on the spreadsheet. All right, thank you. Next, we have Senator Baumgartner.
Thank you, Madam Chair. We'll blame Representative Carpenter on this. I'm just taking his lead where.
He's to blame for everything,
I
so
know,
go ahead.
I know. We always need one. No, but he said others are going to be coming forward, and so I thought I might as well just bring this up as others come forward. I've been hearing from folks that have children, young children, through foster care. So they're fostering young children that have severe medical issues. And one of the things that Hal Oberholzer mentioned, his third component was it's most cost effective to have the individual not in the hospital, but at home as soon as possible. And that becomes this issue where DCF and KDADs, so these kids with severe medical issues, and there are just under 3 dozen of them. When they're first placed in the home, they're put at a higher tier of an enhanced IDD rate, even though that's not really necessarily the issue. And once they're in the home, then the rate is being reduced. And part of what's being shared is there's not a structured tier rate for kids with significant medical issues in foster care. So I've heard from a couple of different folks about this, wanting to know, is this a KDAD's practice? Is this a DCF practice? Or is this just a KVC practice? And this notion of, well, if you don't want to accept that pay, we'll just hospitalize them. Well, that makes no sense. But these are kids that essentially need someone 24 hours a day to be caring for them. And one of the families has, so that the foster mother can go and do her part-time job, does have nursing care assistance that comes in. And that was given as a reason for reducing the rate, is because, well, assistance is coming in, even though, someone has to be there for that child, and there are expenses for these children. So I think we need something, if we put it on the spreadsheet, but somewhere along the way, we do need to hear from KDADs as to what is this practice, and why do we not have a tiered rate for kids with severe medical issues that are then put in foster care. And some of these, it's my understanding, have been in foster care for several years. So I don't know that that's really foster. This is, several years isn't really what we're going for foster care. But if we could
unfortunately, you're going to have kids that's just going to happen with.
We do know that, don't we?
Yep.
But
It's
if we
just
could
like
get,
still having kids sleeping in the offices, but that's not news anymore.
it's not, at least it's not being reported. But if we could have that addressed in some manner, that would be helpful.
Yeah, we could have Elizabeth make that a spreadsheet item. If you need more information, get with the senator, please. Okay, anyone else with questions? Nope, that's it. Okay, I've got some things here is, I guess Elizabeth and KDHE just needs to make notice, is I want to understand more about the issue that Aaron Herbal brought up on the hospital issue. Because on the rural hospitals, because I think that's concerning when we have fought so hard to increase those out there, and now we're creating an issue. So I definitely want that on the spreadsheet, and I'd like to have, before we adjourn tomorrow, I'd like to have it today if possible, is to hear a response back on that. And then I have...
I can give you a response.
Okay. Thank you.
My name is Jerry Smith. I'm the Bureau Director for Facilities and Licensing. And I certainly have talked with Mr. Herbal many times as we have tried to go through this process to move to become a rural emergency hospital. So in this case, most of it really does lie at the federal level. Mr. Herbal is right. This hospital has provided long-term care. It's called a skilled nursing facility bed. They were first licensed and certified in 1975. However, as I was digging through the archives, I did come across documentation that in 1997, Mercy Hospital terminated their skilled nursing facilities and changed them to swing bed services only. In a swing bed, you can continue to provide the services. Part of the agreement when a hospital becomes a rural emergency hospital with CMS is that they give up their swing beds for a monthly stipend of $270,000. We have gone round and round with CMS and with KDHE and KDADS looking at this particular situation. But because the beds were no longer CMS certified SNF beds, and that stopped in 1997, they don't exist anymore as far as CMS is concerned. So they're just swing beds. And so when you give up the beds and collect the stipend, that's the deal with CMS. So Mr. Herbal has tried to get a waiver through CMS, and he was unsuccessful, and I've certainly have reviewed so many emails and so much documentation. I think the issue continues to lie with CMS. If Mr. Herbal does not have those documents, I brought them over today. I found them last Thursday. So maybe he can file another appeal with CMS, I'm not sure. But we don't have any jurisdiction over changing them back or for him to be reimbursed. All that does come through CMS. So we just don't have the authority or the jurisdiction to remedy this. I wish we did. He is correct, we have been working on this for many, many months, but this isn't something that we have the ability to solve.
So are we having any other hospitals with the same issue?
I was not aware that we are, and there are 2 other hospitals, but I think it really just comes down to an interpretation that the services have been provided all this time and that they could continue. When CMS looked into whether they were certified SNF beds, they did not go in and actually verify that those were not there anymore. And so I think that had they had done that, I think Mr. Herbal would have had his answer many, many months ago.
Okay, and I appreciate that, so thank you, and we'll make sure that we have a clear understanding of that. I think that, Elizabeth, it's still a spreadsheet item. And whether it comes from this committee or what, but I think maybe we have a visit with our congressional delegation and see if there isn't something that they can help us with on that. Mm-hmm. You know, because I know how difficult sometimes CMS can be, and I get that and the frustration, but we've got some elected officials that more often than not are willing to help us with some of these issues. So
yes.
I think we just need to figure out a path between now and tomorrow how we'd like to proceed with that, but let's definitely make it a spreadsheet issue. Representative Carpenter.
Just very quickly, so has the reimbursement continued throughout this process for those swing beds?
No, the reimbursement was stopped in December. When the moment they became an REH, CMS stopped payment on those swing beds. The stipend has, yes, they have been, he would have to confirm that.
Yes.
Okay, but yes, so they've been.
But the swing beds have stopped, but the stipend
That's correct.
Because of the designation,
Yes.
REH. Okay, very good, thank you.
All right, appreciate it. Anyone else on this? All right. Next, Christina. I didn't have the last name down here. Yes, Kovacs.
Yes.
Christina, you mentioned in your testimony, you talked about on the behavioral health, expanding telehealth. What do you feel is needed that we don't have today?
I'm not sure. I discussed expanding telehealth. It is part of our services, but that may have been someone else's testimony. I'm sorry, Madam Chairman.
No, I had it on yours. That's why I was
Was
just curious, because we've done a lot on the telehealth with, yeah, it was on page 4, telehealth expansion.
Oh, it was part of the written testimony in the deck. I'm so sorry. Yeah,
Yeah.
so I think what we do, and this isn't necessarily specific to Kansas, but we utilize telehealth to make sure that we can bring all the resources and services to the rural communities specifically when we need to pivot and we can't. It's difficult to recruit providers sometimes in those locations or have them commute to more rural locations. So to make sure that there is connectivity in those rural locations so that we can provide those services.
Okay, I appreciate that. I just think, you want to be real careful about, providing testimony to us that may pertain to other states and not to us, because then it gets confusing, not only for the committee, but then also for individuals out there thinking that we have a problem with that, and we've spent a lot of time working on it. So thank you very much.
I apologize, Madam Chairman.
That's fine. I don't know why I'm doing that. That's just stupid. You stop. Okay. Mark Schultz, and this here will be more for Elizabeth, is I think that we need more follow-up on this application delay and what's causing it and what can we do to fix it. So that makes it a spreadsheet item. And then on the dental, it will become a spreadsheet item, but we're going to have that discussion when we get into the sedation. Elizabeth? Okay, that's all I had. So committee, now we're ready to move forward unless there's other questions for any of our conferees that we had. Okay. Now let's see if we can make time up here a little bit. I don't think we allowed enough time for our questions, so I apologize for that. We're going to have KDAD updates, and I believe our first person is going to be Scott Bruner, Deputy Secretary of Hospitals and Facilities. Welcome to committee.
Thank you, Madam Chair. You can give me some direction on how much time you want me to make up over the course of the next hour and a half, I guess, which is, I think, what we've got on the agenda.
I think you're well-versed in how to do that, so I'm going to trust you.
Thank you for that vote of confidence. I wanted to give a little bit of an update. The Secretary asked me to provide her update as well. There's in the slide deck that we've provided. She had a few notes that she wanted to pass along. So I'll start with that. First, the Long-Term Supports Services and Supports Commission's been busy since the legislature's adjourned. Sending out offer letters to individuals on the waiting list to fill the 500 slots on the PD and IDD waivers. Those letters are out in different cycles, and Commissioner Hayden's here, and she can answer questions if you've got about that. There's a great deal of work going on with the community supports waiver. There are some issues that have come up in the discussions with CMS about targeted case management and conflicts of interest, and I think we're going to talk to you some more about that over the course of the day today and tomorrow as well. We're excited to announce with the Kansas Housing Resource Corporation a partnership with KDADS and the Division of Healthcare Finance. We're awarded an $8 million grant from the Department of Housing and Urban Development to advance, create, and renovate housing across the state for people with disabilities. Addresses a lot of the needs around housing, which you've heard about over the course of your work, and people at risk of being hospitalized. Since the end of the legislative session, we've hosted 2 large stakeholder meetings and had 100 people in attendance with 50 virtual. We've also had a stakeholder input hearing about our budget development and received a number of suggestions about ideas to include in our enhancement requests for fiscal 2026. And we're also implementing 20 provisos that were in the appropriations bills over from last session, and you'll hear about a couple of those items in particular today about mental health in schools and the supplemental staffing agencies requirement. And then finally, we're excited to share at your meeting in October the results of the Waitlist study that KU's been working on and the final report of the South Central Regional Psychiatric Hospital Advisory Panel. That work is going to finish up in the month of September as well. that gets into the more, I didn't even introduce myself, and I always try to remember that, so I apologize. So, but the slide has my name on it, so I can remember at least that. I'm Scott Bruner. I'm the Deputy Secretary for Hospitals and Facilities, so I apologize. I'm just downshifting into my actual job. So I wanted to give you a couple of updates about the Regional State Hospital project. Actually, in our presentation today, we talked to the research staff about what we could just do in writing or refer to the slides that we've presented. And I may gloss over a couple of things. And there's a couple of standalone presentations as well that you'll hear from that are on your agenda as well. So the Regional State Psychiatric Hospital project, so we're in the process of designing and building in partnership with Sedgwick County, a 104-bed regional psychiatric hospital that'll serve both patients that are involuntarily committed through the care and treatment process and criminal defendants who need to have their competency evaluated or restored. We're in the process of design of that building right now. We just received on Friday our 50% construction document packet, which documents all of the interior structures, wall structures, footings, things like that, that are the product of about close to a year's worth of design on how the patient experience will be, the back office, those kinds of things. So that's all working towards the timeline to start the construction on the project. The request for proposals, it takes all those construction documents and releases it to the vendor community to find a general contractor, is scheduled for release on October 24th. Sedgwick County is leading that process on our behalf. And when it's released, then the responses will come back by November 22nd. And then over the course of the month of December, we're going to make the decision to award that contract, work that through the Sedgwick County Commission as well, and then get that all done and buttoned up by the end of December. We're expecting to start construction in February of next year and complete by August of 2026. So we're hope we can announce groundbreaking for early in 2025 to stay on that timeline. You all did add $26.5 million in the omnibus bill. That's letting us move the project from the original planned 52 beds with the ability to expand. We're going to build the full 104-bed design. That's the recommendation that our advisory panel made, and you all have endorsed that as well. So that gets us on a very good footing to both as we put the bid documents out, we're not putting it out in phases. It's all one project. And so we're optimistic that'll get us the whole project done in that same time frame of complete by August 2026. And then the kind of significant milestone in the project, at least for us, the Sedgwick County Board of Commissioners approved the land donation agreement that actually gets us our site at MacArthur and Meridian in South Wichita. The closing date for that's August 30th. We've not run into any significant problems with the closing process, so hopefully we'll have our site all buttoned up and ready to start the construction process by the end of this month. And I'm happy to answer questions about that at the right time. The next couple of slides are ones that I show you from every time that we meet about the number of vacancies at our current state hospitals and the percentage vacancy rates. I won't spend too much time on that. The one for some of you that are newer to the committee or haven't seen these in a few months, this represents the staff that we characterize as direct care, so our safety and security, nursing, our mental health and developmental disability tech positions, and nursing as well. So it's not the whole campus job base, but it's those kind of critical positions that are in direct care. Since we also draw the line on there when the 24/7 pay plan was implemented in December of 2021, and then kind of track that as with that significant investment in wages and some incentives, what that's done to vacancies. And the lines stayed pretty constant. Something new that's happened that we're expecting to see and have started to see some movement in the line is a budget proviso that you all adopted last session. So we asked for, after working with a few of you on a subcommittee about state hospital staffing, a proviso that gave us some permission and additional authority to offer bonuses to our state employee or state hospital staff that go above and beyond the statutory cap of $3,500. So we can award bonuses up to $10,000 per fiscal year. I should have updated the slide a little bit, but we did work with Personnel Services to create payroll codes so we can track each of the bonuses at the person level and the campus level, and that's been put in place since July 21st. So that was the first payroll period when we were able to offer those bonuses. There's several different levels. I won't read through all of them, but there's a sign-on bonus if you're a new employee. If you're an employee and you refer somebody who becomes an employee, there's a bonus. There's a retention for long-term employees for longevity, and a retention bonus once you stay on the job for 6 months and don't have any disciplinary actions. There's a $2,000 bonus that's paid out in a couple of phases. That's one area where we identified in surveying staff and looking at the data that if we can keep somebody past the 6-month mark and then at the 12-month mark, we have much longer longevity. They stay with us for 5 or 10 or additional years. So we thought a bonus at those milestones would be important. And then finally, one that's actually had a lot of impact for us is a pickup shift bonus. So if the superintendent identifies a shift during the work week that's extremely hard to fill, nights, weekends, holidays, those kinds of things, we can identify that shift for an additional bonus and pay an employee up to $100 if they sign up for that shift. And we have seen some good traction from that one as well. Did want to show some of the initial results of these bonuses. We haven't, because the sign-on bonuses and those initial longevity bonuses take a while to play out because we have to make sure the person's hired, they stay employed for 6 months, and then we can award the bonus. So those haven't shown up in the data yet. But we have had a number of people benefit from the pickup shifts, either for a full shift or a half shift. And you can see the numbers there by hospital. And then the longevity are just our bonuses that are paid to employees beyond, if they're unclassified, that because they're a long-term employee, we have those have been paid out. So close to $60,000 we've paid out, at least for the first. I think that represents 2 payroll periods, and we'll keep doing that through this fiscal year. The next slide talks about state institutional alternatives. We talk about or show you over time the number of hospitals that are participating with us that provide state hospital levels of care. But that's written only. I'm going to breeze past that one a little bit unless you have questions. The next couple of slides are about mobile.
Real quick on that, I think in the next time you show us the slide, it'd be good to see where the adults and then where the children are.
That's a great, thank you.
That's fine.
We can do that.
Yeah.
Yes. All of the KVC hospitals are children. Via Christi, St. Joe, in Wichita also serves children and adults, and then the others are adults only. But we can note that on the table. Mobile competency. So another issue you've asked us to report on a regular basis are our wait list and wait time for criminal defendants waiting for competency services through the state hospital. And the tables are there of ones that we've been working, but not the ones that we serve on campus, but where we go out to jails and try to perform those competency services in the jail setting. That program's worked well with the counties that we're in partnership with. And then we've also contracted with Wheat State Healthcare to branch out to using the mental health center network to provide services in jails around the state as well. So far, through that contract, 24 mental health centers have staff trained to conduct competency evaluations, and 17 have staff trained to do competency restoration. And they've been working with their jails and local law enforcement and their judges to set those services up around the state. And you can see on the chart there on slide 13, they've done somewhere around 50 to 60 competency evaluations every month. At least that's showing for this calendar year. The other, thanks, Lee, for going back and forth. Reimbursement to counties. So another program that we put in place and you all authorized through through statute was to let us reimburse counties and healthcare providers for the cost of having patients wait for services. And there's 2 different laws. Senate Bill 228 directs us to pay to law enforcement while somebody's waiting to get from the jail where they're in custody until they get to Larned or Osawatomie for competency restoration services. So we pay $100 a day to law enforcement for the waiting time that's related to that wait. House Bill 2184 is similar, but focuses on the wait time for people who are waiting for a care and treatment involuntary admission to either Larned or Osawatomie or one of our state institution alternatives. That one's open to law enforcement or hospitals or healthcare providers who sometimes the person shows up at an emergency department. They've been screened for a state hospital stay. But because of wait time, they're waiting in the emergency department for that either transport or for their admission to come up, and either law enforcement or the hospital is having somebody wait with them, sit with them to monitor their behavior and keep them safe. And so we're paying $40 an hour for that plus the transportation costs. So we've been reporting on the amount that we've been spending for those two programs. And again, they're similar purposes, but for a different target population. So on slide 16, the total that we spent in fiscal year 2024 was $7.8 million to law enforcement for wait time related to trying to get into competency services in either Larned or Osawatomie, and we broke it down by county. And then we've spent so far through fiscal 24 of reimbursement requests that we've received about $1.2 million to either hospitals or law enforcement for involuntary commitment for the wait time related to getting admitted for involuntary commitment. Madam Chair, that's my part of the presentation. I'm happy to come back up when the other commissioners have presented, or happy to pause for questions now if that's appropriate.
No, that would be good. Committee, are there any questions for Scott? Representative Reese.
Scott, trying to figure out how to ask this question. Looking at the reimbursements and looking at the totals and seeing the reimbursement rates for all the counties. And also, it's my understanding that there is a way to ask for a competency evaluation. One of them is a little bit more straightforward, and I think the other one is a little bit more complicated and might keep that individual in custody longer. Is it possible that that can be used to get more reimbursement?
Representative, so law enforcement judges order people to have their competency evaluated or their competency to be restored. So that's a judicial process. The judges can't control, well, they can order either the mental health center by the statute change that happened a couple of years ago. They can order the person to Larned, of course. They can order them to be served by the mental health center if they've got a relationship there with a private provider. And that triggers that process to have the person evaluated. If they have to come to Larned, of course, then there may be time waiting to transport them or get them admitted. Mental health centers are getting into jails where they've got those partnerships set up, and a number of them do within a couple of days or less. And then we can also send out mobile people from Larned as well. That's less frequent. So I don't think there's a whole lot of incentive to hold somebody in the jail if they don't need to be there, and if there's another option to get that person served. So for evaluations in particular, I don't think that's much of a risk. Restoration is more complicated because you're treating the person or they're getting some level of service. The restoration process takes some time because it's training the individual, trying to get them competent enough where they can understand the legal process and the charges against them and how they participate in their defense. And that takes a little longer, and some of it's done through group sessions. So there was a couple of weeks there anyway, so there's a built-in treatment time. Now, that could happen if they come to Larned, but if they're doing that in the jail, then they don't get reimbursed for that until they're ordered to Larned. So I don't think there's a lot of incentives for law enforcement to keep people in jail longer just because of their competency status or having that evaluated. We have heard some stories of repeated rounds of evaluation where either somebody's restored, they go back to jail waiting for restoration, they decompensate, they need to be evaluated again. So that does happen, but again, I don't think there's much of an incentive for law enforcement to hold somebody to play that out, particularly not, we've made this process as simple as we can figure it out. But I don't think it's so easy that there's enough incentive to try to game the system to have the counties make money off this. And at $100 a day, they're not making money on this at all. I don't think.
Thank you.
I was going to say, our sheriff would love to see them out of his facilities, so.
I think that's the incentive.
So when they do the competency, because that's what's going to fill up the new hospital. Yeah.
For half of it, yes.
At least half of it. Then after the competency, and sometimes those can take a year, 2 years, 3 years, is that correct? Or months? Depends upon the individual's needs?
Restoration.
Competency?
So competency restoration, by statute, we have 2 90-day rounds. So we can attempt to restore in 90 days. If we're not successful, we can request another 90 days. At the end of that, the way the statute's structured, we go back to court and say, we can't restore this person, they need to be referred to a care and treatment case, and they go on a different path for treatment. Or if we think we can be successful, they could get another round of restoration if the judge orders that. But so the time is really waiting to get to the place that's going to do the restoration or provide restoration services, not so much the time in restoration.
Right. Okay. And I think, Elizabeth, what we'd like to do is follow on the spreadsheet the impact of Senate Bill 228 and House Bill 2184, so that we keep an idea on what the ongoing costs are for this program. And I know that the agency will have that, but this is for us to make sure that we pay attention to it. Is there any other questions of Scott? Yes, Senator Fagg.
Thank you, Madam Chairman. Thank you, Scott, for your presentation. I was going back a little bit to the Mound Ridge Hospital issue with Aaron, and it sounded like CMS was the issue, but I'm sitting here, does the state have the authority to do waivers? And if so, why haven't we done waivers to help that situation?
We do have some limited authority to do waivers. One thing we're not allowed to do is go back and create a skilled nursing facility in the past. So when our statute or the regulation changed, it grandfathered in some facilities that wouldn't meet the current standards for a skilled nursing facility, but because they had operated as one and were licensed as one in the past, we grandfathered those in. So we do have that authority to waive, but as Mr. Smith mentioned from KDHE, Mercy Mound Ridge didn't have that license in place at the time, so we could go to allow us to go back and grandfather it in place. So we do have waiver authority, but it doesn't apply in the circumstance because of the timeframes and the types of licenses that were in place at Mercy Mound Ridge over that historic timeframe.
So we have no way to help them at all with their issue?
As Health and Environment said, they've been working with Mercy Mound Ridge. We've been talking to them as well because we did try to figure out, is there a way to grandfather or to license them as another type of long-term care facility? And we ended up, I think our last action was to put together, we did an on-site review and put together a list of the things that the facility would have to do to be able to become licensed now. And I think, at least I've seen some communication from from Mercy Mound Ridge about the cost of potentially doing those things. That might have been in the testimony as well. But that was based on some work that we did to say, well, here's the path from where you are now to what we could license under current rules and regulations.
Thank you.
Well, and Scott, would it be accurate to say that the bill that we passed this last session, that is a precursor to the feds maybe tweaking that grandfather issue? Or am I confusing it with another?
I don't, there may be something you could do to either change our authority. I think where you'd run into problems is the rural emergency hospital. Again, as Jerry mentioned, there's a limitation on providing on the type of long-term services that could be provided in that setting. So there's a federal limit that we may not be able to figure out or figure our way through.
Kara, you're back there. Is that ringing any bells that you can highlight for us, or am I confusing two issues?
Yes, Madam Chair, thank you so much. Tara Mays with the Kansas Hospital Association. The bill that you passed last year really was just about rural emergency hospital eligibility, so it wouldn't necessarily apply in this instance.
Okay.
However, we would seek to say if there is a way to get to a waiver and statutorily grant KDADs the authority to provide a waiver in these instances, because it will impact every future rural emergency hospital that is looking at this, and this will be quite a deterrent, we would look to clarify that for the agency if that's what they need to feel really good about granting that waiver.
Okay, and I believe, Elizabeth, I asked for that to be on the spreadsheet. So I think we just need to kind of stay on top of it. And again, if it goes back to, Scott, that we need to, visit with our congressional delegation or whatever we need to do, because, we're trying so hard to address what needs to be done in the rules, and I know that you guys want that as well. So anything that we can all do, let's do it. And I think we've got a pretty great delegation that can help us with some stuff. Okay. Any further questions of Scott? All right, so I think Drew's next.
I'm going to turn it over to Drew.
Drew Adkins, Commissioner, Behavioral Health Services.
Good morning.
Welcome, Drew.
Thank you. Good morning, Madam Chair, members of the committee. I believe I only have a couple of slides here today to talk about IDD crisis stabilization. I will point your attention, we had some follow-ups, I believe, specifically on our regular reporting items on the psychiatric residential treatment facilities, as well as some CCBHC follow-up information. So if you have questions on those, I'm happy to answer them at the appropriate time or if time allows. So on our first slide here, we had a question and a follow-up about IDD, crisis stabilization, and then some facts and figures that were mentioned that we weren't able to present last time, I believe a few months ago. And so some of those updates include that we have 6 IDD crisis stabilization projects currently implemented that were between December 1st, 2023 and then June 30th of 2024. Those participants include Good Life, OCCK, and Twin Valley, and they are increasing community capacity to prevent crises and incidents and provide effective crisis response through training opportunities for their direct service staff and then first responders. We also have 2 projects in Johnson County, JCDS, and Sedgwick County Developmental Disabilities Organization have community assessments that they're doing for IDD crisis services. Johnson County and Lake Mary Center are also creating kits to be distributed by law enforcement agencies when they receive calls involving people that have IDD and or behavioral health needs and or dual diagnosis.
Drew, I'm going to stop you right here for just a moment because you had several charts above that. Is there really not anything in there that we need to look at with you, or is there?
Madam Chair, members of the committee, I am happy to try and answer any questions of the information you have in front of you. It was my understanding these were the 2 items that you all were curious about, but I'm happy to go over the full presentation if that's what you're requesting.
No, that's fine. I think we'll just glance through it, but I was just checking. You're
Okay.
fine. No, you're fine.
I'll continue to move forward. So on the second slide, we do have state fiscal year 2025 projects that continued contracts that we have vendors for. Those are going through our internal concurrence process. All of those 6 vendors will continue on with us across the state. They're continuing to provide research-based training activities in some of the identified regions throughout the state. Lake Mary, as I mentioned, will be distributing again brochures and videos to law enforcement as well as the kits and also to families of caregivers too. Good Life, OCCK, and Twin Valley are providing in-person and online training sessions for IDD providers and first responders. One of the things that I wanted to note that I don't believe we got to talk about last time was an enhanced FMAP, federal medical assistance percentage opportunity that we have through the ARPA dollars that we were awarded at the state. This is in coordination with our LTSS commission, our sister commission. We had about $3.5 million, I believe, and we put out an opportunity on training for enhancement of supported services for individuals with IDD, also for dual diagnosis. It's no secret that we have a lot of individuals that either have a primary IDD diagnosis and a supplementing or a co-occurring behavioral health disorder, also vice versa, where we have an individual that may have a primary behavioral health diagnosis, but also may be suffering from an additional disorder. And so we know that some of these individuals are coming through our certified community behavioral health clinics and or other providers. And so we are in the process of getting a vendor awarded for that training opportunity and getting that training out there. I believe we have until next year, December of 2025, to draw the funds down. So we're trying to move quickly on that. And I believe that's all I have, unless there are follow-up questions, if this is the appropriate time or when the appropriate time is. Thank you.
Yep. Committee questions for Drew? No? Drew, I want to go back, and it's one of the slides that you didn't cover, and that was on page 20 of the testimony that dealt with the transportations provided by our CCBHCs, and it looks like that maybe we've got 2 of them. Do we have others that are attempting or trying or working on it? Because I know it's not an easy process to get done. Because I think Johnson County's had theirs for a while, and I don't know if Sedgwick's is really active, but I know it's, so I don't know where they're at in the process.
Yeah, we do. I think that this was something, Madam Chair, members of the committee, thank you for the question. I know that we had put out a poll after we received the follow-up question to get information from providers, from the association specifically, and this is what we got back. I did just return from Southeast Kansas a couple of weeks ago visiting a lot of the CCBHCs, and I know it's something they're working on. One of the problems is shuffling their funding around and making sure they're accurately costing for it when they're turning in their cost to us, to make sure it's either reflected in their prospective payment system rate, or if they need to find other dollars through maybe a block grant or through state general fund opportunities to ask us at the state. And so I know there are others that are trying to attempt it. I think this is just what we got back on that flash poll.
So because I know that Johnson County had one that they did with an MCO.
Yes.
So is that all tied into this here as well? Or is that, are we talking 2 different types of transportation plans?
Madam Chair, members of the committee, I believe we're talking 2 different types of transportation. If memory serves me correctly, that was with one of the MCOs, and that was pairing with peer services too. That was one of the flares, but I think these are 2 different topics here.
Okay. And then on slide 22, I just think, you know, committee, there's been a lot of discussion on the CCBHCs and those that are certified and not, so you may want to take a look at that one there to get a better handle on where we're at with those. And okay, I guess on slide 23, it's looking at the ability of the CCBH data warehouse to track the data on the drugs used. So primarily like the psychotropic drugs. Can you highlight that a little bit for us?
Yes, Madam Chair, 1 second. I don't have the slides here. I can't see the number. I apologize. I'm looking at, oh, thank you.
Oh, I'm sorry.
No, that's okay. That's okay. That's on me. I did black and white and didn't use the color printer.
That's why you should be paperless, I'm just saying.
That's fair point, Madam Chair, members of the committee. And can you repeat the question for me?
Just to understand that a little bit, because I think there's concerns on the increase that we're seeing with our psychotropic drugs, and we're concerned whether or not that the data warehouse is tracking it, and what we're seeing, what kind of trends we're seeing with that. And if you don't have more details on it today, that's fine. It's something you can bring back to us.
So what I can tell you is that the data warehouse will in fact be able to track that information What my follow-up and my to-do is for the October meeting is to bring specific metrics that are de-identified that we can present to this committee. So, and I can also follow up if we already have those from some of our centers. We're doing an onboarding of about 4 or 5 centers right now, I believe, and the association is working and helping with that. But I believe that we should be able to track that, and we should have more robust information when we come back in the fall.
Okay, committee. Any other questions? All right, seeing none. I think that puts us with Lacey.
All right, thank you, Madam Chair.
Lacey, Hunter, Commissioner Survey Certification and Credentialing. Welcome to committee, Lacey.
Thank you, Madam Chair. I have a few slides that I believe we're going to go with just written only, so I believe my spoken testimony is going to start on slide 32. Yes. So the first topic that I was asked to speak on is the licensed nursing home administrator requirements here in Kansas. Here in Kansas, we have what is called the Board of Adult Care Home Administrators, or the BACA board. And as you can see here with KSA 653504, the requirements to sit for the exam, those requirements are provided by that board. Further, there is a regulation 26382 that requires that individual seeking to sit for the exam and be a licensed nursing home administrator in Kansas has a bachelor's degree or higher. Next slide, please. The BACA board has had some meetings and has, at the request of different legislative representatives, put on their agenda a couple of times now, reviewing the requirements, and particularly the educational requirement to sit for the examination here in Kansas. And after several times talking about it in different debates, the BACA board has not at this point in time chosen to lessen the requirements for that bachelor's degree. The next slide goes over a little bit kind of just comparing, because we do get asked a lot about Missouri, it being a neighboring state of ours, and why we don't have what Missouri has. So here's kind of just at a glance what Missouri requires versus what Kansas requires. Some of the stuff that this slide does not show you is that Missouri does require a high school diploma to sit for their board exam. They're one of 6 states in the United States that have that minimum requirement. 11 states, including the state to the north and the south of us, require an associate's degree. 34 states is where we sit. We, like 34 other states, require a bachelor's degree in order to sit for this exam. Next slide is kind of, this is the end of my topic for licensed nursing home administrators, so I don't know if you want me to stop there for questions, or if you want me to, my next topic is nursing home enforcement, so.
Representative Carpenter has a question.
Yes.
Has anyone else got questions on this particular issue? We'll stop on each one of her deals.
Thank you, Madam Chair. Well, I'm probably one of the legislators she just named that's been kicking this thing. I failed to see, and I did a deep dive into it, and much of the information, a lot of states don't require, our degree. So what is the level of vacancies in nursing home administration right now?
To my knowledge, we don't have any vacancies. Our regulations don't allow for a vacancy in that position. You're required to have one at all times. We do have regulations that allow for you to oversee more than one nursing home with your license, and we do have some who are exercising their right to oversee more than one home. I don't have that number for you. I could get a number for you, though, on how many people are overseeing more than one home under their license.
Yeah, well, when it came about, there was quite a few vacancies, and I don't know if they've all been filled or whatever, but I did comparisons, and again, all of our surrounding states only require an associate's degree, and, so there's a lot of variable, but I know the board this last year, or the last meeting, did not want to lower those from a 4-year degree, so, but I would be curious how many vacancies. When I first started this, there was quite a few vacancies, and that's kind of why I brought this up. Thank you.
Further questions or comments? All right, seeing none, proceed, Lacey.
Okay. The next slides are a bit of a, I think I have my own, actually my own little presentation for this one. So the topic is nursing facility enforcement. Do you want to pull those slides up or do you want me to just go?
Yes, because I don't think we have them.
Yep. These are it. So the first couple of slides that I have to kind of cover this topic really just kind of cover what the state has for nursing facility enforcement actions. Within the statutes, we have the ability for the adult care home license.
Lacey, just a moment. Committee, it is a separate presentation. So if you go back into your S drive, you'll see a second presentation. So thank you. Yeah, it'll be the second testimony from Lacey. There should be two under Lacey. Right. Okay.
Okay. So next slide. This first slide here outlines within our statutes the different enforcement remedies that we have available for the adult care home license or the state license to operate. Those include a correction order, civil monetary penalties, a ban on admission, and then licensure, denial, suspension, or revocation. Just kind of to outframe that for you. So when we say that, we're talking about an adult care home is an assisted living, and a boarding care home, a home plus, a residential health care facility, a nursing facility for mental health, adult daycare. I think that's all of them. And then if you go to the next slide, it kind of goes a little bit more into what we're allowed to do in statute with the civil monetary penalty enforcement action. So the civil monetary and penalty enforcement action can be prescribed to a facility when we find a deficient practice. That civil monetary penalty is capped at $2,500 per deficient practice found and cited. Unless the deficient practice found has resulted in or caused serious physical harm. And then that penalty can double. And then the maximum penalty can double too. So you can get up to $10,000 if that happens. Next slide. Okay, now we're gonna go down the rabbit hole of federal enforcement. So everything we talked about before is what we have the ability to do for the adult care home license. Everything we're going to talk about going forward is the enforcement actions that the Centers for Medicare and Medicaid Services has the ability to exercise for skilled nursing facilities who participate in Title 18 and Title 19. When a deficient practice is cited at the federal level in a nursing facility, there is a state operations manual, Chapter 7, that is dedicated specifically to nursing facility enforcement. Within that manual, you find what you find on this slide here, which is the different categories. The federal government has 3 categories of remedies, and they, depending on the citation that is cited and the scope and severity that that citation is cited at, you then look to the different category as to which category you're going to be required to pick an enforcement action from as the Center for Medicare and Medicaid representative issuing that enforcement letter. Slide 1 here has the Category 1 remedies. As you can see here, directed plan of correction, state monitoring, and directed in-service training are all Category 1 remedies for the Center of Medicare and Medicaid Services. Next slide. Category 2 remedies. So Category 2 remedies, when you have widespread deficiencies that constitute no harm, but the potential for more than minimal harm. When you have 1 or more deficient practices cited, regardless of scope and severity. Those are the instances in when CMS is looking to look into a Category 2 remedy. And next slide will tell us what those are. So denial of payment for all new Medicare or Medicaid admissions, denial of payment for all Medicare or Medicaid residents it's only imposed by CMS. Low range per day civil monetary penalties or per instance civil monetary penalties. The last category is Category 3 remedies, and that is when serious actions, and these are the most serious actions that CMS can take. So termination or temporary management or both must be selected when there are one or more deficiencies that constitute immediate jeopardy to the resident health or safety. So if we have a situation where we are citing immediate jeopardy in health or safety, termination and temporary management are categories in which CMS must look at and they must consider selection of. A civil monetary penalty of no less than $3,050 up to $10,000 per day, or $1,000 to $10,000 per instance is the range in which CMS must be looking at for when assigning that civil monetary penalty. Temporary management is also an option when there is widespread deficiencies that is not the right word, resulting in actual harm that is not immediate jeopardy. So what they're saying there is while temporary management is a required Category 3 remedy when immediate jeopardy is cited, in the scope and severity grid, right below immediate jeopardy is actual harm tags. When actual harm is cited, you can also look at using temporary management. All of the remedies that you see on this page, as well as the Category 2 remedies, are remedies that only the Center for Medicare and Medicaid Services can impose. We as the state survey agency are not allowed to impose those remedies upon a nursing facility. Next slide. Okay, so this is a little bit of a chart. I copied and pasted this out of Chapter 7. So what this is this tells you when and if a scope and severity is cited, what remedy must take place. So this is required by us as well as the Center for Medicare and Medicaid Services when we do enforcement. We as the state survey agency do have the ability to do some enforcement. As you will see in this chart though, most of the enforcement, including the most severe enforcement, can only be done by CMS. The other thing I would like for you to note in this chart is that on the right, or the left-hand side of it, over there is where you will find a little excerpt that says that regardless of whether or not the state survey agency takes enforcement action, Centers for Medicare and Medicaid Services must take enforcement action and follow this chart. Next slide. Okay, so still in Chapter 7, this talks about when enforcement remedies can go in place and who tells them that that remedy is going to take place. Again, all of this is outlined in that State Operations Manual, Chapter 7. Formal notice is sent by the state, and when they say the state, they're talking about me, they're talking about my staff as the state survey agency. When there is the initial notice, on the first revisit for Category 1 remedies, denial of payment for new admissions when authorized by CMS or the state Medicaid agency. The CMS location for remedies other than those provided in accordance with 1A above for skilled nursing facilities, and nursing facilities where the CMS location is taking the enforcement action. That's a lot of words for saying that sometimes CMS goes out and does their own surveys and that the state doesn't, and in those cases, that's what that applies, B applies there. And then C, the state Medicaid agency for remedies other than those provided in accordance with A above. So in instances, some states do have where their Medicaid agency has requirements that are outside of Medicare requirements. And so you have differences in requirements for Title 18 participation versus Title 19. Kansas is not one of those states. Title 18 and Title 19 have the same requirements. Next slide. All right, so timelines for informal notice. So what this means is once we exit the facility, once my survey staff leaves the building, we have 10 days to write up any deficient practices that we found unless immediate jeopardy was found. If immediate jeopardy is found, they're notified immediately and the survey process stops until it has been abated. If immediate jeopardy is found though, we have 2 calendar days to provide the facility with their initial notice of what the immediate jeopardy was, as well as their initial notice for pending remedies. The same calendar days go for CMS as well. So if immediate jeopardy is found, if you refer back to that chart that I had, it would show you where CMS has 2 calendar days to impose a civil monetary penalty, as well as some other items that they would need to be looking at. If there is no immediate jeopardy found, that extends out to 15 calendar days. But you still have the same responsibilities from the state survey agency as well as the Center for Medicare and Medicaid Services. Next slide. Okay, so I tried to put it all in neat little boxes for you, but civil monetary penalties was one of, I think, of all of the enforcement remedies that CMS has, I guess, within their toolbox. The civil monetary penalty is, I think, one of the hotter topics in the amounts in which they are providing for civil monetary penalties. So this slide is all about that. So on the left-hand side, it talks about the range for the lower amount of per day civil monetary penalties. So what a per day civil monetary penalty means is that the Center for Medicare and Medicaid Services is going to charge you a fee somewhere between $50,000 and $3,000 per day every day that you are out of compliance with the requirements to participate in their program. Then you have kind of the upper range of per day. So same principle, it's just a larger amount. But again, you're going to be charged a per day amount somewhere between $3,000 and $10,000 for every single day until you achieve compliance with the requirements to participate in Title 18 and Title 19. The last type of penalty that they utilize is a per instance penalty. In these cases, it is a lump sum amount. It is not accrued over days that you're out of compliance, but rather a lump sum for the instance in which you're being penalized. Those range from $1,000 to $10,000. As the person who sees all those letters come through, I can tell you that I don't feel like CMS utilizes this as much as they do the per day ones. Next slide. Okay, so this one talks a little bit about the CMP calculator. This subject in general, I could spend all day up here talking about it. There's a 300-page manual on it, but in particular, this is its own special little rabbit hole. So I won't go too far into it. But so the Center for Medicare and Medicaid Services, when they are creating a civil monetary penalty for a facility, they are required to use what's called the CMP calculator. And this slide kind of outlines a little bit about what that calculator looks like, the inputs that go into it, and if you're kind of following, you basically kind of start at the top, and as you go into each one of those boxes, there's kind of questions on whether or not data should be input there until you get to the bottom, and it's going to spit out what the calculator thinks that the CMP should be assigned to that facility. Next slide. That's the end. Any questions on that?
Committee questions for Lacey. Representing Carpenter.
Of course, Lacey, you knew that. Well, I want to commend you. Every time I bring up this subject, you get a little more detailed, and this is a very good report, so thank you for that. So I continue to get correspondence with nursing homes out there, and I'll just kind of read one of them to you, and I won't read it to you, but I'll kind of go over some highlights. The current issue is the imposition of immediate jeopardy citations with KDAD survey process causing implications that will eventually lead to our application for receivership. They're perceiving that we've changed how as KDADs, has changed how they use the utilization of immediate jeopardy. And is there any truth to that?
So in particular, in this work, in the citing of immediate jeopardy, the work that we're doing is on behalf of the federal government. The federal government pays us to do this survey work. They tell us how they want that work done. They come out and follow our staff and then grade our staff on how well they're doing the work on behalf of the federal government. We have our last score from the federal government, so of the sample size of surveys that they reviewed our staff's work and whether or not they cited the appropriate citation at the appropriate place, we have 100% on our scorecard. So the federal government believes that in their mind, we have not made any mistakes in the citating in where we cite our sites at. We, in the last, I think it was last month, it would have been last month's Spirit Report. So I keep close tabs on all of the nations and the what's called the state performance standards. So every state, the federal government gives you kind of your rubric for what you're supposed to do as a state survey agency and how you're going to be graded on it. One of the things that the standards that they highlight in there is the national average for IJs and the amount of time IJ is cited on survey. Kansas used to be above the national average. We used to be around 6%. The national average is 4%. As of last month, we sit at 3.1% for the number of times we cite IJ. So we're actually almost a full percentage point below the national average for citing IJ now.
Thank you for that. So down in this email here, the implications of immediate jeopardy citations are severe, including fines, denial of payment, ban. We've already covered a lot of that. These folks are talking about potentially owing $400,000 to $1 million in fines from one facility.
Yeah. In some of those instances, yes, there is some really bad stuff that's happening out there, and people are getting fined for it. And in some of those cases, the IJ that is written, it is written in several instances. So for an example, an individual is abused in a nursing home. They're abused by another resident. They were hit. The nursing home did not report the incident as they're required to. The nursing home did not do an investigation into the allegation, and they did nothing about it. In that case, the Center for Medicare and Medicaid Services expects us to write that facility for 3 IJs. We are IJing them because a resident-to-a-resident abuse happened, and that resident was abused, so they're being cited there. They're being cited for their failure to do an investigation into the altercation, and they're being cited to IJ for failure to report, because if they're not willing to report when abuse happens in their facility, they're putting every resident in jeopardy of not reporting. And that is how we have had it told to us by CMS. But it gives a good example and a clear example of where facilities are seeing a change. Years ago, you would see CMS saying, you're only citing them 1 IJ for that same example. Now CMS is wanting us to cite 3 IJs for that same example.
That may be an example of what I'm talking about, that these guys are perceiving an increased use of IJs. Mm-hmm. So these folks are just bad actors and we're doing a great job. Is that what I'm?
We are not perfect. I am not one to think that we are perfect. Our grade card says that we're at 100%, but I take these conversations seriously. I've had a number of providers reach out to me, and I don't want us to be so good at our survey job that people are going out of business. That's not my intent. My intent, my staff's intent, I think the intent of the providers at the end of the day, we all have the same intention, which is to take care of the elderly within our community in a safe way. But I don't know how we can go about not doing what's required of CMS. So we're doing this work on behalf of them. It's not something that we get to make the standards for. We don't make the survey process. They have a standardized survey process that is electronic that we use, as well as every other state uses. But it is something that I do hear. I do keep a watch on it. I keep a watch on what the national average is for citing IJ versus what we are. I've talked in depth with Scott about maybe having a third party review some of our IJs and ensuring that we are writing and citing IJs appropriately. Happy to have transparency in any of that process. Absolutely happy to transparency or work and figure out how we can do something differently. But unfortunately, in this case, CMS is kind of our boss. We're doing this work on their behalf with their money. So if they say that we have to cite in 2 other places, we either cite it in those 2 places or they're going to cite it and issue it as well.
Sure. And I appreciate that. And I think it goes without saying that I'm not looking to put anybody in danger in our nursing homes and would never support that whatsoever. I do think there may be some leeway, and it should be applied, evenly across, the entire spectrum. I think some of these folks may feel like that, and maybe rightfully so, I'm not sure, you know what I mean, because they've had issues in the past, but I think a lot of them, not a lot of them, but quite a few of them feel like that they may be singled out, and treated differently than others, and that's a big concern of mine, both ways. We just want a level playing field, or they just want a level playing field, that they know what the perimeters are that they operate in. And of course, we're all for the safety of our folks. So I'm going to continue down this. I had a lot of folks contact me that would not put anything in writing because they were afraid of retribution and stuff like that, which was really disappointing because it didn't give me a whole lot of ammunition, so to speak, because they were like, yeah, we got problems, but I don't want to stir up anything. So it's out there, and I'm going to continue until I reach some kind of a basis that I can put this to bed and that we're doing a great job. So thank you.
We have had several facilities or operators reach out to us and have that same thread of concern. I will tell you, of the ones that have reached out to us, and we set up meetings, we want to hear their concerns, but of those, we have had large operators, small operators, for-profit and not-for-profit, all request that kind of meeting with that topic.
So when's it going to happen?
We've had those meetings. Every time they request, we absolutely have those meetings with them.
Okay.
I don't have any outstanding meeting requests for that.
Very good. Thank you.
Do we have a shortage of inspectors at this time?
Yes, we always do. I don't I don't know a time in my employment that we haven't had at least one vacancy. I would have to get you specific numbers, but last I knew we were somewhere around 35 vacant RNs.
Okay. Well, and I just know, Lacey, the inspection process is really tough, because we had at one point in time, and I was talking to Representative Ballard, and this would go back to Bob Bethell, myself, and her, that it was awful. I mean, our homes were getting hit left and right, and when the agency finally got into looking at things, it's like, yeah, we were kind of nitpicking. And so I think that has to be looked at, because I mean, human nature is just human nature. And when people aren't monitored, that's when they go awry. So just a comment there. Representative Fagg and then Representative Berquist.
Thank you, Madam Chairman. This is kind of a follow-up to what you were saying there. I was wondering, how often do you actually go out and do an inspection, and do they know you're coming? That's a couple of questions I had with that.
No. It is federally illegal for them to know our survey schedule. I would have to go look in the state statutes, but even when we do a state licensed only, in the adult care home world, all of our inspections are unannounced. Same with the state fire marshal when they come in and they inspect an adult care home. Those inspections are done unannounced. I would have to go to the chalkboard and get you a exact on state licensed only for the survey interval, but our federal survey interval is 18.1 months, I believe, is what we're down to. I think in the height of COVID, we were close to 23 months. So we've edged away at it. We're working on it.
Lacey, I was wondering, what is the biggest issue out of compliance, would you say?
For any level of tag or for a harm level?
Yeah.
Any level?
Yeah.
Food storage and labeling in their kitchen.
All right. Thank you.
Resident to resident, staff to resident abuse.
Thank you. Representative Berquist.
Yes, ma'am. Back to the resident to resident. Is the resident to resident incident, is that initiation for a citation against the facility itself, or is that just if they've ignored it?
Every incident is different, and we're going to investigate each one separately on its own merits. So it kind of depends. It kind of depends. It depends if when it happened, was anyone harmed physically, psychosocially, Was someone sent to the hospital, they were harmed so bad? Did someone die because it happened? It kind of just depends on each scenario and what happens within that scenario. But every scenario is surveyed separately.
Thank you, ma'am.
Senator Petty.
Thank you. And what does IJA stand for?
I am so sorry. I tried really hard not to use acronyms. It stands for immediate jeopardy.
Immediate
jeopardy.
And you just said about the resident-to-resident abuse situation. So, and I think I understand from when you were speaking earlier. So if the residency reports this incident, it's at a different level than if they don't report the incident, and then that could put them in jeopardy of another level of fine. Would that be correct? Is that correct?
Yes. So if you receive Medicare or Medicaid dollars, anyone that works in your facility is a mandated reporter. You are mandated to report any abuse, neglect, or exploitation allegation that happens within your facility. So when nobody reported as they should for the abuse to that part of that, that's when you would see that secondary citation because they did not report as a mandated reporter. And then the third one that you'd see that citation on is due to them not having done an investigation. As the survey agency, our expectation, if you can't stop resident-to-resident abuse always, sometimes it's going to happen. You're taking care of human beings. It's going to happen. But the expectation would be that, one, what were those residents' care plans? Was one of those residents already exhibiting aggressive behaviors and was supposed to be on a one-on-one? And were they on a one-on-one when the abuse happened? When it did occur, did the facility report it? Did the facility follow their policy and procedures for when they see an incident happen, and did they report it? Once it was reported to whoever their policy and procedures tell them to, typically it's either like the nurse on duty, the DON, policy and procedure within homes can dictate who they report to. They then report it to us here at KDADS. KDADS runs the 1-800 number for abuse, neglect, and exploitation in all healthcare facilities. So that includes hospitals, adult care homes, anything across the gamut that is the facility and not the community.
Thank you.
All right, committee, are there any further questions for Lacey, Representative Concanon?
Thank you, Madam Chair. Lacey, I'm not sure that you're the right person to ask this to, but I'm just wondering, is there any correlation between the reduction of use of psychotropic drugs and the resident-on-resident violations?
I have not seen anything to support that, but I have not looked either. The last thing that I think I saw that Center for Medicare and Medicaid Services put out that was in support of lower use of psychotropic drugs was directly correlated to staffing levels.
How?
Higher staffing levels equaled lower use of psychotropic drugs.
Which means that they can't restrain, so they give them. And that's an issue that
I understand that.
Representative Ballard and I have had those discussions because it's been an issue for many, many years, and we had really gotten it turned around. Then the shortages started happening. Then COVID happened, and that's when you saw it start sliding back up again.
Well, in our, I believe it was in the Senior Care Task Force, we had some discussion along the way that I guess we had a speaker, a physician from KU, that talked about the fact that it is necessary to have a little bit of restraint there when they're trying to balance out their meds. So it just made me start wondering about if they were getting violent. So thanks.
It's a tough population sometimes. All right. Seeing none, Lacey, you are off the hot seat until later. All right, next I've got Michelle Hayden, Commissioner, Long-Term Care Services and Supports. Welcome back.
Thank you. So again, I'm Michelle Hayden. I'm the Commissioner for Long-Term Care Services and Supports. So I'll start off by talking about the KU-CDD waitlist study. The final report in October will include survey results of the IDD and PD waiver waiting list, additional analysis and recommendations from the survey, and findings from the KU-CDD's analysis of existing administrative data, findings from the KU-CDD's analysis of national data collection, practices used in other states to manage waiting lists. There was a question about how much has been spent on this waiting list. The original study was $971,000. To date, $917,000 has been used, leaving a balance of just over or close to $54,000. So we go to the community support waiver. KDADS has brought on a contractor to assist in the development of a new HCBS Medicaid waiver, the ks.gov, as we are calling it, for IDD individuals. KDADS has hired internal community support waiver staff. The new waiver will help to address the waiting list for the current comprehensive IDD waiver, with over 8,000 Kansans served and more than 5,000 waiting. We have been able to reduce that a bit with the wait list offers, the 500 additional slots for the IDD waiver. The community support waiver will offer less costly services. There's a $20,000 annual cap per participant, compared to the average annual cost of approximately $66,000 per person for the current waiver in FY24. Services may include transportation, employment support, personal care respite, and various therapies. Due to network adequacy, a phased rollout is planned, starting with 500 participants funded by 60% federal match to 40% state funds. We want to serve 500 participants with the $20,000 cap. First, for our first year. Year two, 1,000 additional participants with a 20,000 cap equates to an additional approximate 21 million, all funds 8 million SGF. Fully implemented, a range of participants could be from 3,600 to 7,461, with a total cost ranging from 72 million, all funds, including 29 million SGF, to 149 million, all funds with 40 million SGF. Note that the part of the KU-CDD waitlist is to determine a more accurate number of individuals who could be served by the community support waiver. And we are requesting for the FY26 budget to fund 500 individuals to be served on the community support waiver. So here's our timeline. We've, August of 2023, approved approval from CMS to use FMAP funds to hire staff and contractor for community support waiver. The remainder of 2023, hire and onboard and community support waiver staff, draft the RFP to contract with additional assistance in development and application of the CSW. April through June of this year, chosen contractor will form and convene stakeholder groups, provide feedback to the state regarding services. July 2024 through next July, contractor will draft the community support waiver and expand the provider network. August of 2025 to September 25, we will have public comment. And October 25, we will submit the waiver application to CMS. They need at least 6 months to review it. So we hope to be serving the first contingency as of April 2026, if approved by CMS. So there are 6 buckets of work. We've been working on the waiver development. We've already begun drafting the waiver. We're working on the rate development, what rates we're going to be paying for each service. stakeholder engagement. We already have had a town hall at the end of July. Almost 300 stakeholders attended to talk about the community support waiver. We have a technical advisory group that will start meeting this week. And this is about 31 individuals from the provider community, from the advocacy community and families to help advise us on building this community support waiver. We have CMS engagement, and we've already been talking to them about this new waiver that we're working on, so they're very much aware of that. And then we will have public comment and CMS review. And then there's IT systems changes, what we need to do to put the right codes into the Medicaid system so that our providers can be paid. So we have been drafting the waiver application and drafting service definitions. Community support waivers website has launched, and you can go to that website, www.kansascsw.com. First, we did hold the first town hall, and as I said, we have a technical advisory group that is meeting this week to help advise us on how to improve the IDD system. And that's what I have for now. Do you have any questions?
Representative Carpenter. I know you're shocked.
Yeah, I'm shocked.
Yes.
Michelle, of course. Thank you for all your hard work on this, and I would ask the committee, whenever they can, to get behind this waiver, talking to folks or whatever. I'm a little disappointed that they have a year to write the waiver. We should have had that done in a couple of days, don't you think? But anyway, it's on the board. I know, but I'm really impatient about getting this done. But it's going to be a good thing, and I really appreciate. And I also got on board during this session. I met with the KU folks, and I think I bagged on them pretty good at one of the meetings, and we kind of smoothed that over. I understood where they're coming from. So thanks again for you guys for putting that together, and it's going to really help our ID population to monitor the status of these folks and what services they need. So the only thing I can say is it should have been done yesterday.
Committee, further questions for Michelle? Representative Reese.
I'm with Representative Carpenter. I can't believe it's taking this long. And I know anything that has to do with CMS takes forever. I get that. It just, boy, I just wish we weren't having to wait this long. So anyway, just throw my 2 cents in there for that.
Thank you.
Any further questions? All right, seeing none, thank you, Michelle. Appreciate it.
Thank you.
All right, next we have Drew Adkins, the Mental Health Intervention Team update. Welcome back.
Thank you, Madam Chair, members of the committee. Appreciate being welcome back to talk about our MHIT program. So we'll go over a little bit, we'll go through an overview in the first couple of slides, and in the second half, we'll have some specific updates of where KDADS is at after inheriting the program this past legislative session. So again, just as a refresher, the Mental Health Intervention Team program, also known as MHIT, is dedicated to improving each of its students' overall academic potential by breaking down barriers to mental health services to those who need it most. Under MHIT, the school districts employ school-based liaisons, and they identify students needing intense mental and behavioral health services, and they link them to local mental health and behavioral health providers, or those providers that have those services available. MHIT currently, the program has 90 school districts, and they're unique. Each of those districts' programs are unique to customize their program to fit the needs of their students, their families, and their communities. Thank you. So the MHIT pilot program was established in 2018. This, again, was to address some challenges that schools were experienced through an increased need of students and families that were asking for and needing mental health services. The 2018 Kansas Legislature approved a proviso authorizing initial 9 school districts to enter into agreements with their local community mental health centers to provide these school-based services. The Kansas Department of Education successfully launched a program that continues to this day to receive a lot of praise by all, and 7 years into this pilot program continues to have that. We appreciate their leadership, certainly, as we inherited that successful program at KDADS. Again, to date, MHIT program serves over 90 school districts across the state. And the school-based liaisons, or the SBLs, work in over 400 school buildings within those districts. Just a little bit of data here and some indicators to go over with you all. So during the, you'll see in that second paragraph, during the 2023 and 2024 school year, the KSDE data portal, which they have internally to their agency, indicates that the program provided nearly 7,000 students with individual school-based behavioral health services. This number also includes nearly 600 students that were in or are in foster care. The data monitoring, KSDE continues to maintain the MHIT data portal, which monitors the progress of MHIT students, which KDADS did get access to. We're very thankful for that. The school-based liaisons and their service providers identify and track indicators of concern, all of which impact their school success. Those indicators that are being monitored are academics, attendance, internalizing behaviors, and externalizing behaviors. So to talk a little bit about some of the changes to MHIT, Madam Chair, I might ask for a point of personal privilege for an introduction really quickly. We have Angie Brungart, our new Mental Health Intervention Team Program Manager, if you'll stand up and wave to the committee. So Angie came to us, and we're very thankful that KSDE gave her to us because she has been hitting the ground running. I think that we've had her on board now for a couple of months. So she'll be our dedicated MHIT program manager within the Behavioral Health Commission. We will also bring on an MHIT coordinator to help her out. Those 2 positions will travel the state, providing technical assistance, meeting with school districts, monitoring, doing whatever they need to, especially, and we'll talk about this with some of the changes, as we've expanded funding to the program to include more school districts as well as some qualified school districts, also known as private school districts. And so, I mentioned this before, but with the fiscal year 25 proviso legislative changes, the program moved from the Kansas Department of Education over to KDADS within the Behavioral Health Commission. It did expand the funding. It added for the USD population, expanded funding, and the qualified schools to $4.5 million. That's on top of, I think, roughly around $13 million. And so total program funding is right around 18 to 19 million right now. It did include a qualified school program startup. Again, that was 1.5 million that was included in the expansion funding. There is a requirement in the proviso that was passed that the Secretary of KDADS put together a qualified school board monitoring board to evaluate the proposals that would be submitted to the agency for those funds. It also amended a current practice on the funding levels. The school districts now retain 65% of the grant award and pass on 35% of that to their mental health providers. In the last 8 weeks, MHIT has settled very comfortably into the Behavioral Health Commission. It's located in our Children's Division under the direction of our Children's and Prevention Program Director. And on the next slide, you'll see some of our changes with the qualified school district, just a quick definition of that. We do have a fair amount of interest already from this entity and this being added, so we're excited about that. This could be a school that is a non-public school providing education to elementary and secondary students, accredited by a state board, a national or regional accrediting agency recognized by the state board, and satisfying the teacher performance assessment for professional licensure or is working in good faith towards that. I won't go over this in its entirety, but we did want to highlight what the requirements and purpose of the MHIT qualified school boards is. There are 7 members to that board. There are positions overseeing, responsible from our mental health professional, from CMHC. We also have a licensed mental health professional requirement from our federally qualified health centers. We have lived experience, or specifically those that would be a caregiver or a parent of a qualified school student as well. We also have a KDADS representative and a KSDE representative there. And we are actually at the, I believe, in the final stages of that. I believe we're only looking for one more position, and that's a licensed psychologist from a qualified school district. And so on this next slide, we'll go into some program implementation successes. The initial program goal was to transfer the program, the MHIT program, with minimal negative impact on the school's program within its staff, students, and their families. One of the first things that we did after getting this program settled within the Behavioral Health Commission is made sure that the existing school districts that had funding the previous school year were taken care of. They already had existing structure, relationships, and services out there to the kiddos and the families and the community, so we wanted to make sure there wasn't a hiccup in the transition. I'm happy to say that we can report back that there has not been any hiccups in that. Mentioned again that Senate Bill 28 includes the $13.5 million in funding for all the pre-existing unified school districts. This included over 90 districts and over 20 community mental health centers, several FQHCs, and then some other private providers as well. Just a quick snapshot of where we're at 24-25 school year for the pre-existing unified school districts. We have completed the MHIT application process and are in the pre-approval for the award status there. All of those school districts will receive and have received and will sign a memorandum of agreement between the Unified School District and KDADS, and that's due August 31st. And they will also have a memorandum of understanding, or an MOU, between the school district and the mental health providers that are due on the 31st back to us at KDADS. I believe we have done, this is kind of continuing on to what I had mentioned earlier. We have notified all the non-MHIT unified school district superintendents and officials of those districts that haven't been a part of the program to let them know that we have expanded funding. An opportunity for that. We obviously want to get those dollars out there to have more services in the state and make that as saturated as possible. So we have done that. All right, and I think this is our last slide here. We'll highlight that it's an innovative program. Again, we're very excited to have the program at KDADS and see that as being a success, and we're excited to continue our work with KSDE, who has championed this program. And wanted to include this direct quote here that the therapist that this individual MHIT student had, the quote that she had was that it saved their life. And so we wear that. Again, we're very excited. We've created and postured positions within the commission to make sure that we have that external facing and the internal importance as well. And I think with that, I'm happy to stand for any questions. Thank you.
One of the things, Drew, I noticed in your slides is when you mention the number of school districts, I think it would be important to mention the number of buildings as well. Because I think sometimes people think, oh, we're just doing 90, but when you start dividing that by the buildings, it makes a lot more sense on a visual.
Yes, Madam Chair, happy to do that. We did mention the school-based liaisons are working in over 400 school buildings, but are you mentioning how many different buildings in the districts that have presence? Okay, yep, we can do that. Happy to.
And I actually overlooked that 400 in here, so that's on me, too.
That's okay. That's all right.
All right. Representative Berquist.
And we do understand what you mean by pre-existing USDs, but for the record, people that are listening to this, if they understand that pre-existing in the program, in the original group of, in the program, USDs in the state that were involved. So existing USDs, they're all of them existing, but 90 of them were in the initial group. Is that correct?
Madam Chair, Representative, that is absolutely correct. Thank you for correcting me there.
No problem.
90 of them would have been in last year's program. Yeah, the original was 9 districts. Further questions for Drew? Senator Baumgartner.
Thank you, Madam Chair. Quick question. What's the status of the 988 call center in Lawrence right now? Do we know?
Madam Chair, Senator, are you speaking to the suicide prevention headquarters?
I am.
If it's all right, if I can elaborate on the status, are you asking if there's, well, I might have Deputy Secretary Andy Brown answer that.
So just
Senator, I'm sorry, Andrew, is that we do have something coming up on the 988 discussion, but if you want to have some now, that's fine.
No, we can do that later.
Is that good?
Yep.
All right. I'm gotten a little bit behind. We didn't allow enough time, I think, for the questions that we had this morning. So, Andrew, Drew, excuse me, when you and I had a discussion here just a few weeks ago, and I think that there's a little bit of concern that's not going to impact this year, but I think their future years, and that's on that database, because it was created by KSDE. And I can't say enough about the partnership that KSDE had in this process, because we couldn't have done, and I know there's a lot of people that dislike Dale Dennis, but Dale Dennis actually brought people out of retirement that got very excited to help put this program together. And the work that Diane Jerstead did in the beginning of traveling this entire state, and every week we were hitting problems in that initial pilot, and we're able to solve them. We didn't have to wait for the next legislative session. So it's just been a great accumulation of everybody working together. There was a lot of people that were concerned with the program being part of KSDE, and that was part of the reason that the move happened over to KDADS. And I'm hoping that, because I understand that there may have a law on the books, and we may have targeted back to a legislator out of Arkansas City that did some privacy issues, and I think we need to get a better understanding of what that statute is. So if you can present that to us, I think that would be good. And look at it, if it's something that we need to tweak, or if we can get a commitment from KSDE to keep in mind that I think it's 65% of the funding still goes to the school districts, and that this is all about children, and that we need them to continue the partnership that the state is having with them and forget about ownership. And that was one of the other things, because the first year that this program was put into place, we were crossing money about 3 or 4 different agencies. Now, we've simplified it since then, but it was very complicated. And not one time was there ever a turf battle. And I don't want to see a turf battle today or tomorrow. And this isn't against you guys or anyone else, but I just want people to be very clear. This is about children. It's not about who has the program. It's not about who administering. And KSD is still a big part of it. They benefit from it on a financial level. Their kids benefit from it, and their parents of these kids, because this is true wraparound family services in this program. So I just want that clear. And I want to stay up on the, where we're at with that database, and as we're moving forward and the discussions that occur. So.
Madam Chair, members of the committee, absolutely. And for the record and for what it's worth, KSD and KDADS have had ongoing conversations. Again, they have been very generous. I believe KSDE has a representative here to contradict anything that I say if that's necessary. But they have been very open to keeping the data portal available for us. They remain open to helping us through this in the long, both in the short and the long-term solutions. And so on the Kansas Data Privacy Act, I think I heard you mention that. We can definitely make that a priority for the next presentation to report out on what that looks like.
Okay, that would be good. Further questions? Senator Erickson.
Thank you, Madam Chair. Thank you, Drew. This is very helpful to see updated numbers and appreciate the presentation. So I'm going back to your student served data that 7,000 students were served. Are those students who were, do you know, you may not know, and that's fine, were not receiving any services before the program? Do you have any data about how many new students have been served because of the availability of the services at school? Do you have any information on that?
Madam Chair, Senator, that's a great question. Just to clarify, are you asking unduplicated students served year to year? Is that the question on if they're receiving services year to year, if they're a new student that year?
No. As a former school administrator, I know that we provide some level of services, behavioral services, or we refer students as students. So I'm just wanting to ascertain the number of additional students that are receiving services. So those 7,000, I'm guessing some of them were already receiving some level of service before potentially. So I'm just wanting to see if you've looked at the data, before the MHIP program and just the number of additional. I would assume that a lot of these are new because of the availability at school, but I just don't know that data.
Madam Chair, thank you, Senator, for the clarification. I don't have that with me today. I have that same hunch and assumption, but I've gotten in trouble for that before, so I don't want to do that. So let me take that back and see if we can get that for you if we have it.
Thank you. And if I may, Madam Chair, just one other follow-up real quick. So I know that this is for students, but trust me, as a former educator and from my teacher friends, they're also struggling with issues that are related to mental health around what happened during COVID. Is there any plan to perhaps provide wraparound services for staff or not through this? Thank you, Madam Chair.
Madam Chair, Senator, thank you for the question. That hasn't come up yet in our conversations, but it's probably well worth at least a conversation and discussion to see what that would look like.
Well, and I do know that some districts, and because I know that during the CSG meeting that was held in Wichita here, 2 years ago, that 259 Wichita gave a presentation and talked about additional mental health services that they were providing to staff, because they would agree with you that that is an issue for staff out there.
Thank you, Madam Chair. And if I may, I do want to give a shout out to those districts, 259 being one of them. When I was an educator and an administrator there, they were very good about providing mental health services to staff, no questions asked. We had that available. But I know that's maybe a luxury that a lot of other staff members out there do not have, but I do know 259 has done a great job with that. Thank you, Madam Chair.
And I do think it becomes a cost issue, and I think what 259 was worried about is they had used ARPA funds for that. So one-time money for something that's going to be ongoing, and I don't know where they're at this year. I have not followed up with that, but it's a good question to take it and look at out there. And I think that, the reimbursement rate on Medicaid for school districts on providing services is a lot less than if you move it outside of the schools, because they can only build so many codes and their rate is very, very low. And I mean, sometimes it's pennies on the dollar. So that was the other benefit we saw of moving this program outside of what the school was actually doing. And number two is the providers of the services are actually able to also bill private insurance on top of it. So they bill Medicaid, private insurance. Then there's also a small amount of funding that goes in here for the uninsured children that we deal with. So no one is denied this benefit irregardless of the ability to pay. And so we've actually been able to expand, I think, mental health services without it all being, necessarily put back onto the state. And when you look at the data, and you might bring that spreadsheet on the quarterly report that's given every quarter, to look at the improvement of whether it's less disruptions in a classroom, less tardies, less absenteeisms, graduating, because some of these kids weren't doing that. And then we've also learned going through this process is that we have kids becoming more aware, because still adults have a little bit of inhibition on the idea of dealing with mental health, is that the kids are coming in and say, my friend Johnny needs some help. And so then the liaison can go out and have a visit with Johnny, indiscriminately, so it doesn't become a big deal. It's also proven to be a nice deal in our small communities, because when you show up somewhere, everybody knows your business in a small community. By going to the school, they don't know that you're going in there, because these services, a lot of these school districts are staying open till 6, 7 o'clock at night in order for the parents to come in and participate in programs within the school. So it gets a lot deeper, I think, than what people have viewed this program. I will say that it's one of my sad points is that we were not able to get this put into statute, that it's been a proviso every year that it's been in place. Because if this program goes away, a lot of children will be hurt in Kansas. And the private schools came to us, and they were spending their ARPA funds to provide these services, and now their ARPA funds are done, and they didn't have another place to go. And so that's why we looked at putting the private schools in there. It's up to them to make those decisions. I know that I had a legislator ask, he said, well, but don't they have to be Christian counselors? And it's like, I'm sorry, I don't go to a professional, whether it's a dentist or a doctor or a counselor, and say, are you a Christian? I'm like, are you the best at providing these services? And the private schools are fine with entering into this program. I know that during testimony in the Health Committee, Representative Reese had some great questions during committee and even after with them that I think put some things to ease for her on these students. And I will give a shout out to the governor, because she did originally veto the program in the first bill. She left the money, but the legislature wasn't going to hand any agency $14 million without guide rails. And when I asked her why she did it, and her comment was that, well, the private schools. And then I reminded her that during her State of the State that she said 90% of the kids in Kansas go to public schools. And should we tell 10% of the kids that because they don't go to the right schools that they don't deserve the same services? And I felt very fortunate that she agreed with that, and we came up with a really good compromise, and I hope that we see that continues. So anyways, for any legislator that's willing to take and carry the gauntlet on this, and at some point to get it into law, we did get it out of the House with 112 votes, and I think it's a great deal for Kansas. But ask more questions. Understand this. I understand it because I was there from the very beginning. And I don't know that I wouldn't have the depth of passion for this if I hadn't talked to the liaisons. And I think during the legislative session, as committees work through this, which I hope they'll hold hearings on it, bring in some of those liaisons. Because when you hear their stories and the lives that we have saved, I always go back to one particular story of a young man that they noticed he was acting strange for a couple of days, and so they monitored him. He was part of the program. And then they got a little bit concerned, so they had approached the parents. And the next morning, this young man brought in 4 coffees to hand to 4 special people in school. And they realized that he was telling them goodbye, because he'd planned on killing himself that day. And we can't count on one hand or 2 hands the number of kids that have been prevented, and the fact that sometimes those tips have come to the schools from law enforcement as well in some of our different communities. So I hope to see this go forward, and just don't let it die. Further questions? All right, seeing none, I'm done.
Thank you.
Okay, now we have Gabriel. Is Gabriel Hall providing testimony? Nope, those are all just part, okay. All right, so now we have the, Lacey, are you able to come back, or do you need to do your piece this morning?
I can come back.
Oh, we would love for you to do that. So we'll take you up first thing when we come back from lunch. Is that all right at 1:30? And then committee, you'll notice that we have written-only presentation by the KanCare ombudsman. And that will take and conclude where we're at for this morning. So we are recessed until 1:30. going to go ahead and get started. And Lacey, we've got you up first. Will that be on the, is that separate testimony? Okay. We'll find it here. Thank you for helping us out earlier today. Go ahead.
Okay. All right. Lacey Hunter, Survey Certification Credentialing Commissioner for Kansas Department of Aging and Disability Services. My last topic of the day here for you all is a topic that I was tasked to do and my commission was tasked to do based out of some budget proviso language. So what my commission is up to for this next fiscal year is we are reaching out to and having supplemental healthcare staffing agencies register with my commission. They pay a fee. It's $2,035. And then we are still in kind of the registration period, but beyond the registration period, we will have quarterly reporting. So beginning in October, we will see that first quarter of reporting. This first slide here kind of depicts some of the bills that had some language that was similar to in the past that required either some sort of oversight or registration of staffing agencies, but they did not make it through the legislative process. This past year, through both Senate Bill 28 and House Bill 22551, there was language put, as you can see on this slide as well as the next slide, the language that was put into both of those bills that requires this registration of healthcare staffing agencies and that be done by our agency. If you move on to the next slide, I have a little bit of a timeline here of kind of what our efforts have been within my commission to get this up and running. My commission actually took away three kind of homework assignments from this past legislative session. We had this, we did CCRCs, and we also did discharge reporting for adult care homes. And so within that, I then went to, I have 4 direct reports, and 3 of those 4 got a project, and Tabitha Mojica is the winner of this project. And the reason why is because Tabitha oversees our health occupational credentialing part to our commission. And so within that, we already had a decent portfolio of healthcare staffing agencies that had been in contact with Tabitha and her team to do criminal record checks for their staff and the staff that they provide to adult care homes. So that's kind of where our arrow starts here is in June. Tabitha, she went back through the contact information and database we have for our criminal history record checks and pulled out all of what appeared to us to be healthcare staffing agencies. She identified a little over 200, and we started with sending a mailer as well as an email kind of giving everyone that we knew of a heads up of this new proviso.
In June?
In June, yes.
I think they would differ with you, but I'm just going to say that. Okay. Go ahead.
In July is when we started receiving applications, started receiving fees. It is also when we published some information on this requirement in our Sunflower Connection and also discussed it and talked about it with all of our stakeholders at our monthly stakeholder meeting. We have asked, and if anyone would like for us to ever present to their members, we are happy to present on this topic to any of our stakeholder members. But that kind of gets us to where we're at today. I actually talked with Tabitha this morning, so my next slide gives you as of August 7th, but as of this morning, we've actually had 91 healthcare staffing agencies register with us. We are thinking this is the bulk of what we are going to receive for applications, and we are hopeful that we will have this published list online available to the public sometime either this week or next week. And then within that first reporting period that we have in October, you will then start to see published reports on the information that they're required to provide to us. We have set up a email inbox. You've heard me talk about Tabitha a little bit. She has been our main point of contact and really the reason everything has gone so smoothly thus far. But we will also be providing a comprehensive report as directed within both of those bills to the legislature in 2025. That's about all I know so far and have so far on this endeavor. Like I said, we still haven't had our first reporting period, but I will stand for questions when appropriate.
Committee questions? Representative Carpenter.
I think this is one of those ones why we're making such a concerted effort to make sure some of these provisos are properly vetted. But anyway, so Lacey, what are you going to do with that $180,000 you've got?
We haven't done anything with it right now. The proviso states that it goes to the state licensure fee fund. That fund currently has quite a few things that come out of it. Salary for some of my staff, I do believe, at some point comes out of there. But I think the idea is we want to see kind of after that first quarter what the workload is, and if Tabitha can really continue to kind of volunteer and do this as a side project, or if we need to look into creating an FTE to oversee this program. And then that money would go towards supporting that FTE.
So then this would become kind of a tax?
Yes.
It's okay. Yeah, it would.
It is something that I mean, I think we've been successful in what we've been tasked with in doing. But it is extra work for my team at this point, but it is stuff that we are able to get done without any other areas hurting.
Thank you.
Committee, any further questions? How many did you say are out there?
I can't give you an answer to that infallibly. But I can tell you that when we went through our criminal record database. So anyone that's contacted Tabitha and her team to have a criminal history check done, which is required that you have them done through Tabitha and her team for anyone who works in an adult care home. And we identified about 205 to what we thought to be healthcare staffing agencies that were operating in Kansas. And so of those, about half basically have registered because we're at 91 out of 205.
Oh, 205. 205?
Yes.
But you're saying you've got 50.
When the slides were due, that was the amount that we had registered.
Have how many now?
As of this morning, we have 91.
Oh, okay.
That's how I got to 180,000.
Ah, all right. And for those that don't do it, there's no penalty or consequences, correct?
No.
All right. Because I know that, we were getting some stories that someone, not from your agency, was telling their staffing agencies that if they didn't sign up for it, that they couldn't come in their facilities, and those were in western Kansas. And my first question was, where are they going to get staff?
No.
And so we need to make sure no outside entities are, putting pressure on the agencies to do that. Because I'm with Representative Carpenter. This is an unnecessary tax. And the email that went out was actually the Friday before it went into effect July 1. That was ridiculous. And I'm not trying to beat up on you. You're just the messenger, and I get it. So, any further questions, committee? All right, seeing none. Thank you very much, Lacey. And again, Susan, excuse me, Representative Reese.
I just wanted to make sure I understand this. The entities that have registered, these are staffing agencies that nursing homes have been able to contract with? Is that?
The bill requires that if you provide registered nurses to not only nursing facilities, but also hospitals, really it's healthcare facilities, that you as a staffing agency must now register with us to meet the requirements of this proviso. But Representative Landmer was correct. There is no penalty for not registering, and there's also no penalty to a home or a hospital for utilizing a staffing agency that did not register with us.
Okay, thank you.
Any further questions? All right, seeing none. But again, I want to thank you very much for accommodating us. And you're always great and forthcoming with all of your answers and stuff. And I know sometimes we give you hard things, and when you don't answer, we know that we've given you a tough question that you probably shouldn't answer. So thank you very much. All right, now, let's see, we've got Christine Osterlund, the Medicaid Director and Deputy Secretary for Agency Integration and Medicaid, KDHE. Is Christine here? There she is, back there in the corner. You're always back in the corner. What's up with this? Oh, wait, no, usually you're over here. What was the, well, then don't confuse us.
That's right. Keeping you on your toes. You never know where you'll find me.
Honey, it's not good for me to be on my toes. Go ahead.
Christine Osterlund, Deputy Secretary for Agency Integration, the State Medicaid Director. We just had one item that was open. We provided a written update. Essentially, the core sets were provided to the committee back in February. I don't know if there's any additional questions on them. Yes. It's okay. Yes.
All right, so committee, she's got, because I think originally you were going to be written only, I think. So you've got a letter in here on the digital, and you've also got the spreadsheets are out there digital, but we have this copy. So the first item, when you open the spreadsheet up, she's on number 3. So now I don't know why it takes us time to figure out the spreadsheet every time. You'd think it was new to us.
I have to figure out which way to turn the pages. So I'm with you.
Everybody staples them different. It's confusing.
Exactly.
Okay, all right. Thank you, Christine. Go.
All right.
Okay, if you don't mind starting over, I'm sorry.
Okay. Yep. So the our one remaining open item from last meeting was on the core sets. I had provided the committee previously with what all the core sets measures were for 2024 for both adult and child. We really don't have any other update unless there was any specific questions. And of course, I know we provided them a while back, so if it would be helpful, we could resubmit them to the committee too, just so you have them again.
Where we're lost right
Okay, so there's CMS measures that they put out around data for adult and children that the state Medicaid programs have to report on. So I'm happy to send those PDFs back over because I know it was a few months ago, and then that way you guys can refresh your memory. And then in October, if you have any follow-up questions, I'd be happy to answer them.
Okay, yeah, and then we could look then whether or not we keep it on the list or take it off of the list.
Excellent.
All right, thank you. We were too easy on you. Do we have you tomorrow too?
Yes, I am back tomorrow, so.
Oh, Representative Carpenter.
Thank you, Madam Chair. So I had asked earlier for that, and I don't know if this is appropriate time or not, but it's in our packet from a gentleman named Patton. And so would it be appropriate to put this on the list or just get it, let us know what's going on with that?
I can provide an update if you'd like. He does disagree with our policies, which are actually CMS policies, not state of Kansas policies around eligibility. He did request a fair hearing, and the administrative law judge did rule in KDHE's favor that the case was processed correctly, the share of cost is correct. And again, I understand that from a family perspective, where our thresholds are and what the rules are can be very taxing and put a family in a stressful situation, but the case is correct.
So we're done then? Okay.
Unless something would change with, obviously, their family situation, and we've made him aware of that as well, that if anything changes, to submit those changes to us, and we're happy then at that point to relook at the case.
Okay.
So you're good?
Yep. Thank you.
All right, thank you very
Thank
much,
you.
Christine. Okay, Andy Brown, you've been waiting for us all day because you're so excited to be here. Welcome.
Thank you. I'm happy to be here today. I'm going to be starting on page 5 of the spreadsheet, which are the issues that are assigned to KDAD specifically. And the first item on that list is number 2. It's a need to develop models for intensive community support as an alternative to incarceration for the IDD population. Our update on that is kind of lengthy, so I'll kind of hit some highlights on it. But over the last year, we were able to implement successfully 6 different IDD crisis stabilization projects around the state. 2 of those projects have initiated community assessments of IDD crisis services. Others have focused on training. We do have our fiscal year 25 project contracts that are pending vendor signature and are approved by the secretary. All 6 of the fiscal year 24 vendors will continue to provide their training activities. And Lake Mary will distribute training brochures and videos to law enforcement agencies, as well as to family caregivers. And then we also have a vendor award that's pending for mobile crisis training and enhancement of support services for individuals with IDD. So this will provide statewide training for IDD professionals, first responders, and others that might want to work to help us prevent and stabilize crisis events. Any questions about that one?
Committee, are there questions? I think we kind of covered it earlier today on some things in more detail, so I think that was really helpful. But I would like to point out, committee, this is what makes this spreadsheet so important. If you look at when this issue started, it was from the 22 spreadsheet. But it allows us then to stay informed and not forget things and let them drop through the cracks, which sometimes I think the agencies hope will happen. But it's really good. But I appreciate this, and I think we're very excited to see this move forward. So we'll keep it on the spreadsheet for now and follow it and see where it ends up.
Yeah.
Thank you.
Sure. Item number 3 is a fairly simple one. This is around adopting language for the assistive services. It's similar to Technology First states. We do currently have a task order that's been posted, and we're reviewing the questions from potential bidders about that. So we're hoping to move forward with that process here soon.
All right, and I think we'll keep that one so that we see where that task force ends up at. And, and committee, if I say we're going to keep something or get rid of it and you object, just let me know. Otherwise, we'll just move through it that way. Huh? No, I'm not even going to ask you. Okay, continue, Andy.
All right, so for number 4, this is around a audit about the KMIS program. Our internal processes on procurement are continuing. We're trying to identify the provider that's going to help us with that analysis. So that's a continuation.
This is another 2022 spreadsheet item. So when do you think that this will all happen?
Well, again, it's sort of in our procurement house at the moment. We're trying to get through the RFP process, and it takes time. We've had to reissue the RFP a couple of times, and it's been lengthy.
Why do we have to reissue it twice?
If we don't get the responses that we're looking for in the RFP, then we have to turn around and adjust the RFP and put it back out again.
All right, we'll keep this item.
Okay, and then
Something's moving forward, so that's a good thing.
yeah, I mean it's progress, not perfection yet, right?
Mm-hmm.
So for number 5, this is around the ABA therapy stuff, which we've talked a little bit about already today, but just as an update on where the policies stand, those have now been posted to the KMAP website, and so that step of the process has been completed.
Committee, are there questions? Do you want to keep it? Will? Number 5.
Which were you looking right here? This one here? This one? 2022?
Mm-hmm.
I think we should keep it.
Keep it? All right, keep it. Number 6?
So number 6, this is around respite care. So right now, and I think I mentioned this earlier today, but we are looking for a new TA manager position. That's going to be separate from the SED manager, program manager position. That position has been posted. We've had some candidates that have applied, and we're currently working on scheduling interviews for that position.
All right, I think until we see it completion, we'll go ahead and keep it. So I think that's all your items, is that correct? No? Oh, there you are, page 7.
So, yeah, I was going to say, I've got stuff on 6 still to go, and I think I've got some stuff on 7 as well.
Okay, go ahead.
Okay. So item number 7, this is around what services are reimbursable by Medicaid and hospitals. Our update here is just that KHA presented to KDADS at our stakeholder meeting with a proposal to have KDADS request funding to pay for care provided in hospitals until long-term care placement can be secured. And they've requested KDADS develop solutions for placement in appropriate long-term care settings for Kansans. So we're evaluating that now, through our budget enhancement process and trying to make determinations about what we'll submit for that.
So you believe that there'll be a request for the governor's budget?
At this point, I would say I'm not certain.
Okay, we'll keep it.
And then for item 9, what statutory or policy changes are needed to reduce wait times? KDADS is working with Wheat State Healthcare to expand our outpatient competency evaluation and restoration treatment in the community using the CMHC network. We're also working on a number of pilot programs between Lawrence State Hospitals and jails in Johnson County, Shawnee County, Lyon County, and Geary counties, and a county-run project that's occurring in Douglas County. Our governor's advisory panel on the South Central Regional Hospital is recommending the governor or legislature request Criminal Justice Coordinating Council or the Judicial Council initiate a thorough review of the Care and Treatment Act for mentally ill persons and propose changes to the involuntary commitment statutes for the 2027 legislative session. This review should include identifying processes to prioritize individuals in crisis that are screened for involuntary care and treatment to ease the strain on law enforcement resources.
I think on this one here is, I think that the committee can write a letter to the Judicial Council and make this request, if you guys are okay with that, and if the committee is in agreement with it. That just expedites things. So staff, if you'll do that for us, and we'll get that off to them. Yeah, no, no, it's not coming off.
All right, so moving on to number 10. This is about the antipsychotic drug use trends that were brought up earlier this morning. And again, like we have information that you saw in the survey certification and credentialing commission reports that were part of our agency updates. So you can refer to those slides and get more detail there.
You know, I don't know, committee, if there's really a benefit for us to see this on a regular basis, because it's not going to change till staffing changes. Do you want to keep it or take it off? I would remove it, but that's my opinion. I would remove it, but I'm asking the committee's opinion. Will?
Yeah, I don't care.
I don't care.
I'll be on it anyway.
Well, it can always be added back at another date if we see something. Yes. Because there's nothing really new that takes and comes to us on that. Because we know that all of it revolves around staffing, as much as we hate it, but it also is to protect the individual as well as those around them.
I, for one, will keep
Huh?
bringing it up.
That's fine.
Bringing it up. We don't
Okay.
need it on here.
All right, okay, that's fine.
Yep,
Well,
number
just so you
10.
know, we're not downplaying it and say it's not worth following, but it's just one more thing to remove off of the list. Okay, go ahead.
All right, so number 12 is about the BI waiver. So currently, our wait time for therapy seems to be holding at about 1.5 to 2 months. Our institutional transitions tend to move quicker because they develop discharge plans before they leave. The number of months between the first day coded for BI and the billing from the HCBS provider are listed there. As you can see, most of those are occurring within or shortly after 1 month. And then our total number of participants was 36, and there were 3 participants who were transitioned off for multiple reasons.
So Andy,
Yeah.
do we know if we're causing an issue if we're not getting to them sooner than a month? Because I know the sooner that you start treatment with them, the more opportunity we have of helping them improve a lot.
Yeah, I mean, I think our goal is to try to make sure that it's happening as quickly as possible for those reasons.
Okay. Do we track if we have individuals that have been on this for an excessive amount of time?
So we do track, and I think the numbers here kind of reflect that we're trying to track that based on how long they've been on that, how much time has passed between those points of receiving the service and being identified for the service.
Well, because I'm like, do we have people that have been on here for a year, 2 years, 3 years, 4 years? Because at some point, you reach done. There's no improvement to be made. And I wonder if we don't have people that fall through a crack because either as an agency or as our MCOs, it's not being tracked properly.
We can take a look at that. I believe that if somebody is on the waiver and not receiving services, there's a timeline that the MCOs track. And then if they've gone, I don't remember what the cutoff date is, but after a certain number of months with no services, they get flagged. And then that gets sent to KDAS and KDHE to make a determination on if that was because they're not using the services or because they don't have access to the service.
All right, Representative Carpenter?
Thank you, Madam Chair. So that's exactly correct. So, and Steve is behind you there. He could tell you what, I think it's a year, isn't it, or something, that if they don't receive services in a, excuse me, Madam Chair, for asking him. Is that okay?
You're fine. Yes, you're fine.
Okay.
Steve Anderson, Medicaid Inspector General. Actually, if they're supposed to use a service per month to maintain eligibility on the waiver program, it's not a year, it's 1 month.
Okay. Thank you for that. So I'm looking here at your notes here, and it says we currently have 58 individuals showing not having therapy services. Is that not having therapy services because they can't get them, or is it because they just haven't received them?
We'd have to look at the case-by-case basis on that, but I believe the answer is both.
That was in the second quarter responses where that came from, Andy.
Yeah, so I'm just curious if those folks are being counted as brain injury waiver folks, or how they're being counted, not receiving services.
Yeah, but I think the 58 number was people that were on the waiver.
But are not receiving services.
Well, at that time. So that was our last quarter response. So in quarter 3, the total number that we had in the count was 36. So we went from 58 to 36 in this quarter.
But they're, okay, so moving on down, so then 36 people this quarter are not receiving services.
Yeah, or haven't since they were identified.
Okay. And are they being counted as brain injury waiver folks?
I believe so, yes.
But they're not receiving services?
They haven't received a service since they were identified as a BI.
I'd just be curious about the timeline of that. You know, and I agree with Representative Lynn where, you know, this brain injury is real, I mean, it's touchy, but, you know, at some point in time, those resources need to be allocated to the people that it's going to help. And when you're on, you know, as incompassionate as this may sound, when you've been in therapy for 3 or 4 years, your option is long-term care. And, you know, we've been trying to watch that for several years to make sure that we're just not housing these folks and taking up resources from brain injury folks when these folks aren't going to improve. So, thank you, Madam Chair.
Okay, then another question I've got, and as we look at the ones that are, you know, we've got 6 of them that it took, did it take 6 months, or we're saying within 4 months, or did it take 4 months for them to start getting services?
So BI coding would be billing, right? So they had billed services within that time period. So if it says 6 participants had BI coding within or shortly after 4 months, it would mean that between the time they were identified as BI and the time that they got to 4 months, they had billing that showed up on the Medicaid billing utilization.
Okay. I just hate delays on the BI stuff. You can tell that, so. All right, committee, are there other questions? I think we'll keep this on here, huh? Senator Erickson.
Thank you, Madam Chair. Thank you. And just a real quick question. Are the network adequacy issues referenced in Q1, are those all resolved now?
I don't know that I could say that they're fully resolved, no.
Thank you, Madam Chair.
All right. We're going to keep this item on here. Number 13, is that right?
Yep.
I like it when Elizabeth shakes her head that I'm correct on this spreadsheet.
Okay, so number 13, this is about the waiting list PD, and number 14 is about the waiting list for IDD. So in both of these cases, as you're aware, last session, we worked to expand the number of wait list offers. So the PD waitlist active status is now at 1,061 per CAMUS at the end of July. And by 9/8/24, all of our additional offers for the mega round should be sent out. And then we have a meeting scheduled on 9/19 for reviewing the current PD waitlist for the next waitlist offer round. And we'll continue to offer those slots to people as they become available. And then for IDD, the same situation, but the active status is now 4,596 at the end of July. But we're on the same timetable as with the PD waiver.
All right, I believe we'll keep those two. Representative Carpenter.
So that is really good news. How did that happen?
So, yeah, we started a process where we did a sort of a test run with an initial batch of offers to make sure that the system was running smoothly. And then essentially every 2 weeks, we've been sending out new batches. So each people get an offer letter saying like, hey, you're available now for the waiver. And they have steps that they have to take. And then what we do is we'll go back and review everybody that got the initial offer, see whether or not they took action on that or not. And then if they didn't, we'll offer that slot to the next person on the list.
So basically, a lot of these folks, because of the 2-year wait list, had already dealt with it in some other fashion.
Well, I don't know for sure the numbers yet, but I suspect that we're going to see like there's going to be a significant percentage that'll probably be the case that by the time they get their offer letter, either the information that we have for them isn't accurate anymore, or maybe they're not eligible anymore. But we'll continue to offer those to the next people available on the slot.
Now you're starting to scare me. Because now you're saying there's only 1,000 people left on a wait list where there was 2,300. So, I mean, I'm not complaining if it's true, but that doesn't sound like it. It may be semantics, maybe more than actual people or actually being served.
Right, well, and it's a process where we've got a wait list, and so we're having to just start at the top and go through everybody and make sure that they've all had their opportunity to take the action that they need to be eligible for the waiver. And if that's something that either we're not able to reach them or they're not able to reach us, like we have to kind of move forward with offering that to the next person that's in line. So that's what we're currently doing, is going through that process.
Okay, so we really didn't serve 1,300 people.
I think it'd be a stretch to say that we served an extra 1,300 people last month.
That's what I'm getting at.
Yeah.
So we've just, by being 2 years from the time that they signed up for the PD waiver, then they've made other arrangements or moved, or who knows?
Well, we've extended offers to individuals, right? And we're waiting to get those responses back. Once we have all the responses back, then we'll know what those number breakdowns are. But I do think that we're going to see like a large number of people come off the list due to the size of the initial offering that we're putting forward.
Which was 500?
Yep.
Okay, thank you.
Yeah, I'm wondering, Representative Carpenter, if maybe there's a better way for us to ask for more specific data, because this does get complicated. And I can see where you've got different levels of moving parts. So maybe that's something we give some thought to, and between now and tomorrow, and see if we can't clarify a breakdown that we want for the October meeting.
Yeah.
Okay.
And so we do think that by 9/19, we'll have that review completed of the initial rounds of offerings to see how many slots that actually resulted in a match between a person and a slot. And so we should be able to report, I would say, like after October 1st, probably, about what those numbers look like.
Okay. So let's see what we can come up with by tomorrow, and if staff has ideas or suggestions, we're open to them, or any other committee members have it. Because I think we're missing a detail in there. I don't feel like you're trying to play a game with us, but the numbers are not.
Yeah, it's just a moving target. If
Right.
you start with this set, right, and then you send out offers, and you've got the difference between that set and the new set, and
Yeah, I just think we need to get a better visual of the moving parts.
Yep.
Yeah, okay. All right, so we're going to keep those two items on there and get modified. Representative Reese.
Thank you, Madam Chair. So Andy, when, I'm assuming a letter goes out.
Yep.
Right? So if a letter comes back, wrong address, what happens? Or if they send in whatever they have to send in after whatever deadline is in the letter, what happens? Do they go back on the list?
I'll have to come back and report on that, because I'm
Okay.
not sure exactly what the steps are. I know that there is, there is a process by which they have to follow that's kind of laid out. And we want to make sure that we're doing our best to do outreach to people. And so there's, I believe there's a couple of different points in that process where there could be a sort of a break, right, where that person doesn't end up in the slot that they were offered. But we're trying to monitor that very closely and make sure that we have an idea and a sense of where that's headed.
Thank you, Madam Chair.
Well, and I think that, the representative kind of hit it on the head, and then your comments is, we're trying to understand how it works and how this movement happens. So it gives us a better idea, so we don't sit there and say, well, Andy, we think your numbers are wrong. We would be able to say, oh, well, this is why it's off, or it looks odd, or something like that. So, okay. Any further questions? Excuse me, Senator Fagg.
Thank you, Madam Chairman. I was wondering on the PD or the IDD, people we are serving or people that's on the list, would COVID affected that in the last couple of years with any death loss?
Potentially, yes.
Do we know at what level that would be?
No.
We ever seen any numbers on that?
No.
Okay.
Questions? Seeing none, all right, we'll keep those two items, and then we'll figure out what language we want to add to that by tomorrow. Number 15.
Okay, so for number 15, this is about how's the workforce issue being studied. So for update this quarter, we've contracted with the University of Kansas Center for Research to help us with implementing a defined career ladder for direct support workers, or DSWs. So this team that we're working with, their key activities are going to include developing a career ladder, working on landscape analysis, doing a labor market analysis, and then a behavior economic survey, and then the creation of a marketing campaign, and then our long-term implementation and sustainability plan. So our timeline for that is about 16 months, which means that we'd be finished with that around November of '25.
Will there be periodic updates on that for us?
I think we could do
During
a
that
quarterly
16
update.
Quarterly?
Yeah.
So we'll keep it on the list and just look for quarterly updates on it until we see what the end result is. Representative Baumgartner.
Thank you, Madam Chair. Share with us, so you said you're contracting with the University of Kansas. So what are you paying them for those services?
I do not have the dollar amount with me today.
Okay. Is it going to take roughly a year and a half for that to get done because that's just all the faster they can get it done? Could it get done more quickly if it were done outside? And was there a bid process for that?
I don't have that information in front of me either. Sorry, Senator.
So I guess my follow-up is there a policy within our agencies that if we're going to do something such as this, that there be any bid process?
Yes.
So there was a bid process?
There's a procurement process, and I don't know if this was part of the RFP bid process or if it was a different procurement process. But we would have gone through the state administration procurement processes.
But you did indicate roughly 18 months for it to be completed?
Yeah, for the project to be completed.
So none of it will be implemented until the project's completed? Is that right?
Well, so they're going to, over that time, right, they're going to do all those steps of the analysis and the career ladder development. So they'll have deliverables during that timeline. But at the end product is really our long-term strategic implementation process.
And Madam Chair, that's what I thought you said as far as the implementation. So that really means it's not going to be implemented for perhaps 2 years.
Yeah, I mean, this is a career workforce investment process. So it's not something that happens in 6 months.
I appreciate it. It just seems like that is a pretty long runway to determine the career laddering and then to start the marketing process. That is a very long runway. Just speaking with regard to higher ed, that's a long runway. Thank you, Madam Chair.
Do you know, Andy, off the top of your head, how much that grant was?
I do not.
Could you get that for us, please?
Yep.
And then staff, when he comes back with that, if you will just add that grant, just go ahead and put that a grant amount in the third quarter information so we have that going forward. Okay, so we'll keep that item. So number 16.
All right, so number 16, this is what's the benefit to the individual to have case management services on the FE and PD waiver and the cost to add to it. So our update here is that we've been working with the MCOs since July to develop a community services coordination program. This community services coordination program will be part of the next round of KanCare contracts. And it'll assist in addressing the social determinants of health, as well as assisting members in accessing local resources that are non-Medicaid resources.
Committee questions, comments? And we probably have had this discussion before, and on the previous one, I didn't look at the date until now, and then I looked at the date on here, and these were all started October of '23. And now we're just getting to action, but it's not really beneficial action, it's just a planning process action. How do we improve this, Pat? What? Have I lost it, Senator? Senator Baumgardner, and then Representative Reese.
Thank you, Madam Chair. I appreciate you saying that. You haven't lost it. And a part of the reason that I'm just a little stunned by this is, I mean, part of what you're looking at with this career laddering, community colleges and the TEA as far as how technical ed funding is delivered, and those career tech programs are all built on laddering. That's what institutions do all the time. And when you look at part of what they're going to be doing, say you've got the University of Kansas essentially going to be looking at their own programs to figure out how they should ladder up for folks. That should be a part of, so let's be clear, what we know to be true in our universities throughout this state is, this year we're going to see some bump in enrollment, but we have had steady decline, boom, 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 over the last 10 years as far as enrollment. So to get paid to do what they should be doing to build up their programs, build up workforce, and then for it to take 2 years before the implementation, you're not wrong. It's just a little crazy to me, because this is something that should be able to be implemented at all the universities that have these types of programs. Now, we only have one KU Med Center, but we have allied health programs in all of our institutions. And figuring out how to ladder up from high school kids earning a CRN and moving up the process, that is all a part of why we have 19 community colleges in the state, why we have career tech enrollment programs for high school kids, so that every step of the way, in fact, that's the foundation of the Promise Scholarship, is that you can take a very entry level, take a couple courses and continue to ladder up. And gee, if you're good at it, you might transfer to a university to get a 4-year, and you might continue to get that advanced degree as well. So you're not wrong. It's just surprising that they should already have this information. And if KU doesn't already have this information, there should be another university in our state that has this information about career laddering. Thank you, Madam Chair.
Representative Reese.
Thank you, Madam Chair. Andy, on that number 16, the MCO is trying to develop a community services coordination program. Is this, are they evaluating their value-added benefits that they already have? Is that related to this?
So they could potentially use value-based purchasing to assist with this, but really what we're looking at is trying to create a level of community care coordination that happens in the community setting, so that if person who's on the waiver wants to have a community service coordination or is referred for community service care coordination to the MCO, they'd have somebody in their community that they could work with to access things like food pantries, clothing pantries, job services, those kinds of things.
All right, thank you.
Senator Erickson.
Thank you, Madam Chair. And just a quick question. As I look at the issue or concern for item 16, and then the quarter one response says, these are highly vulnerable people. So what is happening to these highly vulnerable people while we're working on it, working on a plan?
Well, I think one of the challenges that we have is that when we look at our communities, right, we can see these people, right, they're visible to us. And we know that they're slipping through cracks and are not getting the services that they need to remain stable in the community. And so really when we're trying to build these programs, like we have to create a system that allows for them to be identified and referred so that we can then like track and make sure that they're getting the services that we're trying to target to them. And so making sure that those components are in place system-wide across the state so that regardless of what community you're in around the state, you're able to access that care coordination through your MCO is a tricky proposition. And we've been working with the MCOs on identifying that. They've all proposed ways that they think that they might be able to do that in their contract bids. We've been working to try to create a system that all three MCOs can use so that there's a similar process for their members to go through in order to get access to those services. So it's the things that are happening now, right, are going to be situations where we are relying on what we have done historically while we're trying to address an issue and move that forward. So there's definitely still people that are going to be falling through a crack or suffering at the moment while we're trying to get that in place. But we do still have a lot of things that our communities have in place already that are still available to them. It's just a matter of that care coordination between the MCO and those community providers because our non-Medicaid services hasn't existed in the past in the same way.
I don't think we're happy with any of the answers that we're getting today. So do I understand, Andy, that none of this was a part of and maybe it's a KDHE question, I don't know, but I think you're both involved. Was this not part of the MCO bidding process? So this would have to be a modification after we put it into place?
No, it was in the RFP. I don't know how many times it was mentioned, but it was in the RFP pretty significantly around how we wanted to address social determinants of health and community care coordination.
So do we not know what that is today then, if this was part of our contract?
So right now we're in the readiness review stage, right? So we're reviewing the 3 contracts and the MCOs to make sure that they're ready for implementation in January. So we're not, right now in the award process, we're not at implementation yet.
So by October, can you provide us more details of this?
I can give you an update on it.
Well, I don't want just an update. I want to know what are the details, because if they're supposed to implement this come January 1, we should know today what this actually is, and I'm not seeing that here. There's no more negotiating time.
Yeah, I can come back and present something.
Because when's open enrollment?
It's in October, I think.
I'll take you off the hot seat. I have a question.
I'm not on a hot seat. I think Annie's on the hot seat right now. All right, give me a moment on here. Well, you need what Representative Reese was ahead of you, if that's all right.
Thank you, Andy, again. Thank you, Madam Chair. I think the one thing that I really appreciate is that I think you're trying to get some consistency among the 3 MCOs, and that is one of the things that I've heard from constituents over and over and over, there's no consistency. So I appreciate that that's what you're trying to attempt with this. So am I correct in
Yes.
that?
Yeah.
Okay, good, thank you.
Yeah, and the MCOs are working with us to do that too. Like
Okay.
it's a joint effort.
All right.
Representative Ballard.
Thank you, Madam Chair. I just want a clarification. Senator Montgomery, you brought up just an issue a few minutes ago about student enrollment. You said, I know they're working on it. I mean, so I'm not sure how this ties in with this. When you brought that up, that caught my attention because last year, KU student enrollment was up. And they anticipate this year it will be up. But I just wondered, how did enrollment get into 15 and 16?
Madam Chair, may I answer that?
Yes, Senator.
Okay, thank you. Well, what we're doing is we're looking at a career ladder that addresses all sides of the DSW career, entry, advancement, pathways to other careers. So one of the things that we know are happening is that while we're seeing enrollment increasing for freshmen, that stickiness or retention occurring for even with freshmen in some of our larger universities, second semester, but then look going from freshman to sophomore year, et cetera, that's where we see the drops. So there might be a kick up, but what we're not seeing is completion. So when graduation rates are hovering around 50% at a university, and social workers or other allied health programs require you to have, like the BSN, the bachelor's degree or advanced degrees, which we're looking for in a lot of our counseling and social work positions. This is all about enrollment. And universities are really focusing on themselves. What can we do to increase enrollment?
Right.
So attract a student, a new student, but then retain the student. So my point was simply, we know that historically enrollment has gone down, retention has gone down. So that's the job that all universities are to some extent and should be focusing on. How do we get them to our institution? How do we keep them? How do we train them for, and that's why I brought up the Promise Scholarship, because that's all about high demand, high need positions. Healthcare and service type programs and degrees were all a part of one of those strands of focus, as is industrial type things. So it just strikes me as so surprising that we're paying just one of our universities to look into this, because it's something that all of our universities should be looking at. It's something that, for those of us that are on the Child Welfare Oversight Committee, I mean, this is something that we've been talking about for a long time. We talked about federal scholarships that are available for social workers, and that DCF has not been a part of even applying for those types of federal scholarships that are available. So that's how, to me, it fits in, because if universities are doing their job, it means they're not only educating here and now, but they're looking and paying attention to those high need, high demand positions that, quite frankly, are also well paying. I can't remember the exact date. It's been more than a year, but the University of Kansas was also researching how to retain nurses, which is ironic also to me, because 2 years prior, I was asked to participate when the lobbyists for all of the universities in the state, they get together once a year and they have a meeting. And one of the things that they wanted me to do, this was 2 years ago, was to talk about what was then pretty new, the Promise Scholarship. And the question they asked, these are the lobbyists for the university, and it was actually the lobbyist from the University of Kansas that asked the question, do we really need more nurses? We have never not needed more nurses in the state of Kansas, in the Midwest, in the United States. So paying attention in your lane, if you are in the College of Engineering, the College of Education, the College of Nursing, whatever discipline area that might be at a university, or what department or division at a community college or technical college, it's your business to know what are the job demands, what are the training demands, and how do we make sure that what is needed out in the workplace, we are making available for Kansans. That was my point.
Well, and I think, Senator, that we can take this all the way back. I know we've gotten sidetracked with this, Andy, that's kind of what we do, is to our high schools, because we are currently paying for college courses. So the question becomes, are the counselors and guidance that students are supposed to get in high school not doing their jobs to help direct some of these kids, especially kids that maybe didn't know that they had a path to college? Because some of these kids are graduating high school with close to having their bachelor's degree, or they've got a 2-year degree under their belt, but did we guide them in the right direction because they didn't know they could go to college, their parents didn't go to college, their parents never thought they could afford college, but we're paying for it, and I think that we're losing it. So this whole ladder thing goes back. It starts in our high schools where we're already paying for college classes. Senator Baumgart.
I appreciate that comment, and I would only say it actually starts in middle school because the State Board of Education 9 years ago voted and approved that every middle schooler would complete an individual plan of study, IPS, and that's where they were to identify what are some of the classes that I enjoy. What do I think I'd like to be? And in fact, Commissioner Watson tells the story of a kid saying, I love animals, I want to be a veterinarian. And that in middle school allows them to look at, well, you're going to have to be pretty good at math because you're going to have to take all of those biology and chemistry courses, and you're going to have to be pretty good at some of these different courses. And then kids can start to gauge, are those the courses they're interested in taking? Is that, or what are some other ways in which I can, in this case, be around animals if I don't want to go to college, and that would be for 8 years. But the individual plan of study is a mandate of the Department of Education, the State Board of Education, and it gets back to, are they doing it in middle school, and does that IPS ever follow that kid once they start 9th grade and are supposed to be taking for free the pre-ACT test to let them know how they're doing. But we are finding that there's a drop in the number of students that are taking pre-ACT, and we're starting to see a drop in kids that are taking the ACT, again, their junior year for free. So we need to, that is where the ladder is. Middle school, high school, concurrent enrollment, move on. Thank you, Madam Chair.
What this has demonstrated for us, Andy, is that number 15 is a small snapshot of just the support workers. So those are the ones that are taking care of our HCBS services, correct?
Yep.
We're missing the big picture. And I think that had Representative Mason still been around, we would have had that committee that started looking at some of this workforce. But I think this just hits on it, that is there any way within what we're doing with this study here that that could be expanded out to where it's not just support workers? Because I think what we've heard here today, we have missed the full boat. All this here is colleges. Our high school's not even touched on this. No. But
Well,
yet, that's where the college is starting now, is in our high schools.
Yeah. Because the work's being done by a university doesn't mean that we're not looking across the entire, career ladder, right? So I do think that the work that KU is going to engage in includes looking at high school. I'm not sure about middle school, but I'm pretty sure it includes high school.
Well, and all I'm doing is I'm just reading here is,
But, yeah, I understand what you mean, that it's just the DSWs. It's not the entire workforce.
because it includes the School of Social Welfare, Lifespan Institute, Institute for Policy and Social Research, and KU Med Center, combined with the ongoing DSW training. So it's really limited. So my question is, is it too far along for us to add more detail and expand this out to where we're looking at all of this? Because otherwise, if we take and do a separate study, now we're going to duplicate things. That's what we're going to do.
I don't know that I know the answer to that question, Representative.
Can you find out between now and tomorrow?
Madam Chair.
Or KU's with it? Senator Baumgartner.
One of the components, labor market analysis, that could be done. I know an individual, her name is Dr. Sheila Maupin, happy to put her name out there. She could tell you exactly what the labor market analysis is for everything, from someone that just has earned a certificate, laddering all the way up to someone that has a doctorate in the areas that would be directly up the ladder and those that would be branching out on this. It's out there because universities have to report on the programs they have and the graduates they have, and the federal government runs this. It's available. You could get this from someone by tomorrow morning. That's how readily available market analysis information is.
Maybe you could make that request.
Well, I don't work at that college anymore, but I'm telling you that the folks out there have that information. It's out there.
Why don't we take and do this, because, I want to keep, I know we're already behind schedule on things, can you stick around after we're done? You got time to do that? And maybe, 2 or 3 of us can sit here and take this a little deeper and see if there isn't something that we can add or broaden and make this actually more beneficial to this whole workforce thing that we're dealing with in healthcare. Is that feasible?
Jump on that one.
I just gave a solution. We'll handle it after the meeting.
That's fine. Gotcha.
You want to talk now?
No.
Go
That's
ahead,
cool.
Representative Ballard.
That's cool.
Okay.
No, my only question was, I'm looking at the DSW, and I was just reading out, develop a career ladder that addresses all sides of DSW, career, the entry, advancement, pathways to other careers. That, I believe, involves high schools, because we're trying to think in terms of how do they get into the entry portion. But it isn't specific enough. It's not specific enough. I agree with that.
Maybe we can come up with a plan at the end of this meeting and have further discussion on it tomorrow. Okay, so we're going to keep number 15 and number 16. And Representative Carpenter?
Thank you, Madam Chair. I'm glad Renee poked me to wake me up during that conversation. So.
That's
Anyway,
what women do.
So Andy, back to topic. I'll save you here for a minute here. So tell me the difference on a community service coordinator versus what we're doing, a managed care coordinator type of deal.
Yeah.
I think there might be some confusion here.
Yeah, so just in a nutshell, right, the MCO care coordinator is responsible for coordinating the care benefits under the Medicaid program.
I don't see it.
Right? And a community service coordinator would be responsible for working with that care coordinator to make sure that the person in the community had access to non-Medicaid services that they needed for their social determinants of health in order to improve their health outcomes.
Yeah, perfect. This is a perfect segue into and we'll have a presentation by Unite Us here, either today or tomorrow, I'm not sure what, but they do all of that stuff. And from my conversations with them here in the last few days, there's been a lot of folks that are reluctant to deal with them and share information and get them on their websites and all that kind of stuff. So there are, that's a 3-year contract. So there are things out there to do this, but it's different than a care coordinator.
Right.
Okay, just making sure. Because, but isn't there improvements in the care coordination?
Yes.
In the new RFP too?
Yes, there are too. Yep.
Right.
Yeah, there's a lot of that we have been really trying to focus on to make sure that members have access to care coordination and that the MCOs are both accountable to the state, but also to the members to make sure that that care coordination is happening.
So the new RFP would be more like a targeted case manager than the old ones. Is that?
You could potentially have somebody who's on the waiver and is receiving both the MCO care coordination directly from the MCO, targeted case management from a TCM provider, and then also the community care coordination. Okay. So it's possible for them to get all 3 of those different services.
All right, very good. Thank you. Thank you, Madam Chair.
Okay, committee, we're on to number 17.
All right. So number 17, this is around investing in foster home recruitment and retention. KDAD's update on this is just that we wanted you to know that we've awarded 6 grants for children's crisis respite across the state for a total of $2.1 million, specifically for foster care respite or crisis respite. The KDAD's BHS Commission has also awarded a $1 million contract for aftercare services and a pilot to help curb any droppage in care coordination after a child leaves a PRTF placement.
Committee, are there questions or comments on this? You know, Andy, I think one of the things that, and I know that the state hasn't created any new ones, and I think we have just a handful left, but our facilities for some of these kids that are just hard to place in a home. They're runners, they're fire starters, they're acting out sexually, and they just don't fit in a home. Has there been any talk on the state level of creating facilities that we could give more of a structured setting for these kids? They're probably, you know, because then we'd open up some of our foster care homes then and not have kids still sleeping in offices of social workers across the state. Has there been any discussion of that?
Yes, I almost hesitate to say it, but.
Well, I know that it gets really, it gets sensitive.
It is
But you have to
sensitive,
stop and
but-
think, is it better for them to just bounce, which I think hurts them and does more damage on a mental capacity? It never gets them the services they need to control the behavior that got them there in the first place.
Yeah. So the legislature gave us a proviso about a year ago to work on a PRTF study for special cases, like you're describing. And we contracted that. We've completed that process. We're on the verge of having our final report, which I'm hopeful that we'll be able to present at the beginning of the legislative session in January. So again, it's another.
Nothing before that, huh?
Yeah, well, we do have a facility in Fort Scott that we started some work with, and we've added some agreements with Ember Hope as well. So there's some things that we're starting based on some of the information that we got early in the study, and as a result of the pilot project that we did with Ember Hope. But we're continuing to look at what we can do with that. And then we've been working with DCF as well on trying to identify ways that we can move forward with things.
You know, I think, Elizabeth, we need to add probably a line item in here to, you know, make sure that that report gets followed up to this committee here. And any update that you can provide between now and October, for the October meeting of, you know, where we've got, how far we've gotten on that, where we're headed, where we think that we'll be. excuse me, I think that that would be really helpful because, item 17, what the work that you've done here, this is great. That heads us in a very positive direction. It's sad it's just taken us that long to get there. But now we got to take that other step, and that is the hard one. And people just have to stop and think, the well-being of these kids, we're not going to make them productive adults if we don't take care of them while they're in the foster care system and help to get them to stop that bad behavior that's got them there in the first place. Because otherwise, they're just going to end up being Department of Corrections inmates, and that's what we have to stop. So you think we could maybe something by October?
Well, I was going to say, at a minimum, we've already got preliminary
Yeah.
findings that we can share in a
Okay.
presentation if we
I
don't
think
have the
that would be
final
helpful
report yet.
Yeah, okay. So you got that, Elizabeth? All right. So we'll keep 17. Was there any questions or comments, committee? I'm sorry. All right. And then are you going to handle 18?
Yeah, so for 18, our KDAD's comments on that is just that Unitas did respond to that community resource capacity Spark RFP that Representative Carpenter mentioned earlier. And that is administered by DCF, but KDAD's is participating as a state agency. And we'll continue to work with them to bring additional community behavioral health centers and other providers and community partners to the table to work with them and utilize that resource.
Questions, comments? Representative Carpenter? All right, we'll keep that item. So I think we want to monitor that as it progresses forward. Probably get an update on how well it's being implemented, the providers that are out there, watch that growth. And if that growth is not there, then why is it not there? Okay?
Yep.
You have more?
That's all I've got.
I'm showing KDAD's. Oh, those are closed. How long do we keep them on there after we've closed them? Huh? Okay, so then they will not show up in next year's spreadsheet. Okay, all right. All right, thank you very much, Andy, and I appreciate you. Okay, Tanya Keys, Deputy Secretary of Children and Families, Department of DCF. Welcome, and thank you for your patience, Tanya.
Good afternoon, committee. I'm Tanya Keys, Department for Children and Families. Well, I believe we have 2 items as updates for you all on the spreadsheet. I believe page 11, item number 3 and 4. And I'll start with number 3. There's a question about, can you let us know about the timeline for therapeutic family foster homes? And for those who are licensed family foster homes, there's no additional timeline really before you're able to be a therapeutic family foster home provider. So there's no additional time. The augmented or amplified training can begin when you have a child or youth placed with you, and that way you can also customize it to that child's needs. So just a little bit of background, as required for all licensed family foster homes, there's 37.5 hours of pre-service. And so then if they're interested and have had a conversation and wish to be also a therapeutic family foster home provider, they give us some information, perhaps, a resume that might talk about any development or training they've had, things that have prepared them. And so they provide that information, conversations happen. A child can be placed there, safety plans, well-being plans are put in place. So within 3 months of that placement of the child is when they would want 10 additional hours of specific training. And those trainings also would count, toward their first year total. So that's in the mix. Within the first year, they also need an additional, about 30. And with that, they can choose, pieces that might have to do with older youth, teens. It's called CORE training curriculum that they can take, and that's the Critical Ongoing Resource Family Education, or Trust-Based Relational Interviewing, TBRI. Sometimes folks have heard of it with its abbreviation, so that can happen. And then in the second year, the 24 hours is also required. We're working with an organization, Presley Ridge, who was awarded a grant by DCF to build capacity for therapeutic family foster homes in terms of having a statewide consistent curriculum, and also a curriculum that can help us think about how are we supporting relatives as well with any additional they needs in order to be at that therapeutic level of care. So that's the answer to that. There's no additional timeline, but there are some requirements and some opportunities for additional or amplified, augmented development of that family foster home if they wish.
Elizabeth, do we know where that one came from? I know it showed up in February. Okay. Okay. It might be a good idea for us to have on this spreadsheet, why did we put it on there? Where did it come from? Was it, did Representative Lamb request that? Because I'm sitting here looking and I'm drawing a total blank on this one where it came from. Because we cover so many different topics. And that doesn't mean you got to go back and do it. I think we should just start doing it going forward if that's okay. And sometimes even the person that requested it has to be reminded a little bit because a lot has happened. Okay, are there any questions for Tanya? All right, seeing none, that was great. Thank you very much.
Thank you. Number 4 was a status on the Unite Us contract. And so that, I think the committee knows, but just a little bit of refresher in terms of the Unite Us, they replied to an RFP that was issued with regard to Spark Community Resource Capacity Building. So with that response to the RFP, they were awarded $7.7 million for their referral service that they have. You guys can hear me okay? All right, sorry, you guys I thought maybe you couldn't hear me. Okay, so, and I think it was mentioned, Representative Carpenter mentioned, that's a 3-year grant. So it covers October 1 of 2023, started last year, and that's gonna go till September 30th of 2026. DCF administered that award process to a number of grantees in that RFP. The services are available to any state or community agency. We were just the agency that issued and administered the RFP and subsequent contract with that. So really the body of that contract, it covers the cost of annual user licenses for the service that they have in this product. So that's what the contract covers, plus some administration, plus some IT integration costs. But the bulk of it is really to cover the annual license fee. Right now they're in phase 1. And that they're building capacity among organizations and agencies that wish to use the product. So for example, the state agencies that are currently using licenses are Department of Commerce, Department of Corrections. My colleague Andy mentioned that KDADS is using it. KDHE and Kansas State Department of Education are also using this information and service. Other examples are community behavioral health centers, Kansas Pharmacy Association. There are 2 school districts, Turner USD 202, Lansing USD 469, and the K-State Rural Health Workers in 2 counties, Cherokee and Thomas. So those are users of their system that they have those user licenses to use their service. DCF, again, we administer this grant. We receive quarterly reports. So we're able to see the activity, and they're still in phase 1, building and making sure that those who wish to use the service get access to it and they understand the navigation of it and can start to use it. It's not required for use, but it's available. And the cost for this contract just makes it accessible by covering a number of user license fees so that folks interested out there can begin using it and get to know it.
Committee comments? Representative Carpenter.
Thank you, Madam Chair. Just very quickly, so is that what you just, those numbers and stuff, is that a part of a presentation in here? The numbers that you just quoted of folks that were involved, do you have something in here that says that?
We provided an answer in the spreadsheet, which I just read a little bit of. I might not have had the detail with regard to the school district numbers in it. Yes, I wasn't prepared today to do a full presentation, but so I apologize. I just provided the answer in the spreadsheet. Certainly, if the committee would wish for more detail, I'm sure that could be arranged, but I apologize. I only have the answer in the spreadsheet today.
Okay, well, I was just looking for it on the items.
Okay.
So they're not on there. Okay, well, if you could just email that, what you just said about school districts and all that out to the committee, that would be fine.
Okay, yes, I do see. I didn't type in the school districts in the spreadsheet, so I apologize.
Oh.
We'll get it corrected.
It's okay.
I'll stick to the spreadsheet cell script. Sorry.
Well, we could just have staff make that change and consider it an adjustment. That way you don't have to do a whole thing on it. And is there, Senator Baumgardner, I believe you had a comment.
Yes, thank you very much, Madam Chair. So you mentioned 2 school districts, Turner School District and Lansing, and then 2 counties, Cherokee and Thomas. So could you share with us, because as I recall, United Us is a tech company, is that right? Predominantly? I mean, they're not one of our service providers already in our state.
I don't know the scope of all their services. The contract we have with them for this product or a service as a product for the navigation and to connect individuals and communities, it is a technology tool.
Okay. So I'm just kind of curious. We're talking about $7.7 million over the course of 3 years. And in the first 3 quarters, of our 286 school districts, only 2 are using it. And with our 105 counties, only 2 counties are using it. And those don't crisscross. It's not the same counties as where the school districts are located. So what type of participation did you see, and what type of participation as far as closing that loop of implementation of referrals did you anticipate would occur?
In awarding the contract, GCF just wanted to make sure that the funds were out there for the number of licenses that the contract total was for. We wanted to make it available to those who were interested. It's not mandated or required. I don't know that we contemplated the depth at which, either at a county government or a school district level, that there might be interest or capacity within each school district. So I don't know that the expectation was there. I'm sure Unite Us has aspirations and a plan, and as I mentioned, they're in phase 1 of building that capacity so they can create those networks. I don't know that I have an answer to that in terms of an expectation of a percentage or number of municipal governments.
So when it went through the bid process, do you remember how many entities bid on this?
I can get that information for you. I know that with this Spark award, we awarded to 5 entities. And Unite Us was one of the 5 entities that received an award. And the awards were around the Spark concept of community resource capacity building.
So I haven't looked at it, but thank you for a copy of the agreement made. I guess you said the money is going toward the licenses. So Turner, Lansing, USDs, and Cherokee County and Thomas County have a license, is that right? Or are there multiple people in the school districts that have a license?
The user license would be for each user. So, for example, an entity could say, for example, DCF or a school district could say, I would like 25, or I would like 50, or I would like 1,200, depending on the size of your organization. Once your organization has information on the services and the navigation that it provides, they would be able to know within their organization, how many folks might have a use for this tool.
Okay, so, Madam Chair, I'm just trying to clarify. So every county hasn't received 10 licenses. It is that they have to go to this, United USA is out of New York, New York. So they have to go to United Us to make that request. I mean, I'm just curious, at this rate, if, let's say we only have 10 school districts and 10 counties that sign up, United Us still gets the 7.7 million?
They bill us based on the user licenses, and they are doing outreach as they're in phase one. They're making on-site visits. They're having virtual meetings. They're doing outreach. They respond to any requests they get. And I think also there's some connectivity across different populations or different interests. For example, work programs. Those that might be interested in collaboration around work programs, whether that's at a school district level or another community work opportunities agency. So I do think there's some networking of communication there.
Okay, so just out of curiosity, I know oftentimes with grant, whoever is operating the grant keeps 51%, and then the rest of the funding goes toward actual implementation. So can you or United Us tell us what portion of the 7.7 they're keeping and what portion is actually going toward the licenses?
Tanya, why don't we do this, because United's sitting out there. If you guys want to come up and speak for yourselves, instead of us just putting you on the spot, feel free to come up and answer the senator's questions.
Okay.
So you can just step aside. We might need you back, Tanya. You can't leave us.
Hi, everyone. My name is Natalie Daniel. I'm Policy Director with Unite Us. To answer some of the questions here, just to give a little overview, we are a technology company. We are a technology company that provides software to community-based organizations, your social service organizations, government agencies, as well as healthcare agencies. In Kansas, we won the RFP for this accelerator grant, and we are working with KDADS and DCF to be the administrators of this service. And what the service is, it is the software licenses that facilitate connection between the different organizations. So we do have some schools and some counties on. However, we have allocated through this grant over 600 licenses, so over 600 user licenses. That includes to the agencies that were mentioned, such as Commerce, Corrections, Department of Education, KDADS, DCF, and KDHE. So it's not just the schools and the counties, although we would love to have more schools and counties on. In this build phase for the next, it's been since October that the contract started, really November when we were able to start doing work. In this first year to 18 months, we are in this build phase where we are bringing on organizations, allocating licenses as we go, and bringing on government agencies with the goal of using our software technology to connect people through referrals. For example, if you have a single mother who enters her local food bank in need of food, and they have a Unite Us license that is allocated through this process, that food bank could assist her immediately, but also send referrals to WIC or to SNAP to get her enrolled. And then maybe at WIC and SNAP, they say, wouldn't it be great if we can't help you with this, but maybe you need better employment? We will send a referral through Unite Us to an employment organization within your community. And in this ecosystem and network, this individual is being able to get back to some self-sufficiency, get back on their feet. That is the goal of the program. It's to help people within their own community get to a place of self-sufficiency. In terms of the contract itself, yes, it's I think 7.7 is the kind of cap of the 3 years, but it is a consumption-based contract. So as licenses are allocated, that is what's billed to the state. So there's an implementation fee, there's some integration fees, but as we do the work, that's when the money is realized. So it's not the 7.7 million up front. It is as the work is occurring, the money will be paid to Unite Us to conduct those activities. We do have in-state staff who are helping people and helping organizations use the technology and implement it. And then we're also working with the state agencies directly. So we have people in the community working with the community organizations and then working with the state agencies to implement and use the software to better coordinate and communicate. And I think you were asking about what percentage do we keep versus how much is towards implementation. I don't know if I can, I believe the implementation was about 50 grand, and then the licenses, maintenance, everything else, that's about 82% of the total is what I'm seeing on the deputy secretary's numbers right here, which is to say that the implementation is a piece of that, but most of it goes to those licenses and maintenance, and that will be the part that is billed as we go. So only if the licenses are allocated will those dollars be realized.
I appreciate that. I'm looking at this and it says that, okay, so you said we just started in October, but that actually is 3 quarters. I mean, it's been 10 months. So when I look at that and it says actual expenditures so far have been $1.5 million. So we have 2 school districts and neither one of those are close to being our largest districts, and 2 counties.
Right, and we have multiple agencies and we have 606 licenses across the state that were allocated. It's not just those 2 school districts and those 2 counties.
So I think it would be helpful to get some sense, multiple agencies. We had a presentation earlier about this booklet that provides access to all of that information, the types of information. And so it would be helpful to know a little bit more than 2 school districts and 2 counties.
Sure. Absolutely. We can get you a comprehensive list of all of the programs and organizations that have received licenses.
Okay. 1.5 million is a lot of money.
Absolutely. Yes. And it's, we have community-based, certified community-based health centers on. We have Kansas Works, CanWorks to connect justice-involved individuals with reentry and employment. We have some veteran services on, I believe. We have a bunch of different programs on, so happy to provide that comprehensive list.
Thank you very much, Madam Chair.
Representative Carpenter and then Senator Fagg.
So I guess I'm responsible for starting this nightmare here at the last one. Yes. But I did Zoom with 4 or 5 Unite Us folks the other day, and I thought they were maybe on the agenda because they told me that they would have more information than I could ever want at this meeting. Maybe that's coming later on.
I think we supplied that information to DCF.
Okay.
Yeah.
And that's the breakdown.
Yeah, we give the
Whatever.
reports
So
to them.
I was kind of looking forward to that too, not.
Happy to do it at the next meeting. I'll give you a whole presentation.
Yeah, that would be great.
Great.
Okay, thank you. Thank you, Madam Chair.
Senator Fagg.
Thank you, Madam Chairman. You kind of talked about the cost of the license. Do they have an annual renewal on those things?
Yes.
And what's going to happen when 2026 comes up? Who's going to pay for that?
Yeah, that's a great question. That's definitely something that we're working on. It is a grant with the state right now. In other states where we do this work, it's often a blended funding model. So that's something we're exploring. The biggest thing right now is to work towards implementation and get people using it, because what we see in other states is if this is used and this coordination of services occurs, we save money. For example, in North Carolina, we saved $85 per member per month for Medicaid enrollees, which amounts to a lot. And when those costs and that savings is realized, then that can be proven out, and this can be either, maybe put into budgets or put into MCO spending. I think that's something that will need to be worked out with the agencies and with the representation in the state as we continue to build the program. But Kansas has identified this as part of that Spark initiative as something that can really start that coordination and hopefully start that assistance for individuals in need and help with that cost savings on reduced clinical costs, improving care coordination, reducing administrative burden.
Madam Chair, may I have a follow-up, please? So have you had any states that's backed out? How old an organization are you?
How large of an organization?
Yeah, how old? How long have you been existing?
We started in 2013. Have we had any states back out? None of states in my territory, which is a 17-state territory. That's something I could get back to you on in terms of if we've had any state contracts lag. As far as I know, no, but I don't want to give you a definitive.
Thank you.
Senator Erickson.
Thank you, Madam Chair. Thank you for being here. And I just have a quick question. So if I understand right, so the grant is for a 3-year period?
Yes.
And so after that 3-year period, what happens to the cost of the licenses?
Yes, so that's definitely something we're still working out. As I was saying, in many states, we have a blended funding model where it'll come private-public partnership, sometimes with some state budgets, sometimes with private entities such as health insurance plans or hospital associations or something contributing, because the product has demonstrated cost savings and improvements, and so there is support for it. Kansas has done the state of Kansas has done that upfront investment, and we're hoping we can work with the state and with the partners that we build through this process in the state to figure out a sustainable funding model, but that has not been figured out quite yet because we're still working on the build and implementation.
Thank you, Madam Chair. And if I may, just one other quick question. Sure. So earlier you mentioned that you'll take someone who taps into these services and then you'll put it out there for other services to be made available. So I guess my question is this a needs-based model based on the needs of the individual, or is this a service-based model? We're going to get as many people as we can into the service versus what their need is. Thank you.
That's a great question. And honestly, give me a second because I haven't heard it phrased quite that way. I believe it would be more of a needs-based model. So there isn't upfront eligibility to enter into the Unite Us network. Unite Kansas is what it's called, the Unite Kansas network. People can come in through what we call a no wrong door approach. So they could go through, maybe they're in the emergency room and that hospital's on the network and they really are in the emergency room because it is very, very hot out and they are, they're homeless. And so that emergency room, instead of housing them overnight, can refer them to a housing shelter. Or maybe they start at the housing shelter and the housing shelter realizes, hey, they talk to a staff member there and they need employment services and they're referred through there. We try to take a no wrong doors approach and the individual identifies their need. So that could be done through screening or through discussion. So if I'm the individual in need, I'm identifying and saying, this is what I need and this is what I consent for having help for. So everything is, we require informed consent. They know what they're consenting for. And then as things are identified and they are looking to continue on and receive more services, that happens almost organically as needs are being identified and that individual is interested in receiving more needs. So each program that's on the network probably has eligibility, that they are doing specifically, and that is integrated into the platform. But the network itself is there for anyone in need, and they're identifying the need.
So, Madam Chair, my only caution is I want people to have access to the resources they need. I'm hesitant to try to shop welfare to people who may not
absolutely.
need the services. So that's kind
Absolutely.
of my frame of reference. Thank you,
Yeah,
Madam Chair.
absolutely. And we definitely try to work with improving the community and empowering the community organizations.
Senator Baumgartner.
Thank you, Madam Chair. So help us out with your scenario. First of all, how many hospitals or medical centers are you partnered with?
I don't know that off the top of my head. I can get that number to you.
Okay, so let's suppose it's the hospital here in Topeka where we do have a homeless population. And we have had, plus 100-degree heat index for the last several weeks, for several days each week. So someone comes in to the local hospital here in Topeka, and they're there because they want relief from the heat. So if that hospital happens to be connected with Unite Us, how would they ever be able to find additional resources if they're homeless, which means they don't have a computer?
Sure.
So do they have to just keep going back to the hospital to find out what those resources are?
Ideally, no. Ideally, the individual isn't the one logging on at the hospital. It would be the care coordinator or the nurse or the whoever at the hospital is holding that Unite Us license who would be sending referrals on that individual's behalf. And then as that person goes to the different community organizations, those are the touch points. If that person doesn't have a cell phone or a way of contacting, often there is outreach organizations that can help with them, or if their last known address is at such and such shelter or such and such halfway house, that's where they would be contacted. So ideally, no, it would be to keep them out of having to go back to the hospital. This network would be in all of the organizations that they would be being referred to and being able to be assisted through that process.
So the hospital here in Topeka, how through Unite Us are they aware of the services that are available for homeless people?
Right. It's all loaded within the technology and the platform, and so they'd be able to, once again, with the individual's consent, search for the services. Essentially, they would type in housing, and a series of services would pop up. It would tell them these are the eligibility requirements for these services. This one is for women, this one is for men, this one is for this age group. They would then be able to send the referral through the technology to that service and coordinate how that individual will be contacted through the Unite Us platform. But it wouldn't be like doing a Google search or anything. It's all already built in a very intuitive, searchable way that would take a few minutes to find the correct services to service that individual.
But again, to clarify, you said so far Unite Us in Kansas has only administered, for lack of a better term, 600 licenses. Is that right?
That is through this contract, through the monies funded through this grant. We have, let me see.
So some of those are used by Turner School District, some by Lansing, some by Cherokee, some by Thomas.
Yeah, we have over 345 community-based network partners on right now, with over 500 unique programs across 70 counties, which includes housing programs, mental behavioral health, and the needs. So what we consider our service types, some of those service types that can be responded to through the network includes transportation, housing, food, mental behavioral health, family support. So we are covering over 70 counties with 345 community-based programs. And then what this Spark-funded contract really helped us with was bringing on more of the state agencies.
Thank you, Madam Chair. I just don't see how an individual would find whoever would have the license. That would be my concern. That's a lot of money. Thank you, Madam Chair.
Committee, are there first, Senator Fagg?
Thank you, Madam Chairman. On social determinants of health, does that include registering of people to vote?
I don't think that's one of our service types. I'd have to check, but I'm almost positive it's not one of our service types, no.
Okay, thank you.
Yep.
Committee, are there further questions on this item? All right, seeing none, thank you very much.
Sure. And I will follow up with the committee on a full list of the organizations that are available on the network.
That'll be good. Yeah, just get it to our staff and they'll get it out.
Absolutely. Thank you.
All right, and committee, I think where we're at on this here, I didn't say it earlier, but on the previous item, which was number 3, we're going to remove that one and we're going to keep this one. Yeah, I just didn't say it when it was presented, so. And I want to make sure it's on the records. Do you have anything else, Tanya, that's
No,
it?
I do not. Thank you.
All right, well, thank you very much. It's 3 on page 11. Yes, 3 on page 11 is remove. That was a DCF item. And then we're keeping item 4 on page 12. Next committee, we have Marissa Bayless with the Special Counsel to Chief Justice Marla Lukert. Welcome to committee, and thank you for your patience.
Thank you for having me. Good morning, afternoon, Madam Chair and members of the committee. My name is Marissa Bayless, and I'm the Special Counsel for Chief Justice Lukert. The judicial branch has had one item on your issue spreadsheet that we've been updating you on. Family treatment courts, or FTCs, are a new...
You know what page that's on?
I do not. 11.
Just a minute, we'll get there.
No.
All right.
Yep.
Everybody got it now? Yeah.
So I've been updating the Committee on Family Treatment Courts, our new model of specialty courts in Kansas. Our 3 pilot courts are on track to begin their implementation in September. Those are Cali, Miami, and Lyon counties where those courts will be operating. FTCs are a model that specifically center on families who find themselves in the child welfare system, primarily due to substance use disorders. So we're taking that collaborative, intensive approach that we know works in adult drug court and using that model, trying to focus on families and get them to their case plan goals. FTCs are a new model in Kansas, but they have been around nationally for some time. We're currently waiting on some grant applications to see if we've been accepted for specialty grant coordinators. In the interim, if we do not receive those duties will be taken over by district court staff as well as some OJA staff. We also held training at the Judicial Center in July for all of our operational teams. They were able to receive training from a national group that provides technical assistance for these teams across the country. So very excited to see these finally start coming online next month, but very grateful and thankful for the collaboration that we've had with all the agencies. We've really used this planning time well. I was also asked to give an update on our second mental health summit. So in April of 2022, Chief Justice Lukert convened a 3-branch collaborative mental health summit here in Topeka. We had excellent attendance both in person and online. But one of the goals for that summit was to be a catalyst for change and not just another conference. So we structured that conference very intentionally with, we asked all judicial districts, all 31, to bring a team, not just for their court system, but from their stakeholder group that works in that area, and to continue those meetings. But as a part of that, we thought it would be important to have a statewide group, and that was the multi-branch communities of practice group. And some of our legislators here have been on that and very thankful for that, but to keep that conversation going. So
our goal was to have a second summit. We have some tentative dates. Those would be August 26th and August 27th, so a year from now, in 2025 at Fort Hays State University. So while that is a little bit a ways away, it gives us some time for planning to gather some presenters and find some funding streams that we need potentially to get some national speakers going forward. But that community, multi-branch community of practice will continue that work. We hope to have official save the dates out in January for that.
All right. Committee questions, comments? All right, seeing Senator Fagg. All right.
Thank you, Madam Chairman. This is kind of getting off just a little bit, but I'll get right back on it. Drug courts. How many drug courts do we have in the state right now? Do you have that off the top of your
So I
head?
have my list. In total of all specialty courts for judicial courts, we have 29 plus these new 3 family treatment courts. Let me count real quick.
Okay, now my real question comes into, we have drug courts, we have this family treatment courts. Is there any concern that we're short of employees now, being able to service all these kind of things? Because I like the concept, but I've been around where budgeting was an issue on these drug courts.
Yeah.
And this is another layer to that.
Yeah, so to answer your first question, as of right now for judicial districts, we have 15 adult drug courts. And just to note, some of the municipal courts also operate their own drug courts, so there's additional ones there. The staffing thing is a real thing. I will note that the counties, Miami, Lyon, and Cowley, 2 of those have been operating an adult drug court for quite some time, so they kind of have their model down really well, and have some chief judges that are really passionate about this and really asked to be the pilot program. But that is always in mind, that we don't want to overburden our staff too much. That's been a reason why some courts do not open or choose not to go. So there's no requirement for them to have a specialty court. If they can make it happen, that's great, but we always try to keep that in mind. One of the courts that is opening an adult drug court soon or is in the planning phase is the 11th Judicial District, which is Cherokee, Crawford, and Labette. For some years, they've wanted to, but they didn't have the resources to do that. But again, like you said, it is a conversation that you have with us at OJA, trying to find federal grants, or with their counties especially. It's always a question, though. It's always going to be a question, so.
Further questions? All right, seeing none, I think what we'll do is we'll go ahead and keep that item on there just to kind of monitor how it takes and progresses. And I'll put my plug in that I do all the time, as I still would like to see the judicial branch at some point to look at mental health services in family court. Because the individuals that get hurt in that are the little people.
Yeah.
So, thank you. All right, that's it. I like it when we finish that spreadsheet. So it looks like we may have removed a few so we could add the ones that we had this morning on there. Okay. Oh, we've got Andy Brown back again for the overview of the State of Mental Health in America report. Welcome back, Andy. This is an exciting report.
Yeah, hopefully. We'll see how it goes.
We're going to end on. What do you mean, hopefully? Come on.
Hopefully.
Come on.
So, Andy Brown with KDADS. Again, this is just a quick overview of the Mental Health America rankings, state rankings report that comes out on an annual basis. And we wanted to provide an update since there was a lot of conversation last session about where we ranked. So at slide 2, here, the first thing I just want to point out is that this is a little background on the report and the organization. So Mental Health America is a national nonprofit that's dedicated to mental health advocacy. We have 2 chapters here in Kansas. They conduct this annual state rankings report. And that link will take you to their website where you can download the report directly, but I think we also provided a copy in your documents. The public health emergency impact on this report from COVID is copied here verbatim from what they published. But I did want you just to know that the pandemic did have a serious impact on the ability to collect national surveillance data in 2020. So as a result, SAMHSA has determined that 2021 will represent a trend break from previous years, meaning that we're no longer comparing apples to apples, essentially. All right, so the purpose of the report is really for us to be able to assess mental health status across states, look at strengths that states have and areas for improvement, highlight access to mental health services and the prevalence of mental health conditions. And MHA believes that gathering and providing up-to-date data and information about disparities faced by individuals with mental health problems is a tool for change. The citation for the report itself is there if you want to cite this anywhere later. They gather this information specifically in order to allow them to measure a community's mental health needs, their access to care and outcomes, regardless of the differences between states and their varied mental health policies, because, as you know, we're all different. Rankings explore which states are more effective at addressing issues related to mental health and substance use, and analysis may reveal similarities and differences among states, allowing for assessment of how federal and state mental health policies result in more or less access to care. So for our overview on page 6, Kansas this year was ranked 22 overall among states. We were ranked highest overall in our SAMHSA Region 7, which includes Iowa, Nebraska, and Missouri. We also ranked higher overall than our neighboring states of Colorado and Oklahoma. Kansas ranked 24th in adult rankings among states and 16th amongst youth rankings among states. So that's quite a bit of good news for us in terms of where we're at on a national ranking. And that's, I think, reflective of the amount of work and progress that was made in previous legislative sessions on mental health issues and enacting things from the Mental Health Task Force report. Our key national findings, 23% of adults experienced a mental health illness in the past year, 5% of adults and 13% of youth reported serious thoughts of suicide. 2022 had the highest number of deaths by suicide ever recorded in the US. 18% of adults had a substance use disorder over the past year. 10% of adults and 8.5% of youth have private coverage that does not cover mental health, which speaks to issues around insurance parity. And there are 340 people for every one mental health provider in the US, which speaks to the provider shortage. When you look at our Kansas versus the national average in the report, MHA uses a score of 0 to mark the national average score. That's similar to par on a golf course. It's also known as the Z-score. None of the 15 measures or indicators are weighted, so everything counts equally. Additionally, Kansas was just over 0 or was almost at the national average. Areas where Kansas fails or performs below the national average, Kansas was well below average regarding the prevalence of uninsured adults with any mental illness. We ranked 42nd, and I'll talk more about that later. And Kansas was also well below the national average for youth with untreated major depressive episodes. We ranked 44th. So on page 8, this talks about the prevalence of mental health conditions. So here in Kansas, we ranked 27th, both for adults and youth, for those that are experiencing any mental illness or a major depressive episode for youth. Comparison to the national prevalence rates, adults, we were 24.41% versus 23.8 for the national rate. And for youth, we were at 20.34 versus 20.17 for the national rate. And one of the things that I think has to be taken into context when you're looking at the report numbers is just that nationally, rates of any mental illness among adults were higher in completely rural counties, 25.7 versus 22.10 in urban counties. And as you know, in Kansas, we're a mostly rural state. So on page 9, in comparison with the national policies and programs, Kansas remains a state where Medicaid expansion under the Affordable Care Act has not been enacted. We're among 9 of the 10 states which have not expanded Medicaid, and also which ranked low among states for the percentage of adults with any mental illness that do not have insurance coverage. So Kansas was 42nd. This coverage gap for adults means that Kansans may not be able to maintain routine care and recovery or seek emergency acute or crisis services with greater frequency. So our statewide CCBHC safety net and the initiatives that we took both in the legislature and at the agency to build that out over the last couple of years helps cover those uninsured individuals in this coverage gap, but the impact of that program is not reflected in this indicator. And on page 10, this is what Kansas is doing well. So we're doing well in a lot of areas, and we're investing in our state funding for programs that leverage our Medicaid dollars for prevention. We're intervening in crisis situations. We're increasing access to routine care and acute care, promoting individual recovery, and we're working to create thriving communities. Our challenges in the areas that we still need improvement on are basically around supportive housing and supported employment for improving community-based care and behavioral health outcomes for Kansas that are living with a disability. Projects like Community Support Waiver and the Community Care Coordination will help connect KanCare members to resources that address social determinants of health and promote connectedness and community integration. Recommendations from the report are really to look at increasing our family resilience and connections that suggest state investment in early intervention from 0 to 5, and supports for parents and families can result in greater flourishing for Kansas youth, as well as better behavioral health outcomes for youth when they become adults. Also, our upstream substance use prevention strategies could focus on identified reasons for youth substance use by better addressing the underlying stressors that they face, helping families improve sleep habits and hygiene, and promoting mental wellness and healthy coping skills. A couple of strategies that were identified in Kansas: rural families are more likely to experience poverty, face food insecurity, and have less access to preventative services and providers than those in non-rural areas. A focus on improving our social determinants of health in rural and frontier counties would result in improved behavioral health outcomes for the state. Also, Kansas could work to address its workforce shortage in behavioral health to improve mental health outcomes related to access to care and quality of care. So in conclusion, Kansas has done well in many areas in this report, particularly as related to youth. A ranking of 22 overall shows that there is both significant progress and continued opportunity for better outcomes for KanCare members. This report uses some federal data that does not collect or report on unsheltered homeless or incarcerated Kansans. So it's important to remember that both those populations have a higher prevalence of behavioral health disorders, and they are largely untreated and uninsured. Potentially one of the greatest behavioral health challenges that we face in Kansas is how to improve our indicators in our rural and frontier counties. And I'll stand for any questions.
That is good news. Thank you. Committee, are there questions, comments? Representative Carpenter.
Thanks, Andy. Just a quick one. So why aren't our CCBHCs counted in that?
Well, because it measures insurance coverage. So that if you're uninsured and you're going to a CCBHC to get your services, you're still considered uncovered. So when they look at what the prevalence of people that are uninsured are, it doesn't capture that safety net service that we provide.
That seems a little strange. I mean, you're getting the service. Who cares if you have insurance or not, quite frankly? I mean, I understand they want us to expand Medicaid and do all these other things, but the bottom line is the folks are getting the services.
Yeah, and that's why I wanted to point it out.
Thank you for that.
Yep.
Representative Ballard.
Thank you, Madam Chair. Is that a federal regulation?
The CCBHC program?
I mean, that we can't, that they are not considered receiving services? You said that.
They're not considered to be insured.
Yeah.
Yeah.
So just.
They don't have health coverage.
Interesting. It's really good because does this cover at all the suicidal rate of teens going down?
So, nationally, rates have continued to rise, and I don't think that's going to be necessarily different here in Kansas yet either. But we'll get those numbers a little later, I believe, once they've been through KDHE. But I do think that what they take into effect here, and when they're looking at this, is really those major depressive episodes, and whether or not youth are getting access to treatment, and if after treatment they're reporting improvements in their outcomes.
Does this also reflect our residential, I'm drawing a blank on it, but residential homes for youth?
The PRTFs?
Yes.
So this is a very broad study. A lot of the data comes from surveys of members. And so I don't know that there's a specific PRTF question that is addressed there. But what they're looking at when they say untreated major depressive episode, right, that's really, you could look at that as being, you know, what's the impact of kids that are on our wait lists, right?
Great, thank you. Good job, Andy.
Representative Erickson.
Thank you, Madam Chair. Thank you, Andy. Just a quick question to follow up on Representative Carpenter. Have you done any kind of data analysis as to what the effect on our rankings would be if the services provided by CCBHCs were included?
Well, I not personally, no. I think the way the survey questions that is really just, do you have coverage, right? Whether that's Medicaid coverage or if it's private insurance or a different, like a CHIP program or something like that. And so the question itself doesn't address the fact that we have a safety net program here in Kansas. I think our overall rankings would be higher if that was reflected in the study.
Yeah, of course they would be, and I would just be interested because I think that would be a better picture of the level of services that we're providing in the state versus whether they have coverage or not. Thank you, Madam Chair.
Committee, further questions or comments? Representative Reese.
Yeah, we have safety net clinics. So we do have the CCBHCs, but we also have the FQs. And both entities, and prior to the, when there was still community mental health centers, they were losing millions in unreimbursed services. And the FQs continue to have that. So I like having data that shows whether you have insurance or not, and if your insurance covers mental health, because you already pointed out that there are some that don't cover mental health services. So the state knowing that's an important factor in keeping that data intact, versus if you have a in need of mental health services, how good are the services, or how prevalent is the services in the state, and how easy it is for you to access. I think those are two different bases, and I think that's why Mental Health America looks at the data the way they look at it.
Yeah, and they did. They looked at that 9 out of 10 expansion states thing comes right out of their report. And I do think, that everybody knows that the Kelly administration strongly supports Medicaid expansion here in Kansas. Yeah.
So do a lot of other people.
Yep.
No wonder you.
All right, I just couldn't resist.
Well, no wonder you don't vote for it. You didn't know about it.
Oh, baby, yeah. Payback is a problem. Representative Peck.
That's good.
No? Oh, I'm sorry. Senator Peck.
Thank you, Madam Chairman. I realize 12 years, sometimes it's hard to. I realize that mental health is a real issue, and I'm not an expert, but in my experience, I believe too many times we have used that as a crutch, an excuse for people if they have a little bit of anxiety, a little bit of depression, which we all have occasionally. My question is, you mentioned 24.41% of adults experiencing, and you used the word any, A-N-Y, any mental health. So how do we determine any mental health? Do they have to receive treatment? In my line of work, I meet people that are on medications that I am confident they probably don't need for anxiety, depression, et cetera. So how do we determine any? Because I fear that we're allowing mental health to be an excuse for some other issues that people have.
Yeah, and so there's definitions that are used by SAMHSA. And this report, the Mental Health America report, they pull a lot of their data from the reports that we submit to SAMHSA on those definitions. And the any mental illness is a lot higher in terms of a percentage than if we use severe mental illness. So severe mental illness are going to be the things that typically would qualify somebody to probably look at applying for a disability or looking at things like hospitalizations and significant community-based treatment programs. It's kind of our threshold for a lot of the services that we do through our system publicly. Any mental illness is really any diagnosis that's in the DSM, which is the diagnosis manual for mental health. And so there's, generalized anxiety and things like that would be included on that list.
Okay, thank you, Madam Chairman.
Committee, further questions or comments? Representative Ballard, you're on already.
Oh, thank you. When you were talking about DSM and the diagnosis and all of that, when I was a doctoral student, and I don't think it's changed since then, mental health is woefully underreported. So therefore, you have a larger population of people that have never sought help, men especially in that category. And so therefore, we have a whole population of people that need treatment but have never sought it, never probably thought about it, that they can just fix it, whatever it is, on their own, or may not even be aware that it is something that could help. So I would say for any that may be using it, and that's one of the reasons why we monitor their medicines and their pharmaceutical things as well. But it's that larger population that is not receiving any kind of treatment for their mental health is where we have a real big problem. Am I correct?
Yeah, I think the general findings in the report, if we wanted to lower our rankings from 22 to like the top 10, right? Like we would need to find a way of looking at that issue of who's out there right now that's untreated, that would be eligible for treatment, and figuring out how to get them access to services.
Thank you.
Committee, further questions or comments? Representative Reese.
I have more of a comment. Just so it's really addressing a little bit of what Senator Peck was just talking about, that when someone has a severe and persistent mental illness, it affects their work, it affects their ability to form relationships, maintain relationships, it affects their ability to learn, like being able to take college courses maybe. It affects their ability to attend to their daily living activities like getting up, taking a shower, combing your hair, washing your, any of those kinds of things. And it affects all those areas, and that would then be used or can justify that level of severity of a mental illness is disabling. So when you look at somebody getting disability, those are some of the areas that they look at. And I just feel like I have to say this as a clinical social worker, that anyone having any level of mental illness is never a crutch or an excuse. Thank you, Madam Chair.
Committee, further comments, questions? All right. Seeing none, I think, we've made a lot of headway, and I hope we continue down that path. So thank you very much.
Yeah, I'm looking forward to future reports.
Thank you. Did I see Scott come back in? You don't have to get up, Scott. Earlier, I meant to ask you on the state health bonus, hospital bonuses. I assume that will apply to our new facility in Wichita, correct, or not? Well, yeah, okay, I'm sorry. I should have
Caught me
just
off
come out and
guard,
asked
so I
you-
didn't want to
asked you
misstep.
personally, but I'm just curious.
So the bonus authority that we have is just for this fiscal year. It's by proviso. So the
Oh,
new
okay.
building won't be open yet, but part of it is proof of concept. And if it's something that works and we can show evidence of it, we'll request either continued authority or changing the statute.
Okay,
And then it would
I
have
didn't
bumped up.
catch the proviso part, so that,
Yep.
yeah, that would have answered my question. All right, thank you. Okay, last but not least, and he's been very patient, a lot of patience.
Thank you. I appreciate the opportunity to talk. I had to change my notes from good morning to afternoon because of this, because this is unusual for me. But Chair Landwehr, members of the committee, thank you. I am Steve Anderson, Medicaid Inspector General. Appreciate the opportunity to be here and talk about the Medicaid Inspector General's office. Just want to bring you up to date on a few things. We are currently updating our web page along with the rest of the Attorney General's office. OMIG will have its own page, finally, with a link to an online contact form that can be used to make a report of suspected fraud, waste, and abuse, or illegal acts. The web page will also have a link where you can request a presentation or you can receive fraud, waste, and abuse training. We're happy to do that. We've been working with KDHE quite a bit, providing a lot of training on that topic. Just want to bring you up to speed on complaints. As you know, the number of complaints of fraud, waste, and abuse continue to go up every year involving the Medicaid program. The majority of those involve beneficiary eligibility fraud. In calendar year 2023, we processed 1,447 complaints, with 1,377 of those involving beneficiary eligibility fraud. There were 38 complaints that, after reviewing the matter, did not involve Medicaid, and we referred them to the correct agency. There was one complaint involving a state agency and 2 that involved state employees. There were also 14 allegations of beneficiaries committing non-eligibility fraud, such as identity theft. The remaining 53 complaints involved allegations involving providers or contractors. And just, we are on pace right now to basically handle an estimated 1,525 complaints this calendar year. So every year it just continues to go up. There's a chart in the handout that you have. I do want to also comment that OMIG was finally able to start conducting investigations of eligibility and provider fraud last August with the addition of 2 special agents. Prior to that, we did not have that ability to conduct that, even though our statute directs us to conduct investigations. So in this past year, since having agents, we've opened 129 investigations, with 102 involving eligibility, 11 involving other types of beneficiary fraud, 14 involving provider fraud, and 2 involving state employees. We've referred 6 of those cases for criminal prosecution, with several others being finalized and prepared for referral for prosecution. We've also closed 30 investigations. The reason for closure on 14 of those cases was the allegation was disproven. I consider that to be a successful investigation. Anytime you disprove an allegation, if you've been wrongly accused and the investigative body can disprove it, that's a win for them. So always consider those to be positive outcomes on investigation. 7 were closed due to insufficient evidence. We just couldn't make the case. 4 were closed due to agency error, and that's because KDHE made a mistake. The allegation was, when we looked at it, we saw that the individual hadn't actually committed fraud. It was a mistake on the part of the eligibility staff, but we were able to get that corrected. So those were agency error. 3 were submitted for administrative action, and 2 were referred to a regulatory agency, which was Social Security Administration. As a result of the work of our investigations, beneficiaries that were not eligible for Medicaid have been removed from the program. This stopped capitation payments going to the MCOs, resulting in a savings of $150,941 based on 1 year of program payments. We anticipate that additional savings, restitution, recoveries will come as a result of cases that are prosecuted. I want to go on to say that OMIG has 9 staff members, including myself, to conduct all the investigations, reviews, and audits of this very important program we know as Medicaid, right? It's over a $5 billion program, serves over 400,000 people. We could easily open an additional 200 investigations per year, but simply cannot do the lack of resources. With 2 staff, it just can't, you can't do it. We have also identified numerous other areas that could be audited, which result in significant savings, recoveries, waste identified, and improve the effectiveness and efficiency of the program. I plan to ask for additional funding for staffing in the upcoming legislative session and would appreciate the support of this committee in that endeavor. We're also in the process of completing 2 performance audits. The first one involves the process for Kansas for Medicaid recipients involving prior approvals for receiving services while somebody's in a hospital. The second one involves audit of Medicaid reimbursements for schools. When you guys were talking about schools earlier, that really piqued my interest because of the issue of payments. State of Kansas pays over $25 million a year in direct payments to schools for providing services such as counseling and other services to students that are paid through fee-for-service and not through the MCO process. And I just want to give you an example of an investigation that we recently opened. It involves a Medicaid beneficiary that moved from Texas to a town in Oklahoma near the Kansas border with her 3 children. She never lived in Kansas. A lot of these people move from Kansas to other states and they keep their benefits, but this person came from Texas straight to Oklahoma. She never lived there, but she does have a sibling in Kansas, and she used the sibling's address on her application for KanCare, but resides in Oklahoma with her father. She's been on KanCare since October of 2023. She has an Oklahoma driver's license using her father's address that was renewed in July of 2024, which goes further to the fact that she lives there. Over $12,000 in capitation payments have been made on the beneficiary's behalf while she resides in Oklahoma. Our investigations continue to be submitted for prosecution if appropriate. I appreciate your time. I know we're at the end of the day. I'm happy to answer any questions you may have about any topic involving Medicaid or anything else.
Committee, are there questions for the Inspector General? Representative Reese.
Thank you, Madam Chair. With the example you just used, how is she using her KanCare while she's living in Oklahoma?
It's right on the border. It's not unusual for people to use their KanCare benefits in Oklahoma, and she lives only 15 miles away from the Kansas border, so she's actually been coming into Kansas and seeing doctors in Kansas.
Okay. Where her children, she has children?
She has 3 children.
And the kids are also seeing physicians?
Yes, ma'am.
In Kansas?
Yes.
Okay. All right, thank you.
Yeah, Representative Ballard.
Okay. What are we hoping to get the money back? I mean, if she went that far, you're not going to see any money.
No, I agree with you, Representative Ballard. It's not about getting the money back. It's just stopping the bleeding and getting her cut off of Kansas Medicaid and getting her moved over to Oklahoma. One of the things we have found, and we find this with a lot, Kansas benefits seem to be a little better than Oklahoma benefits and a little better than Missouri benefits. So we have people that, once they get on KanCare, they really like it. They have a tendency to stay on it. Also, we've heard from more than one person that Oklahoma's a little more difficult to get on their program. They have more checks and balances per se. So it's actually easier to get on KanCare. So we have a good product, people want it, but unfortunately they need to be eligible for it.
And I think some of that might be is when you're living on the border is you may be in a rural area, probably in the Oklahoma side, and you're hitting closer to urban on the Kansas.
That's exactly right. The nearest Oklahoma city of any consequence is further away than the nearest Kansas town of some consequence.
Yeah. Senator Fagg.
Thank you, Madam Chairman. They probably have 2 mailboxes. What? No.
POs.
I was just, when you think 2,900,000 population, 467,000 Medicaid, I don't know how many we have in Medicare. You add those together and you talk $5 billion. You know, those are big numbers. I was wondering, does the office do any comparison with other states in Medicaid fraud? Is there any way to say our system's, functioning normally, or do we have any things that we could shore up on our part? I just wondered if you have any way to compare any of that kind of stuff.
I appreciate the question, Senator Fagg. It's a good thought. We haven't really looked. We do look at other Medicaid IGs. For example, Tennessee has a rather robust IG program, and we do look at how they conduct business, what they're doing. But as far as conducting the amount of fraud per capita, we have not done anything like that.
Senator Erickson.
Thank you, Madam Chair. Thank you, Steve. Appreciate it. Just a quick question. I apologize if you covered this. Have you done any cost-benefit analysis or return on investment for OMIG? And if so, adding additional staff, I would think is an investment rather than expenditure. But do you have any numbers or data to support that?
I don't have the exact numbers in front of me. I appreciate the question. We have provided data in the past. Our office has returned, have identified like overpayments and potential savings and things like that, pushing $300 million. My operating budget coming into the next fiscal year is just over $1 million. And in years past, it was less than $1 million, and we've been returning or identifying fraud, waste, and abuse, several million. I mean, the return on investment's enormous when you look at what it costs to run my office and what we're asking for. And that's why the request to ask for additional staff is, Senator Thompson brought it up in committee last year as he said, let me get this straight. I give you $1 million, you give me $30 million. And I said, well, that's kind of how it works out on the ratio, sir. And so, yeah, that would be, it's a good investment, I guess. Even with the investigations, I mean, we stopped over $150,000 in capitation payments going out. Like I said, we're not trying to collect money back from people because a lot of times these people have, but they shouldn't be on the program. They don't live in Kansas anymore. And that's $150,000 that we're just simply not going to spend in capitation payments. That's a real savings every time. Social Security Administration, when they do these kind of cost benefit things, they look at a 5-year stretch. We don't do that. We just look at 1 year trying to keep it reasonable. But that's how when you hear Social Security Administration talk about how much money they're saving, they calculate on a 5-year basis.
Committee, further questions or comments? All right, seeing none, thank you very much. Appreciate you
Grateful
being
for the
here.
opportunity. Thank you.
Okay, committee, we're going to ask for approval of the Q2 minutes because there is a correction needed. And do you have that correction that you can tell us about?
Thank you, Madam Chair. Ida Orr with the Kansas Legislative Research Department. In the minutes, there was a discussion regarding Secretary Proffitt's the description of the procurement protest process. I'll get that out. And we reference in that the Office of Procurement and Contracts implements the process as stipulated in law, and that is incorrect. That process is not in statute. It is actually in the Office of Procurement and Contracts Procurement Policies and Procedure Manual, which is what Secretary Proffitt had stated in his testimony. And so we would like to have that corrected. That was an oversight on our part when we did the editing of the minutes.
Is there a motion? Senator Erickson.
Thank you, Madam Chair. I move that we approve the Q2 minutes as amended.
Seconded by Representative Ballard. Questions, comments? All those in favor signify by saying aye.
Aye.
Opposed, noes. The ayes appear to have it. The ayes do have it. Motion carries. Okay, committee, we will have lunch provided tomorrow, so we'll have a working lunch in our program. And, hopefully we'll be able to stay on time, but I can't predict everything on this. So we're adjourned until tomorrow at 9 a.m.